Welcome, everyone, wherever you're tuning in from around the planet to World Health Day 2021, brought to you by Global Minnesota in partnership with the World Health Organizations and dozens of other groups around the planet. Today is a special day, and I'll be reviewing it briefly, but first we'll hear from our wonderful Minnesota's Lieutenant Governor. I want to say a word, however, about our community. Global Minnesota, although this year we are virtual in almost all respects, we are on the campus of the University of Minnesota here in the Twin Cities. And as a university community, we acknowledge that our university, the Twin Cities, is built within the traditional homelands of the Dakota people. It's important for us to acknowledge the people whose land we live, we learn, we work, and that we work to seek to improve our relations with our tribal nation, our neighbors, our friends, our community. And so today we want to bear that in mind as we're thinking about our theme. I'll be talking about that in a moment, accelerating health equity by design. But please welcome our national leader in equity, a lifelong advocate for health equity in particular, Lieutenant Governor Peggy Flanagan of the state of Minnesota.
Bonjour, Lieutenant Governor Peggy Flanagan here. Welcome to Global Minnesota's World Health Day Symposium. The COVID-19 pandemic made it crystal clear. When it comes to personal and public health, we must work together to protect our communities and address inequities. We've made progress, but there's still work ahead of us. Today's symposium will feature successful design-based approaches to eliminating inequities and injustices in our healthcare systems. Some of the focus will be on new approaches to how we educate our health professionals, including doctors, nurses, and other clinicians. And speakers today will explore design features to ensure that new healthcare-related technologies help reduce and eliminate inequities and injustices. We'll also hear from young leaders who are mobilizing the next generation and bringing a passion for justice, equality, accessibility, and sustainability to create a bright future for all. Minnesota is a global leader in health and wellness, and we're striving to ensure that everyone across the state has access to affordable health care. I'm grateful for all who've made this day possible, and I'm thankful to all of you who've tuned in for this important event. Chimigwech, thank you.
Thank you, Lieutenant Governor Flanagan. And today's program is a team effort. It's bigger than a village to make something like this possible. And I want to make a special opportunity. I want to make a special thank you this moment to our ASL, our interpreters for American Sign Language. You will be meeting them throughout the day, but thank you to our interpreters, to the team at the electronic digital assistants that we're having. Carolina Gustafson, who's our manager, and Tim Odegaard, who directs programs. Lots of other people will be involved. But we couldn't do this and make it free on a global basis to people from around the planet who are watching without support, financial support from our members and from our local business community and nonprofit community here in the Twin Cities and beyond. We've had sponsorship at the platinum level from King Solutions, at the gold level for Communicating for Agriculture Foundation, and at the silver level from Sunrise Banks. We also enjoy support from our global platinum members. These are the organizations who support us throughout the year, Carlson Family Foundation and Delta Airlines, and our premier members, Cargill, GHR Foundation, and UnitedHealth Group. Those of you that are members, you know that your support has made it possible for us to grow and prosper over the last 70 years, connecting Minnesotans to the world and the world to Minnesota. You share our values, our mission of advancing international understanding and engagement. For any of you watching today who would like to support that mission, to advance that work, this is a good day to join. You can go to our website. If you join at the basic membership rate, you'll get a free copy of the 2022 Great Decisions Briefing Book. This is a national program looking at key hot topics in global affairs, and they produce a briefing book that's a fantastic resource for conversation and for study and for in-depth. So we also want to make sure that for everyone who's watching, if you need and want to make use of the closed captioning, there is a special set of instructions using Google Chrome. You can watch the translation on screen, but you can catch that closed caption by following the instructions there on the YouTube event notice. So without further ado, I'm just thrilled that we are partnering again this year with the World Health Organization. This is their day. It commemorates the day of the founding of the World Health Organization, WHO, as we like to call it, in 1948, part of a birth of many new global institutions coming after the Second World War. We'll be hearing later in the day from Dr. Tedros. They're doing a press conference and a media availability in the afternoon over in Geneva time. And so this will be later in the day and recorded. But we are so thrilled that we were able to get the participation this morning of Christopher Bailey, who leads all of the arts and health and healing work at the World Health Organizations there in Switzerland, near Geneva, and in the headquarters in Geneva. Christopher Bailey is a dramatist, a leader, 50 years in philanthropy at the Rockefeller Foundation and 20 years at the World Health Organization. Christopher, thank you so much for joining us today, and please help us understand, where does this theme this year for the overall day, Our Planet, Our Health, and how does your work in connecting healing with arts and culture help all of us address that question of health equity worldwide? Welcome, Christopher.
Oh, thanks so much, Mark. And just a little disclaimer up front. If you hear in the background Ukrainian, I'm currently sheltering 3 generations of a Ukrainian family in my home. And I've tried to explain I'm broadcasting right now, but I'm not sure it was entirely understood. So
we appreciate cross-cultural, but also solidarity. So bless you and thank you, and jump on in.
Yeah, well, I think WHO is a public health organization, and public health is not just the patient-doctor interaction. That's a part of it, but it's also the air we breathe, the food we eat, it's the lifestyle we live, it's how we're born, how we die. It's all aspects of living. And certainly nothing is more important than the livability of the planet. And if the planet becomes unsustainable for life, then there's no health. This is, I think, as the UN report that just came out last week showed, this is a critical tipping point right now. We have to sound the alarm and do what we need to do to make sure that human intervention on this planet does not befoul the nest and make it unlivable for us. And we have that opportunity right now. Now, you talked a little bit about the arts and health work that I do. And certainly, I think the most intuitively obvious aspect of arts and health is the fact that I could give you a research report from the UN, I could spout statistics for you, but oftentimes the way our brains are wired, if we tell a story where we can actually empathize with another person, with another way of looking at something, that often helps us arrive at a new truth, to change behavior, to change perspective and opinion in a way that mere recitation of facts don't always do. And so that's one aspect, I think, of the health uses for the arts. But the other aspect, I think, is somewhat more interesting. It's actually the embedded health aspects of engagement in the arts. And when we start thinking in terms of the environment, as I'm sure everyone has experienced, when you engage with nature, there is a healing effect. And oftentimes through the century, artists have been the medium of that. And whether it's a poet, a composer, a painter, they have helped bring the healing power of nature into our homes, into our lives in a truly profound way, especially since the Industrial Revolution, when many of us in our communities and societies began to disconnect from nature.
Well, so Christopher, this has been, I would say, a passion for many here, I know in our region, but only in the last couple of years, especially with the murder of George Floyd and the eruption and the broader community, do the notions of individual healing and community healing and social healing feel more interconnected. And the World Health Organization, as our global public health institution, has to think on all of those levels all the time. There's a person with COVID, there's a COVID pandemic, there's a potential solution somewhere on the planet. Give us a sense of how you and the WHO leadership have been thinking about this expanded, more social understanding of healing, heritage, and health.
Well, I think it actually is very much related to World Health Day, because World Health Day was the moment when the WHO Constitution was ratified by the member states. And in that Constitution, we have a definition of health that I think was very prescient. In that definition, we state that health is not merely the absence of disease and infirmity, but the enjoying the highest level of physical, mental, and social well-being. And I think that was, once you start framing health in that kind of holistic way, as not just the absence of a diagnosis or a diagnosable condition, then we begin to intuitively understand how the arts can have this healing effect. When we perform in whether it's music or drama or any other aspect, the audience, their heartbeats begin to synchronize. We begin to share a moment of attention where we begin to join in on a common story, a common feeling. And when we go on that empathic, cathartic journey, there's a moment of awakening that happens with that group of people that can imagine a new way forward, imagine a community, can bring comfort, can bring context and perspective to a situation that may seem hopeless or difficult or catastrophic. Because at the end of the day, hope is a creative act. And the role that artists have to play in bringing hope to society, of dealing with the actual problems, but finding a path forward is critical to communal healing.
Well, you've taken us back to 1948 when that Constitution was signed or ratified. That meant that the trauma, the crisis of the Second World War on top of the First World War, on top of the Depression, the famine, the drought, led people to say, you know, we've got to change our ways. I mean, we need a new approach. I'm taken by your terminology about hope. We know that patients that are getting chemotherapy and treatments for breast cancer who are hopeful have much higher positive outcomes than those who are not feeling hopeful. We know that individuals going into cancer treatment who are supported by their families, by their friends, who have a community around them. So you are in this moment lifting up the way that not only do the arts and culture kind of help us to kind of connect, but also the actual healing outcome. So this moment, you are hosting a family from the Ukraine. There is a war going on that's being referenced in relationship to the Second World War. The World Health Organization's there to serve every person on the planet, not to pick and choose, How are you imagining in this coming year we link more directly, more effectively, the hope and healing aspects of art as we begin to try to put the pieces back together? I'm assuming, I'm guessing, I'm suspecting that you've been thinking about this in a way perhaps nonstop.
Well, I have, and I've been assisting different performing and arts groups as part of the psychosocial support of the refugees, not just displaced from the Ukrainian war, but also all refugees, the refugees from the South Sudan, refugees from Ethiopia, Syria, and beyond. Because at the end of the day, it's about human beings in need, and that's it. I think what's also important about the arts is that I always go back to my favorite quote by Carl Jung, the famous Swiss psychologist, who said, "Loneliness is not the absence of people. Loneliness is the inability to express what matters to you most." And the beauty of artistic engagement, of playing music together, of finding the words, is that it's more than just a clinical healing. It's being able, after a situation where your autonomy was threatened, your life was threatened, perhaps your identity was threatened, to become author of your own story. And that is hugely healing, hugely empowering. And I think what happened in the terrible incident with George Floyd in your city, Breonna Taylor in Louisville, and other places, it was more than just the tragic killing of an individual. It was an awakening of an untold story of a people that needed to be told. And I think artists play a role in that, but also at the end of the day, each of us is an artist. Each of us can find the words that capture what you care about most. And being able to support that expression is a hugely healing aspect.
Well, it is the moment now that we have the opportunity, because it is World Health Day, to use the new technology to bring people together like yourself from Switzerland and others. But you're putting us in touch with something that's deeply fundamental, but also can happen anywhere. Singing, producing music, painting, sculpturing, all of these things, knitting and quilt making, the range. So
with quilt making, to give you an example, we just had a project a couple of weeks ago called the Corona Quilt in Jaipur, India, where we had women all across India, craftswomen, create small squares of cloth that represented their Corona experience, and two artists put them together into a magnificent quilt. And this became a monumental effort of community building, of healing, and of hope, as an example. So when you say sewing and quilt making, here's a concrete example just 2 years ago at a national level.
Yes, and we've had some incredible quilts that have been connected to AIDS and HIV here in the United States and around, and all of that. And so these are things that we can do individually, as groups. Minnesota will be hosting a giant gathering of Latvian choirs in a few weeks. Been postponed a couple of years, but we have this this kind of history and heritage. But now we are moving into an era where we are perhaps more able to talk about some of the hard things. Discussing equity is not the easiest thing. In fact, it's dangerous. Dr. Martin Luther King, this is the week of the murder of Dr. Martin Luther King, who had come to Memphis to help and stand with the sanitation workers who were fighting for equity and pay and fighting for justice, and he was murdered. So equity and disparity and injustice, these things are complex parts, and they are difficult to talk about, and they sometimes dangerous to confront. But it feels like we're at a time where people are not just saying we want to do something about these problems, these issues, but they're thinking about it in terms of design. You can't just hope that a solution will fall from the sky. Tell us, in this last couple of minutes we have, how are you seeing the design aspects of the way that arts can aid our efforts towards healing in a way that helps accelerate health equity?
Well, I think, first of all, when we, in that WHO definition of health, when we talk about physical, mental, and social well-being, and I would add environmental health as well as a fourth item, even though that's not in the original, these are not separate silos. They're all interrelated. So why does WHO feel that social well-being is a part of health? Well, because with inequities in our society, physical health declines. When physical health declines, mental health declines. Any one of those poles affect the other in a negative spiral if there's a deficit. But by the same token, if we support any one of those poles, the other two improve. So when there's greater equity in our society, there's greater health, there's greater mental health, and vice versa. So I think what we need to do is look at this as a virtuous triangle where in a systematic way, be able to support physical, mental, and social well-being on a national scale, not as something that would just be nice to do, but because it's actually a human right. And that's something we lose sight of sometimes.
So that framework, to talk about this as a human right, to put it into the context of policy, and then to help each other by sharing examples, by pulling people together, by conferences and all of this. I'm hopeful that we can stay very close in touch with you, not just because originally you're from Minnesota, but because you play this crucial role in the international body that is our primary partner in trying to think about health at a global scale. Global Minnesota, that's part of our work. But more importantly, we have people here in our city, in our metropolitan, in our state, in our region, in our country, who I know feel and believe the same about the critical importance, not just in the healing part, but in all things about the interrelationship. And you've been helping some of those groups I know in places like Louisville, Kentucky, which is trying to use that coming together of arts for healing at the community level. And it's something that we want to promote here among groups who are already active, but among others. But the work that you're doing helps inspire us. You're helping to connect us to others in our own country and around the planet is so crucial. But also you're having this big vision of how it fits into the founding of the WHO, which came out of one of the most terrible periods of human history, but also how it can help lead us going forward into that more hopeful and therefore more healing place. Can you give us some final words that will help us think about how we maintain the momentum from the inspiration that you've been giving us?
Well, the first thing I'll do is I want to say hello to Duluth because that's where I was born. And my very first memories on this planet were examining all the little stones and pebbles on the shore of Lake Superior. And that literally is my first memory. So my connection to the environment begins with the shores of Lake Superior, as a matter of fact. I think particularly when we're facing an issue as existential as the livability of this planet, it's important not to lose hope. It's important to remember that each of us can do very specific things to improve the situation in our own lives, but in advocating in our governments. But from an arts point of view, in the face of difficult times, whether it's a war, whether it's the environmental crisis, express yourselves. When things get difficult, instead of succumbing to fear or succumbing to anger, express yourself with all your heart, with all your skill, and create beauty in this world. It will have an effect.
Thank you so much, Christopher Bailey, and thank you for joining us today. And I look forward to many different ways that we can connect going forward. Again, thank you, and thanks for joining us from Switzerland. Goodbye now.
My pleasure. Bye-bye.
If you're just tuning in, we are beginning our day of programming here at the Global Minnesota's World Health Day 2022 Symposium. Our next guest will help us move from thinking about the way that the healing of arts and culture and the aspects of that can bring us into a healthier personal life, but also can help heal the planet and the interconnections. Our next guest is a very special person in our broader community. Dr. Nisha Botchwey is our dean of our Humphrey School of Public Affairs. Full disclosure, I'm a graduate of that school, so I'm very fond of it, and of course, our new dean. But Dean Botchwey is an international scholar and expert in the deepest sense of the word about the interconnection between our well-being and health and the built environment. This is part of that larger conversation that we'll be having all day long, our planet, our health. And she's been thinking about this with an equity lens from the beginning. I am thrilled that we were able to invite her and bring her to Minnesota from actually one of my favorite places, to tell you the truth. But she was the associate dean at the Georgia Tech Professional Education program at Georgia Tech. People don't know this often, but I'm from Georgia originally, and my father was school there at Georgia. And she's been leading thinking around the planet on this question of the built environment and health, but also the nexus of environmental and health policy as it relates to the question of equity in particular. Dean Botchwey, thank you so much for joining us today. I know it's a really crazy busy time, so I'm thrilled to be able to invite you and for you to be able to participate on our World Health Day. And I know that you have some slides to present to us to give us the big picture. I want to turn it over to you to take us away, and we'll have a few minutes for some conversation at the end. Thank you again.
Mark, thank you for your warm welcome. I am truly honored to be here with you in Global Minnesota. This is almost the end of my first 90 days. And so to be able to be with Global Minnesota in my first 90 days to truly kick off my launch as Dean of the Hubert H. Humphrey School of Public Affairs is a treat, and it's an honor. So thank you.
Take it away.
Will do. So here we go. So thinking about, and I think you should be able to see my screen now.
We're all good.
Fantastic. Thinking about health and specifically public health in this global context, I cannot help but be excited about the strong foundations on which Global Minnesota is building and the legacy that your audience here are seeding for the world population that will shape our future. So thank you again for welcoming me to talk about designing healthy places, both next door and around the globe. So let's start with this question: how has the design of our environment impacted our health? Attention to health in the built environment started in the early 2000s. Some argue a little bit before that, but early 2000s with scholars Dick Jackson and Chris Katisky from the Centers for Disease Control and Prevention speculating on the health impacts of urban sprawl, focusing on how the design of suburbs and that center around the use of automobiles and discourage walking and biking for transportation may contribute to obesity and associated chronic diseases. At this early stage in the early 2000s, this work was labeled junk science because we did not really yet have the evidence that this was truly the case, that there is a connection between the design of the environment and people's health outcomes. We had a feeling that this was the case, and so we continued to pursue it. As you can see here in the diagram, in the neighborhood at the top where you have the loop lollipop pattern, walking is not considered to be the normal behavior. But in the neighborhood at the bottom where you have lots of cross streets, walking is not only the normal, but also the expected. It's expected that you would be active and not sedentary if you're in the neighborhood on the bottom versus the top. Scholars along the way and around the world, beginning with this understanding, started to publish papers. And so you can see that in the early 2000s, there were only about 90 articles looking at these connections. But as we moved to 2016 to 2020, there are about 3,000. And so you can see that the attention and the thoughts around this topic really exploded, because now we're not only thinking about, okay, maybe there is an association, maybe there's this walking and sedentary and design piece, but there's so many other components. And let me tell you about a few of those other components. Today, the United States and most of the world are facing three major crises: the COVID-19 pandemic, health inequities and racism, and climate change. All of these have health implications that can be addressed in part by built environment solutions. COVID-19 has had major impacts, as we know, on public transit, limitations in physical space and internet access, protection of essential workers who cannot work from home, especially those in service economies, including transportation, healthcare, facilities, tourism, and even just your grocery store workers. We also know that throughout history and around the world, families and tribes have learned to be cautious and fearful, perhaps, of those who are newly arrived, who may look different and who have different customs and cultures. And unfortunately, in some societies, this has led to the creation of racist systems that discriminate against those not with the most power and influence. That leads to substantial economic and health disparities. We just heard from Christopher Bailey that where there is greater equity in our environment, there is greater health. That is indeed true. Essentially, racism has disenfranchised Black, Indigenous, and people of color from education, employment, and their ability to create wealth for themselves and an economic legacy for their family. Political decisions must actively opt for equitable investments of these societal resources for improving the built environment, our schools, our housing, our parks, healthcare facilities, transportation systems, and so on. In this way, we can really begin to compensate for the years of underinvestment, disinvestment in disenfranchised communities. And finally, climate change. Like COVID-19 and racism, this has significant impacts on health of people throughout the world. Sea level rise threatens millions of coastal inhabitants who will be forced to migrate. As urban areas become unbearably hot, or perhaps unbearably cold in Minnesota in some days, populations will move to cooler regions and demand new housing, transportation, and commercial infrastructure. We will see more heat waves, hurricanes, blizzards, and floods, droughts and wildfires, with the attendant loss of property and lives. Improvements in the design of built environments, of the buildings, of transportation systems, of energy systems, water systems, and communities can and will help promote healthy density and mitigate the contributions of built environment to climate. And so what is then a healthy place? Healthy places can be small, from a well-designed chair or furniture to immense at the scale of our globe. Healthy places, as is noted here, are places in which people can grow up, live, work, play, study, pray, age in ways that allow them to be safe and healthy, to thrive, and to reach their full potential. Creation and maintenance of healthy places require that we pay attention. We pay attention to environmental sustainability, because in the long run, there can be no healthy people without a healthy, intact planet. The built environment are those things that are designed, created, and maintained by human efforts. These are our buildings, neighborhoods, food stores, local markets, public plazas, playgrounds, roads, culture, and social policy. The built environment depends on supporting infrastructure systems for such necessities as the energy we use, the food we eat, the water we consume, housing and transportation. So these systems are also considered part of the built environment. My very good friend, Dick Jackson, explains it in this way. He says that the built environment is set in concrete, both figuratively and literally. Just as the making of concrete requires large inputs of materials and energy and lasts decades or centuries, the built environment shapes behavior and the future culture. It shapes behavior and the future culture of those who live and work within it. Let me show you how this is manifest. So here in the United States, your address or your zip code is a stronger predictor of health than your genetic code. Your address is a stronger predictor of health than your genetic code. We should seek to optimize the design and construction of our built environments to bring the benefits possible to healthy sustainability and well-being for all populations, especially those who are the most marginalized. In this example from Atlanta, Georgia, one of your favorite places, Mark, where people in the southeast part of the city, where you can see the red kind of markers, they live to 71 years old on average, 71, 72, 73. This is 13 years shorter than people who live north in Buckhead. That's just 10 miles away. 10 miles is the distance that dictates a 13-year shorter life. That's not right. Design and policy matter. They can and will lead to healthier and happier people who live longer lives, but we have to make sure that this indeed happens. And so we have this health definition from our friend from the World Health Organization, Chris. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This definition goes beyond a narrowly biomedical view to include many dimensions of thriving, including comfort, happiness, and well-being. Two other distinctions I just want to make here are that are between healthcare and public health. Those in healthcare tend to be clinical focused, focusing on individuals. Professionals in public health operate at the community level, focusing on populations. They are dedicated to fulfilling society's interest in assuring conditions in which people can be healthy, conditions that range from effective healthcare systems to healthy environments. Whereas design professionals focus on the form, function, and operation of things and spaces. So this image is likely very familiar to some of my public health friends. So during an 1854 outbreak of cholera in London, John Snow observed a far higher incidence or number of new cases of disease among people who lived near or drank from the Broad Street pump than among people who had other sources of water. So John Snow, an early epidemiologist, persuaded local authorities to actually remove the pump handle, and the epidemic in that part of the city soon abated. Essentially, John Snow reshaped the environment so people could not draw water from the Broad Street pump. He removed the pump handle, thereby cutting off access to the water from the pump that was the source of the cholera outbreak. This is what designers of the environment and policymakers do. We remove the pump handle with a hammer or a pen. John Snow in this way was shaping the environment like we do and protecting human health. So I want you to think, in what ways can you, where you are, reshape the built environment to minimize negative exposures and maximize positive exposures? Despite these early lessons and advancements, chronic disease, including heart disease, cancer, and stroke, have overtaken infectious diseases as leading causes of death and suffering. Injuries, especially in relation to motor vehicle crashes, are recognized as major public health burden as well. And this data, as you can see, from 1900 to 1950 and then to 2019, this is from the United States, where we see risk factors such as sedentary lifestyles and obesity as key targets of public health and design interventions for what are primarily non-communicable diseases, those diseases that are not transmitted from person to person, but are more diseases of kind of lifestyle and behavior. So what does this chart look like? What do the outcomes look like in low to middle income countries? What are the leading causes of death in low to middle income countries? Where should we be paying attention if we're looking across the globe? Let me give you just 6 quick examples. In low and middle income countries, the dual burden of undernutrition in the form of wasting and stunting, and overnutrition in the form of overweight and obesity is particularly salient, with the burden falling primarily among the poorest. Over the last half century, while high-income countries have seen dramatic improvements in air quality, cities in low and middle-income countries have manifested dramatically high levels of air pollutants, the result of a combination of factors, including industry, burning solid fuels in households, and highly polluting motor vehicles. Nearly 5 million people around the world die from injuries every year, and nearly 100 million require some type of healthcare due to an injury. Injuries are the leading cause of death for youth and have a higher incidence in low and middle income countries. The design of the built environment can have considerable impact on the likelihood of injury from most of these mechanisms, especially motor vehicle related injuries, falls, fires, and drownings. Globally, most types of injuries decreased from 1990 to 2013, especially in high and middle income countries. Many of these decreases are due to changes in the built environment. However, most types of injuries increased in low income countries due to the design of the built environment. There are more cars and unsafe passage for pedestrians. Although most transportation globally is by motor vehicles, such as passenger cars, buses, and trucks, more than half of injuries and deaths occur among vulnerable roadway users, and that's bicyclists, pedestrians, and motorcyclists. While it may seem that water and sanitation issues were solved a century ago in highly industrialized countries, in high and low income countries, water access is not universal. It's not universally clean, affordable, or governed fairly and consistently. However, about 75% of households in low-income countries either do not have access to hand washing facilities or have access to the facilities, but lack access to water and soap. Additionally, anthropogenic pressures or man-made pressures, human pressures, expose water to pollutants from point and non-point sources. The impacts of climate change on water are already being felt within communities. This is from drought conditions, so too little water, to flooding, too much water. Climate change pressure presents a water paradox where residents in some communities, especially low-income residents, suffer from flood events and lack access to clean drinking water. Some areas, especially in low-income countries, have informal housing settlements where ownership of both land and the structure is poorly documented and where basic services such as water, power, and sanitation are lacking, which has important implications for community investment and sustainability. Additionally, the most severe and immediate impacts of climate change, including health impacts, are concentrated in low and middle income countries, especially among people living in informal settlements. And finally, with global reports reinforcing the valuable impacts of education on health, employment, poverty reduction, resilience, equity, and greater individual freedoms, there remains a gap between schooling and learning with the greatest burden faced by low-income countries and communities. Studies in the United States continue to reveal persistent deficiencies in school facilities. Here in the United States, in low-income countries, the situation is even worse, with shortages of such basic infrastructure as sanitary facilities, lighting, and student desks. I would be remiss, especially in this program, if I did not say that sustainable development is key to the remedies. Sustainable development is defined as development that meets the needs of the present without compromising the ability of future generations to meet their own needs. The 2015 United Nations Sustainable Development Goals are the international framework for much of the approach, realizing that human beings are at the center of concerns for sustainable development. And we are entitled to a healthy and productive life in harmony with nature. And I'll just note that goals 3, good health and well-being, 6, clean water and sanitation, 7, affordable and clean energy, 11, sustainable cities and communities, and 13, climate action have direct connection to healthy places. There is also a growing healthy cities movement that is evolving out of this work, and I encourage you to look into it. So when we examine the leading cause of death globally, remember we saw the US data previously. When we look at this globally, based on the data from the World Health Organization, we see that in 2019, the top 10 causes of death accounted for over half of the 55.4 million deaths worldwide. Again, let me say that. The top 10 causes of death accounted for over half of the 55 million deaths worldwide. Causes of death, as you can see here, are generally grouped into 3 categories. So these are communicable, infectious and parasitic diseases, non-communicable, and injuries. And you can see that's blue, green, and black. Okay, those colors I want you to keep your eye on. In this chart, you see that the top global causes of death around the world, low and high income countries, in order of total number of lives lost, are associated with these 3 broad categories. So cardiovascular, so like heart disease and stroke, respiratory infections and so on, neonatal concerns, which include birth asphyxia and birth trauma, neonatal sepsis and infections, and these other complications. As I click through the next just 3 or 4 images on this chart, I want you to keep your eye On the movement or location of the blue, non-communicable, the green, communicable diseases or infections, and the black, injuries. As we now move from low income, as you can see here, and so we have green and then some blue. This is lower middle income. Keep your eye on the blue and the green and how that's moving in addition to injuries. Upper middle income countries, primarily blue, we still see injuries. And then finally, high income countries, for the most part blue, and there are no injuries here. Injuries drop off as we look at these high income countries. There is a clear pattern here that I think is important for us to understand as we move to solutions. And so these results based on high income to low income countries make sense if we understand this iceberg analogy. Here with the iceberg, the biggest and foundational part is well below the waterline. This is the part you don't see. This is where the systemic structures and the societal determinants of health that shape our behavior and lead to healthy or unhealthy events or outcomes exist. This is the roads, these are the trains, these are the behaviors and the choices that we have to exist and live and play in our communities. This is another way of saying that the largest contributor to our health outcomes is where we live, grow, learn, play, and the social conditions that shape our behaviors. These account for 85% of our health. Healthcare and genetics account for just 15% of our health outcomes, just 15%. So how do we turn things around? How do we create healthy places in low and to middle income countries and low income countries? The solutions I present to you are that one, we work with communities. And I'm going to give you a quick example from South Africa from the Water and Health in Limpopo project. And then you build youth capacity. And this comes from my Youth Engagement and Action for Health curriculum. And so here we work with communities to create a vision. In South Africa, we led the Water and Health in Limpopo project with the University of Venda, with partners at the University of Virginia in Charlottesville, Virginia. And in this Photo Voice project, we trained community members, as you can see here. They took photos of what water meant to them. We asked them to say what's important about water, why water, what's good about water, what's most important about water, what's bad about water, sorry about that. Familial and relationship, what does that mean for water? And then how is water represented by weakness? We did individual and group interviews and then had a presentation, as you can see here, with all of the photos laid out near the community tree. We have a fantastic photo collection that was captured by the community. These are amazing images. And the themes that came out focus on infrastructure and storage. That was what was most important, most critical, the most significant weakness, concerns around community and relationship, money and value and cost of having to buy water when it's not accessible from nearby, food, health and hygiene, and then pain. And I'll just note here that the connections are clear for our friends there in the Limpopo community with climate change and health. And what is suggested is that what we plan healthy communities with communities. We engage populations to identify, design, implement, and monitor community concerns toward improved quality of life, thus health outcomes. And secondly, that we allow communities to prepare and respond to their own, to other stressors that they identify successfully. Give them the tools to do this to help mitigate negative impacts of climate change on health. And then finally, the Youth Engagement and Action for Health program. This is a youth program that's designed to teach advocacy for improving physical activity and nutrition assets in communities, focusing on policies, systems, and environmental change. In this program, the youth conduct neighborhood assessments, they complete an advocacy project, and they learn about advocacy and health so they can be the leaders in creating this change. It's a 10 to 14 week program targeting middle school, but the curriculum is accessible to any set of kids. We focused on low-income students from minority backgrounds. It's also able to be used with all youth. And they conduct different community assessments. They share a presentation with a decision maker, and then they have some pre and post assessments. And so you can see here that we have groups all over the world. I'm sorry, well, Hawaii, not necessarily completely over the world, but all over the US. And their community assessments included parks, park programming, food options in their school cafeterias, advertisements in grocery stores and corner stores, sidewalk improvements, and neighborhood programming. These are the things that our youth are saying are important to them. And through the YA program, they're able to build the skills to be advocates for themselves and their communities. Let me just end with a charge. And this is a charge from 3 global leaders coming out of the African continent. Their focus is on Africa, and it's applicable to nations around the globe. Professor Blessing Maberu from Kenya says that real progress in achieving an urban Africa without slums will include massive investments in infrastructure, including water, sanitation, waste management, electricity, good roads and sidewalks, parks and green spaces, transit service, and healthy housing. These are critical if we are to see a healthy progress in this area. Tulula Onu from South Africa says that Africa's young population and dynamic cities are well placed to catalyze and accelerate a reimagination of the urban, to embrace adaptive systemic change, and to place health at the center of sustainable, inclusive urban development. And finally, my good friend, Emmanuel from Pongboma, from New York by way of Accra, Ghana, says that creative and equitable approaches to finance and maintain water infrastructure that empower community members are needed to meet the human right to water and the UN sustainability goals. Thank you for your time listening. Much of what I've talked about is in the Making Healthy Places second edition book that's due out in July of this year. And I want to just thank my co-editors, Howard Frumpkin and Andy Dannenberg, for their contributions to the many ideas that I shared today. And Mark, I look forward to our conversation.
Jean Botchwey, thank you so much for giving us such a big picture in a condensed and such a short time. I wish we had given a whole day, and we will. But I want to come back and say that you're leading and giving us the larger context of the UN Sustainable Development Goals is so crucial. You work in the world and you've worked all over the planet, and you know that other people are using this as a design tool, as a North Star, and we can too. And so I'm excited that your voice will help bring that out in the larger context. But I also want to say that I am loving the Yay t-shirt that you have gifted me, and I want to start finding ways that it's on our youth here and around the planet. And we will come back to this. I know that next week you will be hosting Madiba Mandela. Dr. Mandela is here for a month helping us talk about human rights in the context of health. And you've been touching on this as a human rights question. And so we look forward to being engaged on many other levels. But today you've given us a foundation. Christopher gave us the picture of how we have to think of health as integrated and how it is connected to our hearts, our souls. You've given us the picture of how we make those design decisions about the built by definition planet. The disparities that you showed us with the charts is a challenge. It's a heartbreak, but it's also an eye-opening inspiration. And only by working together, that whole notion of the village. Now the village is planet-wide, and we're so grateful to have you here being part of it. Please send us off with some inspiring words that can help us take what you've given us as the gift of greater knowledge and inspiration, take us forward.
Mark, perhaps the word I would say is Ubuntu. And it's the word that is deep in my heart. Ubuntu means I am because we are. I cannot do anything in my physical space. I cannot be healthy where I live, work, play, if it's not for the people around me, the policymakers, the bus drivers, the folks who make sure we turn the lights off in the building, and the designers who build the mosquito netting to go over the windows to make sure that mosquitoes aren't going into homes and malaria and is infecting communities. But we also have to make sure that we put the mosquito nets up, that I turn the lights off when I leave the building. Because if I don't do the work that we are orchestrating to help make sure we have a healthy planet and a healthy future, then we cannot have that healthy planet and healthy future. And so Ubuntu, I am because we are. And I look forward to the manifestation of that connectedness globally as we continue this good work.
Thank you so much, Dean Botchwey. Look forward to seeing you again soon. Goodbye now.
Bye-bye.
If you're just joining us for our Global Minnesota World Health Day, welcome. We have been digging into our theme about accelerating health equity by design as the context for this World Health Day that we're partnering with the World Health Organizations, our planet, our health. We are now going to have an amazing opportunity to see inside of some of those elements who are designing for health equity in their work in the larger field of addressing a number of the problems that Dean Botchwey spoke about. Our next guest is the Chief Strategy and Product Officer for Medtronic Labs and Stake. Some of you may know the company Medtronic, most famous, I suppose, for the pacemaker, but many, many things. It's a company that addresses the needs of people globally in the larger area of medical technology, but also just in change making about health. And Medtronic Labs is a very special part of Medtronic, company that happens to be based in Minnesota. It's a part of the company that is a health systems innovation. It's a designer of health system innovation that implements it, community-based, tech-enabled, and their focus is on underserved patients, families, communities around the world. And we're so thrilled to have Ann Stake, their Chief Strategy and Product Officer, joining us here today. Please join me on the screen, Ann, and thank you so much for making time to be with us here today.
Thank you so much, Mark. I'm glad to be here. I'm going to share my screen.
Great. Take it away.
Great. Can you see them, Mark?
Yes. Thank you. Perfect.
Perfect. So the last conversation ended with a discussion about water and health as a human right. So I was thinking we would kick off in that same vein and talk about health equity and design and the theme a little bit, and then I'll get into Medtronic Labs and what we do. But this is a picture of some words that were painted on the side of one of our health centers in rural Kenya in a village called Shambeke, and it says, "Quality healthcare is your right." So whether you're in a rural village in Kenya or whether we're living in Minneapolis, at Medtronic Labs, we take this same sort of rights-based framework in the way that we think about health equity. And the second lens that we look at when we think about health equity is related to the social determinants at the root of poor health. So we all know that health is also about poverty. It's also about education. It's also about transportation, about race, a whole range of interrelated social determinants. So when we think about achieving health equity, we also think about how can we address some of those barriers at the ground level on the journey to actually creating better patient outcomes. And that brings me to the second part of the theme, which is design. And we think of design for health equity kind of at two levels, and you'll see that come to life later in the presentation. But first is at the level of the patient or the person, and what does it take to really address some of those social determinants. So we have teams across the world in Kenya and India and Ghana and Sierra Leone, all the 10 countries where we work that are designing with patients and communities every day. And the second level that's really important when we think about designing for health equity is the system level. Health systems and systems, create the outcomes that they were designed to create. So we think about how do we actually change the system at every level, from policy with the ministries of health, with the county governments, all the way down to how it's implemented on the ground. So those are things to keep in mind as I talk about Medtronic labs. Those are some of the frames that we use that power the work that we do. So getting to Medtronic labs, many of you, as Mark said, have probably heard of Medtronic, the large medical technology company. And Medtronic Labs is actually a dedicated nonprofit organization. So we're the global health arm, the signature global health initiative at Medtronic. And we didn't create Medtronic Labs overnight. So it's been decades worth of work. I think it first came about when our former CEO, Omar Ishrak, challenged all of the employees across Medtronic to figure out, how could we create solutions that would actually address the most underserved populations that Medtronic products never can reach. And after decades worth of iteration and experimentation across the company, we landed on this dedicated organization that's a separate nonprofit. And some of the lessons along the way that kind of informed where we are today was, first, we realized that no matter how hard we tried to make the pacemakers or the advanced medical technologies accessible, it would never solve some of the social determinants that I was talking about, some of the root causes of poor health on the ground. So we needed to take a different approach, and we needed to really focus on the last mile. And then the second discovery that we made is that even though at Medtronic we focus a lot on medical devices, there's this massive transformation happening across the world in terms of digital technology and access to digital technology. So 10 years ago, nobody really had a mobile phone in rural Kenya, but fast forward to today, almost every single person in the entire country has a mobile phone, and often smartphones. That kind of creates a different environment for innovation and a different way to expand access. So Medtronic Labs focuses on last mile healthcare delivery, and our mission is really simple: to expand access to healthcare for patients, families, and communities across the world. And to do this, we focus on, as I was designing and implementing tech-powered healthcare delivery models that are all about strengthening and extending health systems into local communities. So we don't build parallel health systems. It's all about working within the health systems, changing the health systems, and really extending them to the patient in their homes and their communities, all to deliver sustainable outcomes. So we have a huge focus on measurable outcomes for patients across the world. And our current focus is on chronic disease. It's a majorly underfunded area in global health. So despite the fact that 70% of mortality in low and middle income countries is due to non-communicable diseases like hypertension and diabetes, only 1% of global health spending goes towards NCD care. So when we were thinking at Medtronic Labs about our strategy, this seemed like the perfect niche where we could really build on the expertise at the company, and also fill a major gap in the health system. I will say that we started with hypertension and diabetes and chronic disease, but we're expanding very rapidly into other areas like mental health, tuberculosis. The list goes on and on, because we all know that diseases don't exist in silos. Now to bring it to life a little bit more, I talked about innovating and designing at the system level. So what we're really trying to do at Medtronic Labs is to create system level transformation. And I'll dive into a case study. I talked about Kenya a little bit already, but a case study around how we're actually able to achieve some of this system level transformation. So in Kenya, we started out actually designing one of our first programs for hypertension and diabetes, alongside the health system from the very beginning. So our teams, I will say that, even though I'm speaking right now, 95% of our 250 employees at Medtronic Labs are actually based and work in the countries where we operate. So I'm lucky enough to talk to you today because I'm one of the very few US-based employees. But we started designing this program on the ground. Some of our team members met with health facilities in Mombasa and started brainstorming how could we actually improve access to hypertension and diabetes care at the primary care level. We started creating, co-designing, and iterating on a model that combines digital technology with a model of care that leverages community health workers to manage the condition at the community level. We started out with a pilot funded by Novartis, where we established a public-private partnership with the Ministry of Health and 3 different county governments to test this in the public sector. After we got some initial results, so we reached about 50,000 patients, we expanded it to reach around 200,000 patients with funding from PATH, which is a big global health organization, and Novo Nordisk. And now we're in the phase of scaling this program across every county, so all 47 counties in Kenya, with funding from the World Diabetes Foundation. So it's kind of the first example of a tech-enabled national program for diabetes and hypertension. And the goal with this is, as we expand to all 47 counties, our technology and our model will be the benchmark and fully integrated into the national system for a sustainable model that's actually creating systemic change. So this is really the blueprint for what we want and hope to do at Medtronic Labs in all the other countries where we work. We're currently expanding in Ghana, in Tanzania, Rwanda, Sierra Leone, Bhutan, and India, and hopefully more countries, hopefully even some work in the United States, because we know that health equity problems exist everywhere. So in terms of actually how we are doing this and the model that we have developed through a lot of this on the ground experimentation in Kenya and Ghana, our approach at Medtronic Labs combines kind of 3 core elements. First, I was talking about digital technology a lot. So we've designed software solutions with and for patients, community health workers, and healthcare providers in low resource settings. So all of our technology is specific to the context where we operate. So it's all offline first, really designed to be used in rural and remote settings. The second element is our field services. So we have community-based teams that are integrated with health systems that are focused on expanding screening, diagnosis, treatment, and community-based management and patient engagement, all kind of with the effort to get patients to a measurable health outcome. And then finally, we put a lot of focus on partnerships. It's very, very challenging to build public-private partnerships like the one in Kenya. So we're really focused on actual implementation-focused partnerships with health systems, with NGOs. We collaborate with multinationals and other funders, all focused around actually getting to a system level change. And to dive into some of the details to bring it to life even more, we think of our product as having multiple different layers, but all of the layers are in service of the patient experience. So we've worked with patients and with clinicians to understand how to address some of the systemic barriers to care. We start with awareness. We do a lot of campaigns in partnership with community-based organizations. We run screening campaigns with churches and on market days. And then we link patients directly to health facilities where they can get their diagnosis. And then once they're back in the community, we follow up with community-based management. And all of this is enabled by our suite of technologies or our products. So at the center, we're just launching actually a new version called Spice of our tech platform. Some of the key features are screening and risk-based disease management. So, we screen and risk stratify the population, so we're better able to target community health resources. So rather than a community health worker going out every month to every single patient, we're going to go out and target the highest risk patients. The second key element is around clinical management and decision support. So the clinician on the other side can see all of the patient data longitudinally to make better decisions. And we have a lot of the country level guidelines built in to our modules to make work a lot easier. One of the third components is interoperability and customizability. So we work in 10 different countries, each with different guidelines and different ways of working, different existing EMR or electronic medical records in some cases. So we are interoperable and very focused on customizability. We have real-time data analytics and we have data-driven patient engagement. So you're getting a theme here around data to improve healthcare delivery. Layered on top of kind of our core digital tech platform, we also put together point of care diagnostic toolkits that enable care to reach the community level. So we put together blood pressure monitors, glucometers, HbA1c machines, and weighing scales, also that at the primary care level, health workers like community health volunteers or nurses can actually deliver care effectively. And then finally, on top of all of this, we have our field operations and services, which I'll get into in a second here as well. But just having a tech platform alone won't actually create change. You need to have the wraparound support, whether that's training and field coordinators or health coaches and telecounselors to actually support the patient on their journey from awareness to better health outcomes. So in many cases, to give you a sense of what it actually looks like in the field, in many cases before we started work, this is a typical picture that you would see on the ground. So paper-based record systems, no visibility on even the prevalence of the conditions in various locations. And when we came in, and a lot of our work, it goes from that to this, where we have trained health workers that are able to use our technology. Here's a clinician in one of our health centers who's using our tablet and our mobile technology to actually view a patient record. And with our program, they're able to see all of that data longitudinally, check up on patients. If a blood pressure reading was really high in the field, for instance, they can see that in real time, connect with them via SMS, et cetera. So it's really a huge change and a transformation that we're enabling on the ground. So the second element, so we talked about digital technology. The second element that we focus on are really these wraparound services. So I was saying that 95% of our 250 employees at labs are fully integrated into the health system. So these are our community-based teams. We have program managers that are experts in field operations. So they really make sure that we're able to screen and enroll enough patients to hit health system targets around hypertension and diabetes, and make sure that we're following up appropriately in the field, troubleshooting, et cetera. We have health coaches that form peer support groups. We've developed in partnership with ministries of health a lot of education on chronic disease, and they run these large patient support groups in the field, both virtually and in person. We also have telecounselors to complement the health coaching. So we have a telecounseling platform where nurses on our team will actually follow up with the patients directly at all of the touch points throughout their journey, to make sure that, after screening, they're able to go to the facility to get diagnosed, that if, they've missed an appointment, we're able to follow up with them, or if they're facing other challenges like transportation or food insecurity, we're able to provide and connect them to the appropriate services. And finally, a huge component is training. So we train on digital health and digital literacy. All of our digital technology requires a little bit of training at every level, but we also work with the ministry to train on non-communicable diseases and the guidelines, because oftentimes even at the lower levels, we're not currently able to provide chronic disease care. So we're actually enabling that to reach lower levels of care to get closer to the patient. So here are some pictures to bring it to life of our community health volunteers. This is taken in Kenya. You can see that they have their backpacks on that we put together with their point of care toolkits, and they're ready to go either do a screening event in the community or follow up with patients door to door with their mobile application to make sure that they're getting their blood pressure and blood glucose checked, making sure that they're going to the doctor on time. Here's another community health volunteer who has the backpack that we put together with all of the point of care diagnostics. She's ready to go. And here's one of our health coaches, Jane, running a patient support group. This is also in Kenya in Makueni County, where we have 300 support groups altogether. And this is one of them with 50 patients learning about everything from how to manage medication adherence to strategies around diabetic foot and other complications. So we have wide-ranging educational programming that we do to help address the patient management side of chronic disease. And all of these wraparound services are really to help patients get to an outcome and help our clinicians better and more effectively manage care. So to date, for Medtronic Labs, we've screened about 1 million patients across the world, and we've improved outcomes for around, measurably improved outcomes for around 40,000 patients. So it's one of the largest programs for non-communicable diseases. And the third and final element of our work is all around partnerships. So at the beginning, I mentioned, we design with patients, and we also design for systems change. And part of that is the hard work and the grueling work that goes into forming partnerships and managing all of these different stakeholders. So we work with ministries of health in Kenya. We work with health systems like faith-based health systems, NGOs, development agencies like the German government. The list goes on, but all of this is really to show the commitment that Medtronic Labs has for the long term. So this is a picture of Omar Ishraq, our former CEO and current board member at Medtronic Labs, meeting the county governor of Makueni to reinforce the message that we're a committed partner for the long term. We're here for long-term system transformation. So I was taken last week, actually, on a visit to one of our programs. And finally, I know, Mark, you might have questions, but just wanted to end with this picture of one of our patients, because all of this work is really in service of the patient and in service of the goal to really create more equitable health systems. So that's all I have. Thank you.
Thank you so much, Anne, for both this big picture, this way of describing and giving us this information, but also for your passion and for the passion of Medtronic, your chairman, your former chairman, now on board member, but also your founder, Earl Bakken, who devoted the last part of his life to saying to everybody, what have you done with the life that healthcare or health technology or a pacemaker has given you? And I'm just so inspired by seeing how far you've been able to take that way of thinking and to put it out into the world. But I think for the last few minutes that we have here, it seems like you've found a sweet spot with Kenya as a place that had the need and the elements of infrastructure and also the policy and the apparatus. So can you give us a sense that your notion where you're designing, but you're designing it with partnership and with the other pieces in mind, give us a sense of how that then is infecting the mothership Medtronic, because I know you must be changing thinking at the deepest levels inside of the larger community.
Yeah, absolutely. Thanks for that question. And it's true, it's really baked into the founding of Medtronic and the mission that Earl Bakken set out when he founded Medtronic. Yeah, I will say that it's been a long journey, and the top leadership at Medtronic have been along for every step of the way. I remember when we just started the work, the current CEO, Jeff Martha, was involved in some of these ground level conversations talking about, patient access in Kenya. And that was always a little bit surprising to me at how engaged the top leadership was. And that has rippled through, I think, through the rest of the organization as people become aware of the work and how, as we gain traction and success, people get really, really, really excited about it. And I do think it's changing mindsets and the way, the rest of the company thinks about health equity broadly. Right now, actually, we're working with kind of some leadership to figure out how we can potentially bring some of these lessons and models from low and middle income countries to address some of the problems here in the US. Obviously, there's so much complexity everywhere. Will need to be customized and adapted to the context, but we will have some exciting announcements, hopefully coming up soon about that work in the US as well.
That's really great news. I remember when the New York Times started reporting on the adoption of the South African coaching healthcare community-based coaching model in the Bronx and Brooklyn and various places. And so we know that sharing can be and must be a two-way street, but it also is very important to know that in the heart and soul and the founding of a Medtronic came this vision and this impetus and this set of values, and you're able to stand on the shoulders, but also now to bring that both back into the company, but more importantly, perhaps back into our nation. We know that we have health struggles in terms of outcomes, but we know deeply that we have this challenge of inequity and disparity. And that's the origins of why today's theme for World Health Day is, accelerating that move towards ending those inequities, but doing it by design. And I'm so appreciative that you've made that design so central and given us this very clear and inspiring picture today. I'm afraid we're out of time, but I want to know if you can give our audience, and there's a lot of young people watching you, that sense of how they can be part of taking the inspiration you've given us today, be part of helping keep that momentum going into the future.
Yeah, absolutely. I mean, concretely, for all the young people out there, I think you literally can be part of this. You just have to find those opportunities. We have lots of opportunities at Medtronic Labs as we're growing, but there's tons of organizations out there, tons of work out there. So before you choose, going into McKinsey or consulting, think about, going directly into a social impact, social justice focused career. I couldn't be more happy with that choice. So encourage you all to do the same.
Great. Thank you so much. And thank you to all of the Medtronic people who helped make this possible so that you could share it with us here today. Thank you to them. And I get a little chance to talk about one of the places where these connections can be made. Some of you know we're in Minnesota. The University of Minnesota has a whole set of programs around how we think about medical education, the engineering, the computer science, the the IT part. And so we're really pleased that we've been able over the years to partner with our Carlson School of Management, their Global Institute. And we have a really short little video to give some of those who are watching, who are thinking about how their life's work could be in this kind of design to address health inequity. And please join me for this short video from our University of Minnesota.
Introducing the Carlson School's Global Medical Industry MBA. Born of a desire to find brand new technologies, students got together to create a brand new process at the Carlson School to look at early stage med tech. We did this first in Minnesota, grew to the program and its reputation for its unique approaches, and then started to go worldwide. First with Minnesota students with 500 alumni, then to Brazil, then to Shanghai, then to Stockholm, Palo Alto, Stanford, and in 2017 started to win brand new prizes in this space with our students in innovation for one of the best programs in the MBA market. We then exported this program to China and Shanghai in 2019, and now are offering it as a fully online program available to the entire world with an incredible curriculum designed for the 21st century. This program can now be available to you because of the Carlson advantage of all the industry connections that we have throughout our corporate partners. And we also now have scholarships available for folks overseas to become part of the next generation of global medical industry leaders. Please check out this program at our URL listed below.
Great. I'm so happy that we can create pathways for our inspired, creative, persistent, and just devoted young people to find a way into this larger world that we're examining today. So thrilled to be partnering with our University of Minnesota in this way. Our next presenter is somebody who plays a very special role in our nation. On the day of the inauguration, he was appointed as the chairman of the National Council on Disabilities by President Biden. There's a very special National Council that has grown in its stature and in its oversight, authority, and responsibility over the years. Some of you are familiar with the American for Disabilities Act, which is the fundamental law that has made the next step a process for addressing inequities and really the discrimination, severe and really inexplicably disastrous discrimination. And this method of putting a national council in place has been important for giving the leadership to our nation's next steps in increasing accessibility and addressing discrimination. Andrés Gallegos is the lawyer that has been at the forefront of many of the national efforts around legal approaches to disability rights and advocacy. And for his work, he's been acknowledged and honored throughout the world and throughout this country. But his appointment as chair of the National Council on Disabilities really created the possibility for him to take national action for health equity. Today was a day he had to be in the middle of his work and wasn't able to be with us on this special day. So we were able to record a conversation with him about his lead taking national action for health equity. So please join me in this pre-recorded session with our national chair of the Council on Disability.
Would by far be the largest and most welcoming. A community that is growing exponentially as we learn of the effects of long COVID. A community for which the National Council on Disability has proudly been its federal voice for the past 43 years. To say that it's been a difficult 25 months is an understatement. For the first time in our lifetime, the world has had to confront a health pandemic for which there was no immediate cure and had a high percentage of mortality. As of March 26, 2022, authorities in 220 countries and territories have reported over 479 million COVID-19 cases and over 6.1 million deaths since the first case was reported in China to the World Health Organization in December 2019. Here in the United States, according to Johns Hopkins University Center for System Science and Engineering, as of March 26th, there were over 79 million reported cases, which have resulted in over 976,000 deaths. We lead the world in reported cases and reported deaths. Hidden within those numbers, and not just in the United States, is the true number of deaths of people with disabilities. In general, people with disabilities were and are absent in virtually all public health surveillance. We know, however, that people with intellectual and developmental disabilities suffer the greatest among all people with disabilities as a result of the COVID-19 virus. People with IDD have a higher prevalence of specific comorbidities such as hypertension, heart disease, respiratory disease, and diabetes, which are identified as risk factors for poor outcomes from the COVID-19 virus. The pandemic has shown a light on the systemic deficiencies of public health systems across the world as it relates to addressing the fundamental healthcare needs of people with disabilities. And throughout the world, we've seen systemic marginalization and discrimination against persons with disabilities as reflected in these headlines. The COVID-19 Disability Rights Monitor Project, set up by 7 disability rights organizations, including International Disability Alliance and European Network on Independent Living, in October 2020 issued a report based on survey responses from more than 2,100 individuals and organizations in 134 countries. The report highlighted the denial of access to healthcare, including discrimination in triage, unaffordable medication, and the inability of people with disabilities to leave home to access essential healthcare and medication, as well as alarming testimonies that people with disabilities have been denied or deprived life-sustaining treatment for COVID-19 on the basis of disability, resulting in many preventable deaths. The pandemic has disproportionately affected the health and well-being of persons with disabilities, who, not because of disability per se, but due to underlying health conditions, are at a greater risk for contracting the virus, a higher risk of hospitalization once the virus is contracted, and a greater risk of dying from the virus. Persons with disabilities are vulnerable to the extreme effects of the virus given the decades of neglect in meaningfully addressing the chronic and profound health disparities between persons with disabilities and those without, and decades of neglect in addressing systemic and pervasive barriers to accessible healthcare. Achieving health equity is a civil rights struggle. Disability is a human rights issue, with people with disabilities being subject to multiple violations of their rights, including acts of violence, abuse, prejudice, and disrespect because of their disability. People with disabilities also face barriers, stigmatization, and discrimination when accessing health and health-related services, stemming from negative attitudes and beliefs of healthcare providers. Attitudes and beliefs that reflect societal views that persons with disabilities are precluded from obtaining health equity. And thus we must insist that discussions of health equity include persons with disabilities and to be deliberate in our work to achieve health equity for persons with disabilities. And those are the topics that I want to share with you this morning. First, a bit about who we are. The National Council on Disability has a proud history. First established as a small advisory council within the Department of Education in 1978, the National Council on Disability was transformed into an independent agency in 1984 and charged with reviewing all federal disability programs and policies. In 1986, NCD recommended the enactment of an Americans with Disabilities Act, and then drafted the first version of the bill introduced in the House and Senate in 1988. Since the enactment of the Americans with Disabilities Act in 1990, The National Council on Disability has continued to play a leading role in analyzing the needs of people with disabilities, crafting policy solutions, and advising our federal leaders. Today, our mission is to advise the President, his or her administration, Congress, and heads of federal agencies on all policy matters affecting people with disabilities in this country and in our territories. We are the smallest federal independent agency in all of government. The council is bipartisan. We consist of 9 council members, 5 are appointed by the President, and 1 each from minority and majority leaders of the House and the Senate. And the President appoints the chairman. On January 20, 2021, on the afternoon of his inauguration, I was humbled by President Biden, designated me as the chairman of the National Council on Disability. Like in many parts of the world, here in the United States, the fight for health equity for people with disabilities is very much a civil rights struggle. According to the Center for Disease Control and Prevention, health equity is achieved when every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. In this country, the potential for persons with disabilities has historically been dismissed by society as a result of both federally sanctioned and state-sanctioned dehumanization and discrimination. For example, in the late 1800s and early 1900s, eugenics, the practice of controlled selective breeding of human populations, which in many instances was done through forced sterilization, spread like wildfires in this country, as was the case through the rest of North America and Europe. Indiana was the first state to have such a law, and then 32 other states. It permitted the forced sterilization of confirmed imbeciles, idiots, and rapists in state institutions. It was intended to improve the genetic quality of the human race, determining who should and should not reproduce. Targeted were the crippled, the blind, the deaf, the dumb, the mute. 70,000 people deemed to be unfit for society were sterilized against their will. They were also forced to enter institutions and asylums. Many spent their entire lives there. The purification and segregation of persons with disabilities was considered merciful actions. It ultimately served to keep us invisible and hidden from a fearful and biased society. While eugenics ended here in 1963, remnants still exist today. A countless number of doctors refuse to provide women with disabilities reproduction counseling or birth control, believing either that persons with disabilities don't have sex or should not reproduce. Historically, we were considered meager, tragic, pitiful, unfit, unable to contribute to society, except we served as ridiculed objects of entertainment in circuses and exhibitions. In the mid-1800s, there existed in many US cities the ugly laws. Those laws were in place for just over 100 years, from the 1860s until the 1970s. They sanctioned state-sponsored discrimination of persons with disabilities. The first appearance of these laws was in 1867 in San Francisco. The laws, in essence, stated that if you're visibly disabled, get off the streets, stay out of public view. Chicago's law was the most infamous. Passed in 1911, the law stipulated as you see here. It made it illegal for us to be on the streets. When adjusted for inflation today, the monetary fine would be between $23 and $1,200. While defenders of this law state their main purpose was to keep people from begging in the streets, there's no mention of this in the ordinance. These laws shaped how the public viewed disability and conversely, how people with disabilities viewed themselves. These ugly laws were not repealed until the 1970s. Chicago was the last to repeal its ugly law in 1974. The struggle for civil rights and to achieve health equity for people with disabilities is not unlike the struggle for people of color in their fight to achieve equality. In 1963, the Medical Committee for Civil Rights, comprised of both Black and white doctors, was created specifically to attack the American Medical Association's policy of refusing to require its Southern members to integrate, thereby denying African American physicians hospital privileges throughout the Deep South. A group of doctors demonstrated on the Atlantic City Boardwalk at the American Medical Association's National Convention in 1963. It was probably the first public protest by doctors acting as a group. The Medical Committee for Civil Rights was trying to advance the premise that healthcare is a basic civil right. In the 1960s, racial segregation was a commonplace in United States hospitals. It took several forms. In the South, there were hospitals for white people and hospitals for Blacks. The latter only founded by Black physicians who could not obtain admitting privileges at white hospitals. Here, Black physicians were picketing in front of the American Medical Association building. When the Civil Rights Act was passed in 1964, it ended segregation in public places and banned employment discrimination on the basis of race, color, religion, sex, or national origin. It is considered one of the crowning legislative achievements of the civil rights movement. Missing from the protected categories, however, was disability. We were not even contemplated. It was not until 26 years later that it was our time. On July 26, 1990, President George H.W. Bush signed into law the Americans with Disabilities Act. Noting that a year earlier, the Berlin Wall came tumbling down, the president, as he signed the ADA, said, "Let the shameful wall of exclusion finally come tumbling down." The promise of equality of opportunity, full participation, independent living, and economic self-sufficiency for the then approximately 43 million persons with disabilities in the United States was cemented in writing. Its intent was to level the playing field for persons with disabilities who were ignored in all previous legislation securing the civil rights of Americans. While the walls of exclusion in many areas have come down, they have not done so in society's most vital area, healthcare. For today, in America, if you're a person with a physical, intellectual, or developmental disability, your life expectancy is less than half of that of someone without disabilities. You're at a higher risk for early onset of cardiovascular disease than those without disabilities. You're more than twice as likely to be obese. You're more than 3 times likely to have diabetes. You're significantly more likely to have unmet medical, dental, and prescription needs than those without disabilities. And if you're a woman with a disability, you are likely to receive poorer maternity care and less likely to have received a pap smear test or a mammogram than your non-disabled counterparts. And if you're an adult who's deaf or hard of hearing, you are 3 times as likely to report fair or poor health as compared to those who do not have hearing impairments. What accounts for this? People with disability encounter a range of barriers when they attempt to access healthcare, including physical barriers, communication barriers, and financial barriers. But as we've witnessed or experienced during the pandemic, the barrier resulting in fatal consequences is attitudinal barriers. People with disabilities commonly report experiences of prejudice, stigma, and discrimination by health service providers and other staff at healthcare facilities. The pandemic has unmasked the most extreme and deadly form of state-sanctioned ableism as seen by these headlines. Ableism manifested in discriminatory crisis standards of care, manifested in discriminatory rationing policies, standards and policies that in many instances categorically define people with disabilities as people whose lives are not worth treating, that categorically define whose lives are not worth vaccinating or vaccinating with any urgency. A pandemic that has given license to many healthcare professionals to publicly express their explicit bias against people with disabilities. As the number of cases mounted in hospitals were overwhelmed, Many states and healthcare systems implemented previously developed medical scarce resource allocation or rationing policies, commonly known as crisis standards of care. Those policies set forth triage criteria for healthcare providers, criteria to assess who would and who would not receive care, or used to determine priority of care. More often than not, those policies discriminated against people with disabilities. Guidelines put forth by Alabama, Kansas, New York, Pennsylvania, Tennessee, Utah, and Washington illegally discriminated against people with disabilities by adopting policies that based triage decisions on quality of life judgments, or policies that excluded patients with specific conditions. For instance, Alabama's now rescinded guidelines called for hospitals to withhold ventilators from patients with severe or profound mental retardation. Those are their words. And withheld ventilators from those with moderate to severe dementia. 25 states had similar provisions that take into account patients' expected lifespan, need for resources such as home oxygen, or specific diagnoses such as dementia. Some even permitted hospitals to take ventilators away from patients who were using them as breathing aids in everyday life to give them to someone else whose life was deemed more worthy. As a result of that, the National Council on Disability called upon the director of the Office of Civil Rights for the Department of Health and Human Services to issue immediate industry guidelines to remind healthcare systems and hospitals that their federal non-discrimination laws apply during times of the pandemic. Think about that for a minute. Guidelines had to be issued by a federal governmental agency to hospitals and healthcare systems throughout the country. Guidelines reminding them that their federal non-discrimination mandates still apply during public health emergencies. What does that say about us? Of course they apply. They especially apply during times of a healthcare crisis. In June 2020, people throughout the country were horrified as they listened to an audio recording between a physician and the spouse of a severely disabled man, Michael Hickson. Mr. Hickson was living with the effects of a spinal cord injury, cortical blindness, and an anoxic brain injury suddenly acquired in 2017 as a result of an acute cardiac arrest. At a hospital in Austin, Texas, he was denied treatment for urinary tract infection, sepsis, pneumonia, and suspected COVID-19, all conditions for which he was successfully treated at that hospital 3 months earlier. Upon admission to the emergency room, a modified early warning assessment for clinical deterioration indicated he had a 30% chance of mortality. His physicians, however, determined that his life was not worth treatment. In a legally recorded conversation between one of his physicians and Mr. Hickson's wife, a physician explicitly stated a preference to treat patients who can walk and talk. After 3 days of treatment, including administration of antibiotics, which laboratory results clearly indicated were effective, and after having identified the specific biological organism at the source of his infection, his medical team abruptly withdrew those antibiotics. They designated him as do not resuscitate and transferred him to hospice. Moreover, all life-sustaining treatment, including artificial nutrition and hydration, were withdrawn. For 6 days, Mr. Hickson laid in hospice, alone, dying. Alarming to the disability community was the fact that those decisions were made by Mr. Hickson's physicians in the normal course of business. Medical rationing and crisis standards of care did not factor into those decisions, as at the time, the hospital was not overwhelmed with COVID-19 cases. We know this as the hospital's chief medical officer stated so in a media release days after Mr. Hickson's demise. The story of Mr. Hickson is not a story in isolation. Throughout the country and the world, we've heard of similar stories, but none as egregious, blatant, or captured in an audio recording. Health Affairs published a study in February 2021 revealing that 82.4% of physicians in the United States nationwide believe that people with significant disabilities have a worse quality of life than non-disabled people. This is the latest contribution to a well-established body of literature acknowledging healthcare providers' implicit bias, attitudes, and beliefs contribute to inadequate or inappropriate clinical decisions and results in the failure to make appropriate recommendations for preventive care for minority and ethnic groups, as well as people with disabilities. In 2020, research published by the Council on Quality and Leadership analyzed the results of disability implicit attitude tests from just over 25,000 healthcare providers to reveal that the overwhelming majority were implicitly biased against people with disabilities. The study underscored that healthcare providers' beliefs and attitudes about social minorities and other marginalized groups are key factors that contribute both to healthcare access and outcome disparities. Those beliefs and attitudes directly influence behaviors and inpatient encounters, clinical decision-making, and referral care. That research underscores the words of Dr. Martin Luther King Jr. in 1966. It is for those reasons that we must not only in this country, but in all countries, be purposeful and deliberate in advancing health equity for people with disabilities. The right to attain good health is a universal human right recognized by the international community since 1948, yet it has remained elusive. Since 2009, the National Council on Disability has maintained that attaining and maintaining good health is important for everyone, but critically important for persons with disabilities. And it is truly the predicate to our ability to live, our ability to learn, and our ability to work and earn. In 2019, we released a series of reports in our bioethics series. The overarching theme was to address the continued devaluation of the lives of people with disabilities in medical decision-making. Negative biases and inaccurate assumptions about the quality of life of a person with disability are pervasive in the United States society. Those biases and incorrect assumptions result in the devaluation and the disparate treatment of people with disabilities. And in the medical context, these biases and assumptions can and do have serious and even deadly consequences. In this series of reports, we explored how people with disabilities are impacted by biases and assumptions in some of the most critical healthcare issues we face, including organ transplantation. People with disabilities are often denied equal access to organ transplants solely on the basis of their disability. This report examined the reasons for this and its impact. Additionally, the report explored how people with disabilities and their families can be pressured into organ donation. Physician-assisted suicide. This report provided an update to our previous analysis of state laws supporting physician-assisted suicide and examined the ineffectiveness of purported safeguards. Genetic testing. In this report, we examined the range of scientific, commercial, professional, and social factors that converge around prenatal genetic testing and their effects on the lives of people with disabilities. The report also provides an update on the interaction between genetic testing and employment discrimination. Continuing in our bioethics series, quality adjusted life years. Here we took a critical examination on the use of quality adjusted life years by insurance programs, including Medicaid, to determine the value of treatments and how the use of quality adjusted life years impacts people with disabilities and their access to care. We also released a report on medical futility, healthcare providers' subjective judgments about whether a patient's life is worth living, often influences their decisions regarding whether to withdraw or withhold medical care. This report examined multiple perspectives on medical futility decisions related to people with disabilities. It analyzed how state and federal laws can be strengthened to prevent disability bias from impacting critical health care decisions. In 2010, the Patient Protection and Affordable Care Act required the United States Access Board to develop standards for accessible medical diagnostic equipment. The act recognized the absence of accessible medical diagnostic equipment as a barrier to people with mobility disabilities' ability to obtain thorough examinations and treatments. That was and still is systemic and pervasive in just about every healthcare setting. The Access Board released its standards in 2017. The standards are merely voluntary until adopted by a federal agency of jurisdiction. Healthcare systems throughout the country have not voluntarily adopted the use of accessible medical diagnostic equipment. In our report on enforceable accessible medical equipment standards, we highlight the continuing need for accessible medical diagnostic equipment. As people with mobility disabilities who utilize mobility devices are still being discriminated against by receiving less than thorough examinations and treatments than those provided to patients who are not disabled. Our weight is hardly ever captured. We are consistently examined while we remain in our wheelchairs, even when it's clinically inappropriate to do so. Our report urges Department of Justice and Department of Health and Human Services, Office of Civil Rights, to promulgate regulations adopting these critically needed standards and adopting scoping requirements. In October 2021, we thoroughly examined the impact of the COVID-19 pandemic on people across all categories of disability, looking at disability discrimination in healthcare, the devastating impact of COVID-19 on people with disabilities in congregate care facilities, the impact on direct care workforce, how the pandemic affected students with disabilities, employment of people with disabilities before and after the pandemic, how people who are deaf and hard of hearing are affected by the pandemic, and the effect the pandemic has had on the mental health of people with disabilities. Last month, we unveiled a report examining Medicaid reimbursement rates for oral health care for people with intellectual and developmental disabilities. As you may know, as compared to other populations, adults and adolescents and children with intellectual and developmental disabilities experience poorer health and more difficulty in finding, getting to, and paying for appropriate health care. This disparity has made people with IDD more likely to have poor oral hygiene, periodontal disease, and untreated dental care in greater percentages than members of the general population. This disparity is created in part by insufficient Medicaid oral health reimbursement rates for people with IDD. In February last year, I issued my vision and priority statement during my tenure as chairman. Given the times that we live, our abiding focus had to be on healthcare, foremost all things COVID, and addressing the accessibility barriers to healthcare for people across all categories of disabilities. Also addressing social determinants of health, the factors historically underlying the extensive health disparities between people with disabilities and our non-disabled counterparts, as well as health equity. 1 out of every 4 people in this country and in our territories report having a disability. Disability, whether acquired at birth or over the course of one's lifetime, is a natural part of the human condition. The fact that significant health disparities between people with disabilities and our non-disabled counterparts have been known for decades, but not addressed, can no longer be tolerated. The fact that disability-based discrimination continues systemically and pervasively within our healthcare sector, with the support of federal funds, is alarming and should be of concern to all. Thus, we organized within the National Council on Disability a health equity subcommittee to develop a health equity framework for all people with disabilities, using in part the significant body of evidence contained in our bioethics series reports. To help guide us in the creation of this framework, we assembled 14 health equity and accessible healthcare experts across the country and across various medical disciplines. We also included a couple of prominent health law and disability rights attorneys. We refer to our advisors as our dream team. These are individuals who have dedicated most of their careers to the advancement of health equity for people with disabilities. We also consulted with national disability advocacy organizations to obtain their priorities and input. We met with the President's Domestic Policy Council and provided them with an overview of our framework. And we met with numerous offices of legislative jurisdiction over portions of our framework on Capitol Hill. Approximately 12 months after we commenced this effort, on February 14, 2022, Valentine's Day, we released our health equity framework, a 15-page document that contains 39 discrete components requiring a combination of administrative and legislative action, and calls for an all-of-government approach to achieve health equity for people with disabilities. Now, we know our framework and all of its components is a lot to digest. So we posed to our dream team, if we could only press hard and accomplish a few things initially, what would be the most important to start with? And unequivocally, those broad consensus that the elements we noted as our 4 foundational or core elements were the ones that would set the others into motion. They were the game changers, that if we could get them, those foundational components would set up the other components within the framework. The core components are, as you see here, designation of people with disabilities as special medically underserved population, accessible medical diagnostic equipment, improved data collection concerning healthcare for people with disabilities across the lifespan, and comprehensive disability clinical care curriculum. To achieve health equity for people with disabilities, it is critical that people with disabilities be legally identified as a special medically underserved population under the Public Health Service Act and gain the benefits associated with that designation. These benefits include federal funding for healthcare centers and public health infrastructure like federally qualified health centers, eligibility to apply for federal funding to develop and operate community health centers, access to loan repayment and training programs, including National Health Service Corps scholarships, incentives for physicians to treat the designated population in the form of higher CMS reimbursement rates for physician services, and preferences given to research at federal agencies, including the National Institutes of Health, that studies medically underserved populations, among other benefits. Our next foundational element is accessible medical diagnostic equipment. Here, we're looking for the Department of Justice and Department of Health and Human Services Office of Civil Rights to adopt as binding regulations the use of accessible medical diagnostic equipment. Standards for accessible medical diagnostic equipment were developed by the U.S. Access Board in 2017, pursuant to its mandate in the Affordable Care Act. These are standards that provide for height adjustable examination tables, examination chairs, and diagnostic equipment such as X-ray machines, MRI equipment, and many others. That is particularly critical for those of us with mobility disabilities that cannot independently transfer onto examination tables, examination chairs, and diagnostic equipment. And for those of us who cannot independently transfer, our lived experience has been that we get examined or treated while remaining in our wheelchairs, if at all. Enhanced data capturing is our third core component. Data matters because we greatly matter. Improving data collection is a vital part of achieving health equity for people with disabilities. With due consideration of privacy concerns, it is necessary that indicators of disability status be included in all public health surveillance systems. This must be done to assess the impact of public health threats and events on populations with disabilities, so that the effectiveness of planning and response can be assessed and improved upon. This data should be captured across individuals' lifespans and be inclusive of all ages and times of onset of disability. Healthcare organizations must also collect and record patients' disability status and needed accommodations within electronic healthcare records to plan and provide informed quality healthcare. Uniform disability identifiers must be included in electronic health records, death certificates, and insurance claims captured for all patients, even if treatment is sought is unrelated to the person's disability. Part of the lack of sufficient data concerning people with disabilities is the information gap overlooked by government agencies. Standardized disability identifiers are necessary across federal surveys. And finally, The last core component is comprehensive clinical care curricula training. There has been abundant studies that demonstrate that the overwhelming majority of medical school graduates do not feel confident in their knowledge and skills to treat patients with disabilities. This points to a lack of formal training, exposure, and clinical experience in training. And not just in medical schools, but in graduate residency training programs in all 24 medical specialties. Clearly, there is a need for standardized national core curriculum that at the earliest opportunity introduces the student to the skills needed to effectively communicate, understand, appreciate, treat, and even advocate for their patients with disabilities. We have experts with experience in creating such curricula, and to do so in conjunction with the disability community. We already have small pockets of progressive medical schools that have adopted this training. The curricula has to be comprehensive, meaning that it also has to include all aspects of medical care, and this truly has to be interdisciplinary. But it has to be mandated. It's too important and long overdue to leave it to the whims of medical curriculum committees that have dropped the ball in this area for over 30 years. We also have questions relating to the care of patients with disabilities appear on national certifying exams to emphasize that the profession sees this as mandatory and not as an elective. It is inconceivable that physicians can become board certified in all specialties without ever having seen a patient with a disability. We are now in the process of meeting with the administration, legislative offices, and agencies of jurisdiction to operationalize this blueprint. All of this can be implemented, and shame on us if it's not done on our watch. In closing, we must lend our voices to insist upon health equity for all people with disabilities throughout the world. For we know these four universal truths that belong to all people with disabilities, regardless of where they live. And that is that persons who are blind nevertheless have a vision for themselves and their families. Persons who are deaf nevertheless want to be heard. Persons who can't speak nevertheless have a voice. And persons with mobility disabilities nevertheless want to move forward. Accelerating health equity by design, by deliberateness, by purpose is incomplete if it does not include people with disabilities. Thank you so very much for having me.
Thank you so much for taking time and bringing this perspective to us. And I'm anxious that we at Global Minnesota in the broader community takes into deep consideration the way that our work, accelerating health equities by design, does include and always includes deeply all of society, in this case, in his dramatic and very powerful presentation. The way that we haven't done this with our disabilities community is no longer acceptable and should never have been, but now we have a chance to move forward. Later today at 2 o'clock Central Time, you'll hear from two people who transform the training of doctors at Mount Sinai Medical School, and their conscious work is something that can give some frame to some of the most important suggestions that Andrés has shared with us in his presentation. We're moving now to a speaker who was a central part of our World Health Day 2021. At that point in time, Dr. Margaret-Mary Wilson was the Chief Equity Officer at UnitedHealth Group. And in her role, she had been one of the key thinkers in how they could move a very large medical health-related institution towards contributing of closing disparity gaps and towards health equity. Her work has been very important, but in this last year, she has also become the Chief Medical Officer for the entire UnitedHealth Group. We were negotiated to try to find a time that might work for an in-person presentation. Today wasn't that day, but she was able to find time to talk with us in a recording about how they see their larger sphere adding to all of our discussions about Accelerating Health Equity by Design. Please roll the recording of Dr. Margaret-Mary Wilson, Chief Medical Officer, UnitedHealth Group.
My name is Dr. Margaret Wilson, and I serve as Chief Medical Officer for UnitedHealth Group. First of all, I would like to thank Global Minnesota for the opportunity to share a few comments at the World Health Day Symposium. As we are aware, the theme for World Health Day 2022 in Minnesota is Accelerating Health Equity by Design. At UnitedHealth Group, our mission is simply to help people live healthier lives and help make the healthcare system work better for everyone. And health equity is at the core of our mission. Health equity is achieved when everyone, regardless of status group, has the opportunity to achieve their healthiest life without any social, economic, or environmental barriers. And unfortunately, today there are still way too many barriers to good health that disproportionately impact historically marginalized groups. When we look at healthcare systems across the world, including the United States, many people continue to be adversely impacted every single day, sometimes even by death, not because we lack the knowledge to treat them or the science to treat them, but because inequities in the healthcare system create challenges to accessing good healthcare, they create resource constraints, and create affordability challenges. And the reality is that we cannot truly modernize or transform healthcare without a relentless focus on equity. And that calls for us to take both a systems-based approach and an individualized approach to dismantle systemic inequities. We often cite alarming statistics, such as more than half of rural counties in the United States do not have a hospital with obstetrics care. And Black women are 3 times as likely as white women to die from pregnancy-related complications. These statistics are very alarming, and they are very, very concerning. One thing we must realize, though, is that if we are within a healthcare system that allows for these disparities, what that implies is that our healthcare systems do not serve anyone adequately, regardless of the person's status, race, or geography. And so in order for us to address access, affordable, quality healthcare for everyone, it's important that we consciously build equity into the design of our healthcare system in order to address these disparities. And importantly, healthcare is not simply about clinical models of care, but it's also about taking a broad step back to ensure that we are adequately addressing social determinants of health. Because if you think about it, 80% of care is determined outside a doctor's office, in our communities, in our schools, and these days in our social networks. And many often say tongue-in-cheek that one's zip code may be just as important as one's genetic code when it comes to determining health outcomes and life expectancy. So things like poverty, air quality, climate change have an impact on our healthcare. If we don't have access to good food or don't have access to safe housing, all of these factors can adversely impact health. With reference to housing, that's one of the things we're addressing in UnitedHealth Group. Nearly 15 million Americans lack access to stable housing. And the financial burden of unaffordable housing often prevents families from accessing their health care, particularly when it relates to preventive care or just standard elective care. Over the past 10 years at UnitedHealth Group, we've made more than $500 million in investments in new affordable housing in an attempt to mitigate the impact of inadequate housing for people in underserved communities. We're taking the same approach when it comes to access, recognizing that there are populations in rural areas who may not have access to healthcare services, particularly mental health care. So one of the things we've done is fund telehealth equipment to bring specialty mental health care to rural areas in Kentucky. Similarly, in Texas, we're partnering with a maternal health organization to bring healthcare into the home for expectant and new mothers. We also recognize that it's important to build out the diversity of the workforce in order to serve the needs of underserved communities. And for 15 years, we've invested in programs across the country to broaden the diversity of the pipeline for healthcare professionals, including mental health specialists, nurse practitioners, and data scientists. Since 2017, for example, we've provided about $10 million to build out a more diverse health analytics and technology workforce. And we've attracted nearly 200 students from historic Black colleges and universities to a health informatics training program through partnerships with Atlanta University Center Consortium and the University of North Carolina at Chapel Hill. Similarly, we announced a $2 million three-year partnership with Harris-Stowe State University in St. Louis, Missouri, to create a bioinformatics program for undergraduate students. We also recognize that building healthy communities is integral to driving health equity. The United Healthcare Catalyst Program is a program that works with stakeholders within communities to leveraging our data to identify communities that have the greatest gaps. And we then partner with organizations in the community and stakeholders within the community to co-create solutions that are relevant to that community. The community catalyst work that we did in Akron, Ohio, led to improved mental health services for the African-American population who had previously accessed the emergency room for their ongoing mental health care needs, which was in no way the appropriate site of care to provide high-quality mental health care. And so far, leveraging the Community Catalyst Program, we've scaled this to about 22 communities across the country, with the potential to reach more than 1.5 million members. Maternal health is another area that where the health equity discussion continues. And what we saw in 2020, driven by the pandemic, was that the United States maternal mortality rates increased by almost 20%. And we saw the biggest increases in African Americans and Hispanic women, likely because of the job burden during that period and the fact that it was difficult for them to access care. So the way we are approaching maternal health through the lens of health equity is with an intentional multi-pronged approach. One area that we're focusing on is strengthening the infrastructure. So in that area, we're partnering with federally qualified healthcare centers in Washington, D.C., to help build out fiscally and operationally stable community-centered programs in a way that we can actually scale those programs to other federally qualified healthcare centers, thereby strengthening the support that we are able to provide to pregnant people. Similarly, in the maternal health space, we're attempting to reduce gaps in access to prenatal care. And recently, through a $3 million partnership over a period of 3 years with Canva, we are aiming to reduce gaps in access to prenatal care for high-risk women in public housing or in family shelters. And we're doing this by bringing care directly to them. So this program will deploy community health workers to deliver on-site support services, including health assessments, educational workshops, and screening. And we plan to reach about 500 women a year over a period of 3 years. And we're optimistic that our partnership with Canva will help significantly expand access to prenatal care and also thereby address infant and maternal morbidity rates in Brooklyn, New York. Another area where we feel that we're able to impact health disparities is by bringing care to the home and actually expanding access to virtual care. The historic model of delivering care, where we have been constrained by buildings, by brick and mortar, is no longer adequate, as we saw during the pandemic. So we must begin to think outside traditional care settings, and that's where virtual care models and in-home services become significant. Not only does it ease access for the person, it also improves the provider's ability to engage people in their natural home environment. And it increases connectedness, leveraging technology between the patient's providers, caregivers, and the person themselves. UnitedHealthcare's new virtual primary care service is helping expand virtual care to include a wide range of services, all the way from regular preventive care to actually managing people who are acutely sick at home or who may have chronic conditions. Our in-home clinical care model, leveraging our house calls programs, supports Medicare Advantage beneficiaries. And one of the things that occurs during our house calls visit is that the seniors now have access to an annual primary care visit that addresses their personal health care needs, identifies gaps in their care, and also helps close those gaps. We have seen a 99% satisfaction rate with this in-home care program. And 91% of our seniors who receive a visit actually are very open to a follow-up visit the next year. Overall, in 2021, our house calls program closed 2.1 million gaps in care, and we made over 300,000 social determinants of healthcare referrals, including about 158,000 for low-income support, another 85,000 for transportation needs, 37,000 were related to medication affordability, and 43,000 helped address challenges around food insecurity. We saw that during COVID-19, the House Calls program, which also provided virtual visits in addition to in-person visits, really took on meeting the unique needs of seniors during the pandemic. And we were able to take COVID care to seniors who were not able to access care. And this also supported our ability to vaccinate this population as well. Overall, the last 2 years have been really challenging. And I think universally, we witnessed threats to the sustainability of our healthcare system. But the last 2 years also provided valuable opportunities for learning and exchange of best practices, which has spurred healthcare systems in the United States and across the world to think very differently from the way we thought previously. We have witnessed and experienced things that hitherto we might have thought were impossible, such as leveraging telemedicine at the scale at which we're doing today, such as the speed with which we have been able to develop vaccinations and roll out vaccination programs in record-breaking time. This, in my mind, should be taken as evidence that healthcare modernization and transformation is critical, and we can do this. But at the core of this, in order for it to be successful, we must be willing to take on and understand the challenges and address the gaps that are posed by health disparities and health inequities. At UnitedHealthcare, part of the way we do this is by reframing the way we think about health. We call it health, but what we're actually talking about is wellness. What we're talking about is well-being. And what we're actually talking about is simply life itself. It's about the whole person. It's about each and every person, regardless of status group, addressing the unique gaps that we find with attention to mitigating the risk that are posed by disparities. That, we believe, is our mission, helping people, regardless of who they may be, live healthier lives and helping the healthcare system work better for everyone. Thank you.
Thank you, Dr. Wilson. Thank you for putting it on the line and putting it out there. This is about everyone. It's about life. It's about wellness and well-being, and having health as one of the words and the framework. But it's so inspiring to understand both the size of the challenge that UnitedHealth Group and those of your colleagues, but those that you work with everywhere, historically Black colleges and others, but also that reframing and giving us that by design feature is what we're trying to bring forth today. And our next guest is one of those special individuals who happens to be here in Minnesota this month, teaching at one of our universities, teaching at St. John's and St. Ben's about conflict resolution. He comes to us from South Africa, where he is part of a team of journalists for human rights who's been tackling the media and getting the media mobilized to address the disinformation and misinformation in the social media world around COVID-19. Madiba Mandela is a journalist, an activist, a leader, and he is with us today because he is in Minnesota teaching for this period of time. And I want to ask Dr. Mandela to join me on the screen and give him again my greatest welcome to Minnesota. And thank you for making this time today. Great to have you on.
Thank you very much, Rich. I really appreciate this opportunity to join you and the audience and the experts in this platform to deliberate on issues of health, particularly from East and Southern African perspective, and to share some of the work that we've been doing around combating misinformation and disinformation as it relates to COVID-19 pandemic in the African continent. So
thank you. And many of the speakers today have come back and said, really, ultimately, this is about human rights. You start from that perspective in the front end of your work. Tell us some about the Journalists for Human Rights and the specific way that you are tackling this part of the health inequity, the mis and disinformation around COVID.
Okay. Well, Journalists for Human Rights, through its project Mobilizing Media Fighting COVID-19, it was a project that was designed as a result of the impact of the pandemic on human rights itself, particularly the rights of women and girls. So we sought to train and capacitate journalists on how to report on human rights issues, on particularly as it pertains to health issues and how the pandemic has affected health issues and human rights, particularly the rights of women and girls. What we have noticed here, Rich, is that at the receiving end of the injustices that came as a result of the pandemic were women and girls. We saw in East and Southern Africa, where I am currently heading the project for Jayshree, and also my similar results in West Africa and even in North Africa. We saw a tendency where there was so much focus on the pandemic itself and neglecting other health crises and other health issues. For instance, if you're talking about immunization and vaccination of children against diseases such as polio, for instance, if you're talking about the intervention on HIV and AIDS that has seemed to be forgotten, and the whole focus has been shifted into the pandemic itself and dealing with how to combat the pandemic, while the rest of other health crises, which oftentimes are so prevalent within the African continent. If you're talking, for instance, about issues of in South Sudan, we're dealing with issues of polio, for instance, we're dealing with issues of typhoid, we're dealing with issues of malaria, and how people that would ordinarily be having access to such vaccinations or immunization, we're now finding it difficult to have access to that. And therefore, it sparked a new crisis, health crisis in those particular regions. In other regions, we're looking at how the COVID-19 health crisis has affected human rights more broadly, looking at how in South Africa, for instance, we saw a rise of gender-based violence, women being heavily affected by the pandemic. I mean, from between November up until December last year, over 12,000 women were raped in South Africa. You know, they fell victims of gender-based violence. We saw in countries, for instance, like Kenya and Tanzania, where we had the rise in high levels of teenage pregnancy, which resulted to a lot of young girls being denied the right to access to education, because in such context, if you are pregnant as a young girl, you're automatically excluded from the systems of from accessing doors of education or institutions of higher learning, so to speak. So those are some of the challenges that we have observed as a result of the pandemic. Now, if you are going to even deeper and looking at vulnerable groups such as those who are living with HIV and AIDS, we're now finding it difficult to have access to life-saving medication that seeks to mitigate the challenges of HIV and AIDS that are presented to them. Now they're finding it difficult to have access to such life-saving medical intervention, for instance. And even deeper now, if you're talking about the intervention in combating the pandemic itself, now talking about the vaccine apartheid, for instance, where most African countries at the beginning, particularly in 2020 and in 2021, were finding it difficult to have access to various vaccines that were established to combat the pandemic itself, and finding the difficulties, even when that particular vaccine has landed within the African continent, finding difficulties on, first and foremost, how do we store such a vaccine? And how do we distribute? You would understand some of the difficulties in distribution networks within the African continent. So if, for instance, you are saying that the vaccine must be developed in South Africa and distributed in the rest of the African countries, most of these countries, such as South Sudan, where I was working during the pandemic in 2020, they do not even have storage facilities. And the environmental and climatological conditions do not even allow such vaccines to be stored within a day. They had to be used within 30 days because it's extremely hot conditions, around 40 degrees Celsius each and every other day. And there are no proper infrastructure in place to store and also redistribute such vaccines. So we had such challenges, not only vaccine apartheid or the access to vaccine being blocked by many European and Western countries. We also have challenges of our own, structural challenges of our own, and we also had healthcare systems that were not prepared and to receive some of the victims of high volumes of patients that were coming into hospitals that were not better equipped and better prepared to handle such volumes. We saw in quite a number of countries where the healthcare system was at the brink of collapse, and in some spaces it even collapsed. For instance, in South Sudan, we only had 4 hospitals there, and only 2 had access to oxygen, and to service a population of 12 million people with only 4 hospitals. You can imagine some of the structural challenges insofar as health is compounded by the difficulties that we had in accessing such vaccines as well. So those are some of the challenges that Journalists for Human Rights was now trying to address by training journalists how to report on human rights issues, on health journalism. And by reporting on such issues, we are informing the communities and mobilizing them to bring government into the table, for that government, both domestically and on a continental point of view, can be able to design intervention or mitigating approaches to try and address the issues that we were experiencing and that we're still experiencing within the African continent insofar as access to health and healthcare is concerned in the country.
I'm hearing the echo from some of our earlier presentations about the necessity of informing the broader community. Sometimes we just maybe assume people know, but we know that media can be both educational, but it can be a pressure tool. It can be an organizing vehicle. And we're seeing this, especially now in the middle of this war, the media has this central role. Now, I understand that particular project has some support from Global Canada. The first year was a success, and that gave life to the second phase. Tell us a little bit just about the history of how that project came to be and where it feels like it's moving ahead in this human rights work.
Okay. Well, that project, of course, it's supported by Global Affairs Canada, and Journalists for Human Rights. It's one of Canada's leading international development organizations. And the project came as a response to what was observed as a second pandemic, which is infodemic. Infodemic is the over-access of information, both correct and incorrect. So how do you deal with addressing misinformation as it as a result of the pandemic itself. For instance, if you're talking about the African continent, there was a lot of mis and disinformation around the pandemic itself. There was many who believed that this, in fact, is just a Western disease. There were many conspiracy theories that came as a result of how do we respond to this pandemic. I remember in South Sudan, for instance, there were stories that because the country comes from a very Arab kind of influence, where there's too much of drinking of tea. And there was this belief that actually, if we drink tea with lemon, you can actually cure the coronavirus itself. So a lot of people now, we started seeing the tea stalls, a boom in the tea stalls, the majority of people rushing for tea, seeing the rising prices of lemon itself, because it was now being used as sought after product to say, this is the way we can cure this pandemic. And many were saying, no, hold on a second, because it's too hot in South Sudan, this disease will actually melt as it hits the surfaces, in all the geographical areas in South Sudan, for instance. So we had to first and foremost educate, use the media as a platform and the medium by which we educate our people, collaborating with health departments in the countries that we work in on how to create educational information that will be easily accessible to the people in those locations where we work. Particularly, language then becomes of critical importance, because if you can translate those health information from World Health Organization and from the national health institutions within those countries, and you translate them into the language that the people can best understand, then you are able to mitigate the challenge of mis and disinformation, for instance. In other environments, we're dealing with different issues where people would say, actually, there are traditional ways that we can exploit to mitigate or to cure this disease, this pandemic, coronavirus, for instance. And many of these interventions would end up actually exacerbating and causing more damage, and with a lot of victims of COVID-19 ending up landing into hospitals, and the hospital sector was now becoming overwhelmed, because now people have tried to be creative, and they have subscribed into these new indigenous forms of knowledge insofar as mitigating from a health perspective into this pandemic. So you have to deal with those particular issues, and you also have to deal now with the conspiracy theories that says, no, actually, there's no such thing as coronavirus. This is just a conspiracy theory to try and lock us up as the people, and all these COVID-19 measures that are being implemented by government is just a mere way of trying to violate the rights of the people on the ground as well. So you have to work with that. You have to deal with breaking down those barriers, so that people can have access. We were moving under the banner of information saves lives, for instance, in trying to find ways to assist in communicating the healthcare measures and educating our people about this disease. And now it even got worse when it comes to the vaccine itself, because there were also many conspiracy theories around the vaccine itself. There's a lot of resistance, people refusing to take up the vaccine. And those are some of the issues that we're still dealing with to this day in time. And now, within the project at this point in time, we are looking at how to educate our people on issues of vaccine, and firstly, give them basic understanding of what vaccines are and how vaccines work, and break down those barriers of misinformation in certain environments. They would say, if you take the vaccine, you are going to turn into a zombie. Or if you take a vaccine, you might not be able to make babies, for instance, as men. So we started seeing men staying away from the vaccination process, refusing to be vaccinated. So how do we then deal with such? Is to create systems and do trainings and train the media sector that is at the center of communicating and informing our communities about the issues that affects them. And one way of doing that is to capacitate them, train them, so that they can communicate more effectively around issues of health within communities. And within the African continent, we barely had such things as health journalists, for instance, or health journalism. You know, we just have general journalists that report on virus issues within society, but there were never journalists that was particularly and specifically reporting on health issues. Now we're having to intervene and start training journalists that are going to be able to communicate more effectively and impactfully health-related measures and communicate to our people and inform our people about the pandemic itself, inform our people about how it behaves, different strands of this virus, and also the intervention levels or mitigating strategies that have been employed locally and internationally insofar as vaccines are concerned as well.
Well, it's interesting, of course, to hear and think about the parallels with our own situation inside the United States, but also in other countries. The conspiracy theories, the misinformation, all of the different, fears. There is a similarity, but also it seems like there are lessons that you are learning that we could learn from. There's a way of putting the notion that this is a human rights question, and your very deep and wide description of those various things, especially on women and girls, the domestic violence, the rapes, the teen, all of those different kind of ultimately human rights violation, seems like a framework also for looking ahead for transformation of the system. You were describing the extra burden for people with HIV/AIDS, the extra burden of underlying conditions. Are you seeing that your work, which has this immediate focus in the pandemic, vaccines, myths and disinformation, all of that, can you see some elements that when you do reach and mobilize the community to put their voice into this, that it can be transformational for the system at large, in addition to the specific COVID-related parts of the system?
Yes, definitely. And for instance, one way in which we managed to achieve that was to first and foremost get our governments in the countries that work in to identify any crisis, particularly in the context of the pandemic. The health crisis, it's a human right crisis, because this is more like some kind of a domino effect. People are affected by issues of health, which have a ripple effect on the rest of other issues within the communities. For instance, when you implemented lockdowns and you use measures such as curfews, for instance, it had a ripple effect on the other broader issues within communities, where now we're beginning to see, because people are forced to be indoors, we're beginning to see the rising levels of gender-based violence, which is a human right issue, particularly as it pertains to the rights of women and girls. We now started to see the rise in teenage pregnancy, because now kids were no longer at school, they were roaming within communities, and they were exposed to things that ordinarily when they were in school, they were not going to be exposed to, and we're now seeing this rising number of teenage pregnancy, young girls at 12 years old who are being pregnant and automatically excluded from the education system. Then that, as much as it is a health issue, it is a human rights issue, because now we need to have mitigating approaches that seeks to educate the young girl about issues around abstinence, issues around safe sex, for instance, which is also a human rights issue. If you would understand that it's not only teenage pregnancy that is going to arise, the rates are not going to be rising. Also, you're going to have HIV, going up as well, because now government is not focusing on prevention, is focusing on attending only at the pandemic itself, while neglecting the rest of other communal health crises. So you had now a disjuncture and a lack of balance. So the intervention that we've made, it helped to put things into perspective for government to say, actually, there's so much that we can achieve if we take a holistic approach into fighting the pandemic, making sure that we address women issues, girls issues, we address other health crises at the same time while we are responding to the pandemic. And we started seeing the new emergence and a close link between civil society organizations, which are at the center of fighting a lot of these health crises in our communities, joining hands with the government institutions and establishing long-lasting relationships and mitigating approaches that would last even way beyond the pandemic itself. For instance, we started seeing a reprioritization and reinvestment redirected into investing into the healthcare system, which previously was not the case in many of these countries. As I've indicated, for instance, in South Sudan, we only had about 4 hospitals and only 2 had access to oxygen. And now we started seeing a refocus into reconstructing and strengthening the healthcare system in such countries such as South Sudan and the rest of East and Southern African countries, including South Africa as well. We now started seeing institutions being built, where, for instance, South Africa was identified as a country where we can establish platforms and institutions where we can create or be allowed to create our own vaccine and redistribute that to the rest of the African continent. Before the pandemic, there were no discussions around that, for instance. There were no discussion around building institutions of health for the African continent itself so that they can be able to respond promptly to healthcare crises as they might emerge in the present and in the future as well. And we also had to learn from some of the successes in West Africa, for instance, in countries such as Sierra Leone, on how successfully they managed to deal with Ebola and how we can use such systems and emulate them to address some of the challenges that we're experiencing as a result of the COVID-19 pandemic. So I think that is also one of the most critical points to raise here.
Yes, it's so important you're making this larger picture, learning from what other people are doing. The example of Sierra Leone, I know for us, even in Minnesota, because we have such large diaspora populations from East and West Africa, those stories and the importance of those successes, the Ebola in particular, and the links of that to things like the various programs that were investments like PEPFAR that were HIV/AIDS initially, then having a much longer term positive impact on public health. But I'm thinking now about some of the hopeful sides, some of the steps towards peace in Yemen and Tigray and South Sudan, and some of the, we're at a moment where we're mixing in climate and COVID and conflicts and war and refugees. We seem to be having so many things simultaneously, but we also are able to tap those positive examples that you're describing and to mobilize the media so that the larger community can see hopeful signs and can see progress and taking their new hope, turning it into pressure and communication with governments. I love the fact that you've been able to connect this in each instance to that larger human rights agenda. You mentioned some of the more recent, I would say you used the word, it was a new discussion about localization of production of vaccines or ventilators or, the things that are necessary in this pandemic, but we know they're necessary because there'll be more pandemics. Would you like to talk a little bit about the kind of journalists who are thinking about the immediate and those big picture? Are they special in a way? Are there young people or others who are coming into journalism with this kind of big picture and attention to detail?
Well, what we have observed, Rich, with the success of our phase 1 of the project, which was implemented in about 12 countries within Africa and the Middle East, one of the things that we've picked up is, as much as we are now reporting on these issues and journalists are fully engaged on human rights issues and reporting on health as well, and how the pandemic has affected human rights in general, we also now, even ourselves, were challenged to say, we cannot only report, and spark conversation within communities about these issues and lobbying government, but we need to take it as a little bit step further and think into the future. And how we do that is to now change the curriculum of our trainings to say, let's not only train them on human rights reporting, gender sensitive reporting, mis and disinformation, and train them on human rights in general, or health journalism. Let's talk about solutions journalism. Let's talk about the kind of journalism that is not going to talk about the issues that confront our communities, but also offer solutions to government, to civil society organization, solutions that civil society organization can take up and run with their engagement with stakeholders and government to say, here are the solutions that have been provided. How about implement them to address the problems in our present and the problems that we might confront into the future? So that is what is also the focus of this phase, is on solutions journalism. If we're talking about broadly on issues of human rights and reporting on such issues, we must also be able to be in a position where we propose to office barriers, institutions of governance, to say, these are the ways in which we can mitigate into these issues, and not only talk about problems, but bring about producing solutions to the problems that we're experiencing in our community. So that's the approach that we are taking now in thinking forward to say, we're not only bringing these issues into the table, but we're also offering solutions that we have that we've co-created with local organizations that we work with, who fully and best understand the contexts and the problems that they are facing within the communities that they live in. When we co-create these programs and solutions and intervention strategies, then we are able to get a buy-in of the people on the ground, and it's easy to also get the buy-in from the institutions of government and office barriers, because these are solutions that have been co-created with the communities that we work in.
It's so exciting to hear this vision of the solutions and moving ahead. And of course, whether you're discussing climate or whatever, the hope married to solutions and possibility, and the co-creation becomes then the agency that people can feel. And this is especially important at this moment. 22 years ago, your grandfather came here as president of South Africa on a very cold February night, perhaps hard to imagine a bit. But he gave this amazing speech, which in fact is on our public television, but it was a speech about some gratitude, because there was such connection here to the anti-apartheid movement and that. But it was a speech about the necessity of all of humanity working together. And he closed it with a benediction. He said that we collectively as humanity progress to a world where race, gender, and other social markers of our rich diversity no longer serve to mark a person's station in life. And he went on to say that together we can create that future. It's such a thrill to have you here today, and for us to see and hear about ways that we as a humanity can work together. You coming here and sharing and teaching us this course I know you're doing on the civility and conflict resolution. These are the things that South Sudan has been challenged, and you've been part of that. We can see this in our own society. But I'm thrilled that you're going to be here for a few more weeks, that we'll have some other opportunities to have a bigger discussion. And our next panelists will be talking about some actual experiences of the creation, the co-creation, the creation of those necessary health tools and procedures and things like ventilators that are exactly in line with that positive vision of the future that you've been sharing. We're out of our time, but I want to ask you to give us some closing words that people can take the inspiration you provided and keep them going, being part of this co-creation across long distances and with our neighbors that you're pushing forward in your work on the human rights of this work in Africa.
Thank you very much. Thank you very much, Mark. And I am, in fact, today, it's one of the biggest days where I will be speaking on delivering a keynote address on a public lecture, which is a platform created by McCarthy Center for Public Policy and Civil Engagement. We'll be speaking at the College of St. Benedict at 6 p.m. In this public lecture, I would actually be revisiting the words of Nelson Mandela 22 years ago. And what would be surprising is that the issues of social injustice, the issues around racism, the issues around the need to build bridges between our communities in order to collectively fight the forms of injustices that we are fighting today. These are the same issues that Nelson Mandela in the NAACP address that he made in 2000, he was speaking exactly on those very same issues. Imagine that 22 years later, I am in Minnesota to talk about that very same issues that Nelson Mandela and his generation were talking about 22 years later ago. And the same year, Angela Davis was in the same institution, in the same campus where I will be speaking at today, talking about the very same issues of social injustice, human rights violation, systemic racism. So I will be actually asking people to take a moment and pause and ask ourselves, what is wrong and what will it take for us to be able to come together as one human race? What will it take for Black people to be able to enjoy equal human rights as the rest of the races that live here in the United States, in South Africa, and in other parts of the world? What will it take until the people of Palestine are freed from the injustices of Israel apartheid? These are the same issues that Nelson Mandela spoke about 22 years ago when he was making this speech of gratitude. He was touching to key pertinent issues that today we are still dealing with. So I'll be posing so many questions as what will it take until we achieve the dreams and some of the ideals that generations were talking about 22 years ago, that generation of Martin Luther King, Malcolm X, Rosa Parks were talking about 50 years ago. These are the very same issues. And I'll be asking my generation to say, do we want to allow ourselves to be, and our future to be tainted by some of the choices that were made by the past generation? The systems of racism were gifted to us, by the past generation. These were the decisions that were made by the past generation. Do we want to continue and live in such an environment where I am judged on the basis of the color of my skin, not on the basis of the content of my character? Do I want to live in society where the resources of the country, where the administration of law and order is skewed along racial lines, where majority of Black people and people of color are still oppressed with the systems of justice, such as the police and the justice system in America, which is skewed along racial lines? Do we want to live in that society, or do we want to bring about the change and an end to such forms of systemic injustice? So those are some of the questions that I will be posing as I make my address to the public lecture, which will be held at the College of St. Benedict later today. If the colleagues are able to come, I welcome you and I extend the invitation for you to come. I'm sure there's going to be a virtual link as well if you connect with the Eugene J. McCarthy Center for Public Policy and Civil Engagement. They would be able to provide you with the link so that you can, if you can't come this side, you can be able to join us visually as we engage and talk about our present and our future as this generation. For we have a choice to make.
Thank you so much for bringing that message. Tonight will be a very special occasion. You've placed it in such a historic context. And I know it will be well recorded and available for many, many, many years to come. And watching perhaps your talk tonight and your grandfather's talk 22 years ago alongside of each other might be one way to think forward about what's possible. Thank you for inspiring us. Thank you for joining us. And I look forward to seeing you tonight, but also seeing you again at some other events. Goodbye now.
Thank you very much, Mark. Appreciate it. And thank you to the audience for coming in.
Our next guests are two very special people who approach life, some by their early training in engineering, civil engineering in one case and electrical engineering in the other. But their lives have moved forward in many different ways. And we are pleased to have them together because they've been finding ways to bring elements of the global into the local to address our theme today of accelerating that health equity by design. Niousha Roshani is the co-founder of Global Black Youth. It's an organization that I learned about a few years ago because they were doing seminars that were based about bringing local solutions to COVID-related problems and other health problems. And the young people who were inventing, the entrepreneurs who were bringing these new inventions into the world were incredible. And I was learning so much. And she then went on in that work to found the Global Black Entrepreneurship ecosystem. But that work has taken her into many, many different opportunities to partner and to bring about this new global awareness and to put it into the context of how we solve these problems together to address inequity. And she recently began working with an engineer, a designer, an entrepreneur in Panama. Rolando Gittens is a person who trained in Panama and at the Technology University there, but also at the Georgia Institute of Technology, by the way, which is where our Dean Botchwey came from after leading that for the last 10 years. And he's been working on the development of products, health-related, COVID-related, things like ventilators and others that are locally designed, locally produced, that meet the local need, but bringing a thought process about how we have to work together as we move ahead to address these issues that are systemic, particularly systemic racism and inequity issues, together with the human right to health and healthcare and wellness. I want to thank Niousha and Rolando for joining us and ask you to come join me on the screen here. And welcome to both of you. I know in busy lives, getting us all together at this moment has been a miracle of its own, but we are thrilled to have you here. And please, Niousha, maybe give us a little background on how your work has evolved into this partnership with Rolando, and then we'll move and hear a little bit more about some of the things happening on the ground right now.
Thank you very much, Mark. Mark, you've always been such a strong advocate for highlighting, especially innovators around the world who are often overlooked and are a missed opportunity for our global knowledge. So thank you for inviting me on this panel once more. And throughout my travels, I'm quite a nomad, as you know, but I'm very passionate about discovering. I think nothing makes me happier than meeting innovators who come up with such fantastic solutions, but that are not unfortunately shared with the rest of the world. So one of my strongest passion is how is it that I'm able to connect and build bridges between them and other opportunities, but also other centers of knowledge, so I can highlight the work that they're doing and we can benefit more from their knowledge on a global scale. So I came to meet Rolando at we launched, so from Global Black Youth, where you took part, where we were trying to move the discussion beyond looking at how the pandemic was impacting Black population on a global scale disproportionately and always as a negative effect. We wanted to shift the conversation and say, wait, it is doing this, but young Black people around the world are not just sitting around passively, just living the consequences. They're innovating, right? They've been innovating for many, many years, but they're innovating even more during the pandemic, and really trying to find solutions that can mitigate a lot of the harms, not just in their communities, but that can provide solutions to our global society. So, we held these 3 seminars as a lunch, and it picked up, a lot of interest around the world. But we realized that one of the things that was also missing was as there's innovation sprouting around the world, and that's just a part of human nature, you need to invest in that innovation. And as we all know, Black entrepreneurs and Black innovators get a fraction of the investment that goes into founders on a global scale. So even in the US, for example, in 2021, the investments that went into Black founders was increased 4-fold, but it's still less than 1.5%. And that's even less into Black female founders. So those numbers are not even, sadder and very grim in other parts of the world, right? Especially looking at Black population in Latin America. Looking at, for example, Brazil, that has the second largest Black population in the world after Nigeria. But yet, in terms of investment that goes into Black founders, it's very, very grim. And it's very sad because and I'll come to discuss some of the fantastic innovators in Brazil, which I am at the moment. But on the continent, on the African continent, one thing that's been really interesting, just looking at, for example, in 2020 alone, you had more than 40 health tech startups on the continent that receive funding, Series A funding, which is quite, impressive. And these innovation in health and sciences have been going on for quite some time. But I think that one thing that's missing is really that connection, right? So what's happening in the continent, connecting to what's happening in other parts of the world, so then they can help each other and benefit from each other's innovation. So coming to this, when I went to Panama, and we decided that, what's missing basically in the rest of Latin America, beyond Brazil, is really, there's no accelerator or incubator in the rest of Latin America for Black entrepreneurs, which doesn't make sense, right? You're thinking we're in 2022, how is that possible? Looking at, for example, Panama, that has over 50% of its population that's Black, right? Colombia has, nearly 25% of the population that's Black. So how is it that we're missing out on tapping in the knowledge that, young Black people are producing in these regions? So, coming to this, with one of my fantastic colleagues, I told her, what about we launch, the Black Entrepreneurs Club? So the Black Entrepreneurs Club is really about connecting the Black entrepreneurs, entrepreneurship ecosystems around the world. So they're not just working and operating in isolation to each other, but connecting them so we have a global understanding of what's happening, who are the innovators, where are they, at what stage are they, what sector are they, and how can we support them better? And really reroute, the pipeline of opportunities to these young entrepreneurs, but also thinking about disrupting the grim stats. Like, I'm tired of hearing of 0.2% and 1.4%. I'm like, why are we still there, right? So in that, I was, lucky enough to meet Rolando, who was in Panama. And when I heard of the work that he was doing, I thought, wow, this is fantastic, because I've been working really on finding these innovators in Brazil, and I'll come to discuss a couple that I would like to highlight on this panel. But had I not gone to Panama physically, right? Had I not been in touch through my colleague with organizing this event, I would have never met Rolando. Rolando would not be, probably, I'm not saying that, but would not be here on this panel and sharing the fantastic work that he does. So one of the things that we have to understand, is really like, we have to have an understanding what's happening around the world, and there's a lack of mapping out the young Black innovators who are coming up with these really important solutions that we don't know of, that even, that knowledge sits with me and sits some with Rolando and some with some of my other colleagues, but we need to consolidate all the information onto one space. And this is one of the things that the project that we're working on at the moment. So then we can say, where we can go for this event, for example, or any kind of like solution that we need in health and sciences, like, we have it. Here are the people that you can support, that you can think of, you can harness their knowledge and utilize it, for a global society. But besides this, one of the things I just wanted to highlight as well is that we have to make sure that, so not just beyond, moving from the usual suspects, right? So even on the continent, the African continent, the large majority of funding, goes to South Africa, Kenya, Nigeria, and some Rwanda. But, we have to look into, for example, other countries, especially non-Anglophone countries. And this is why we decided to launch this initiative in Panama, because we realized that a lot of this innovation and the funding, the investment goes into English-speaking countries, but leave out a large majority of the world as well who doesn't speak, who don't speak English. So what about in Panama? What about in Colombia? What is happening over there that we're not tapping into? Or what is happening in Senegal that we don't know of, right? Or we know very little of. So that's something that's really important that we have to think about. And then finally, one thing I just wanted to say is that innovation, health, and sciences cannot go in isolation, right? Cannot operate and succeed and thrive in isolation to other types of innovation. So that's really important that we think about this. And I know we need to think about not just infrastructure, so energy and access to reliable internet connection, as we know. Some of us know, data is the most expensive on the African continent. So thinking about innovation is innovation for whom have access to the internet, connection to information online, so they're able to develop their ideas and then, find out new other sources, educate and inform themselves. But also looking into how other types of innovation complements innovation, health, and sciences, whether it's biotech, ed tech, or ICT-based education, knowledge. And what Siyabulela was saying is really important, that we also address health misinformation and disinformation. How is that linked to thinking about how, as an impediment to the growth of innovation, health, and sciences in certain parts of the world? So, and just without any further, I just want to make sure that I'll let my fantastic colleague, share his thoughts as well. So thank you very much. Great, thank you. Rolando, welcome.
Thank you. Thank you very much, Mark and Niousha. This is a wonderful opportunity to share. And, I would like to start saying that, definitely relationship building and connections, like when I was able to meet Niousha, are definitely key to basically bring visibility to some of the work that a lot of amazing people are doing, and also to continue moving forward, because the reality is that for Panama, at least, a relatively small country, developing country, and in the field that I work with, I'm a research engineer in a national research laboratory here in Panama called INDICASAT. And, like many, if not most of the researchers down here in Panama, I studied in the United States with a scholarship from the government. So our governments have been trying to invest in science and technology, sending a lot of people outside of the country to study in the best universities in the world, and trying to bring some of that knowledge back to try to develop and try to create new things that can help the population. But the reality is that we still invest very little money in the science, technology, and innovation system. Panama is investing probably less than 0.2% of its GDP into these topics. And so that creates a problem of, you have very limited resources. You dedicate those resources to, forming people, basically training them. But then when they come back, they don't really have all the tools necessary to get that research or get that innovation to have an impact in society. Because that last kilometer, it feels like 100 kilometers, is very complex, right? So I think that that's been one of the experiences that we've had since the pandemic started. Honestly, Panama was in a very tough situation, like many other countries, in terms of access to a lot of medicines, medical supplies, and medical devices that were needed to treat people. And I think that, as it's been shown in the past, crises and critical situations can push countries and people to think differently. And I think that this was beautifully explained in the last conversation you were having with Mr. Mandela, how journalists are having to reprioritize and what they should be focusing on. And I think that we went through a little bit of that here in Panama, or at least in our institution in INDICASAT, in terms of how we could be of service to the country response during the pandemic. And so basically, most of our research had to stop. Panama was one of the countries that established very strict mobility restrictions during the pandemic to try to contain the virus. And so all our laboratory research had to stop. But immediately we were looking for ways to put our laboratory, our highly skilled human resource to the service of the country. And what ended up happening is that for the first time for me, at least in the 9 years that I've been back since I did my PhD, is that government, academia and industry were ready to put the resources that they had. I mean, there was no money involved, but everybody put their time, their resources and species so that we could push forward amazing projects like the construction or the development of locally manufactured emergency mechanical ventilators, which for the experiences that we've had in the past here in Panama, we had never gone to do applied research into a medical device that went all the way into in vivo studies in animals. And so we were able to do that in a matter of 3 to 4 months, which was unbelievable considering the fact that we had no past experience doing that. And that's just one example. I mean, there were plenty of examples of the basically the OTC community, the community that works with 3D printers and building things, with cheap materials or cheap equipment, and basically immediately start producing at the national level face shields and masks and any other devices that were needed to try to protect the population. And everything was done with this one objective of trying to help save lives. And I think that that's what you could see happening throughout the region, because at least for these projects related to mechanical ventilators, immediately we started hearing about engineers and scientific communities from the different Latin American countries trying to do similar things, and very quickly using technology to connect and be able to share this information, share best practices, and share the fastest way to reach to a viable product that could have impact in society. And so, we were able to take advantage of all that knowledge and then try to implement that in a way that could be useful for society. In the case of mechanical ventilators, at least Panama didn't have to use them because luckily we didn't run out of them. But then I will give you an example of another product that didn't get that much attention, but it's called the viral transport media. Okay, it's a little tube that has the solution where the swab goes in after a sample is collected from a patient that requires COVID-19 diagnosis. This has been used for a long time, and it's not just for COVID, it's used for any viral infection that you may have. But that's one of the medical supplies that ran out very quickly. I mean, 2 weeks after the first cases were identified here in Panama, Panama ran out of this medical supply, in part because the countries that produce it, I mean, Panama is used to importing most, if not all of our medical technologies. And so we had purchased some of these medical supplies from Europe, but when they stopped in the United States on their way to Panama, the United States said, well, my population needs this, so my laws allow me to take it. And sorry, Panama, but you can't use it anymore. And so immediately we were in a shortage of these very important supplies so that we can continue with our massive national plan of diagnostics. And so we got contacted by the Panamanian version of the CDC, it's the Institute Gorgas and the Ministry of Health, to see if we could use our research capacities to produce this medical supply. There is no intellectual property in this medical supply, but we very quickly, in a matter of hours, were able to set up the first team that produced in that weekend the first 2,000 units. And since then, we produced over 130,000 units of this medical supply. And it's just one more example of things that can be done that usually, in a way, because we're trained in other countries, right? Like in the United States, when I was in Georgia Tech, I was doing research on biomaterials for tissue regeneration. And we were able to create patents and work with industry that was already there, right? But when we come back to our countries and we don't have that industry developed here, sometimes we continue doing the research that we were trained on, but we're doing it more in the academic space. And I think that that's an area that needs to be further explored and exploited. And it's that how can we connect scientists like myself? These last few months have been unbelievable because even though Panama is a small country, through these projects, through these innovation and entrepreneurship projects, I've been able to connect with the industry around these topics, and then trying to develop technologies and solutions that can have direct impact on the population. And at the end, just to connect it to the point that Niousha and you were talking about, I think that that's key so that we can provide solutions to the population that are and that are needing these technologies the most. Here in Panama, we have a very large indigenous community. We have a very large Afro-descendant community, and these are usually less economically favored communities that have even less access to some of these technologies. And we have a research community that on one side usually ends up focusing on very academic topics, but that we have a huge space to provide innovations and technologies to attend this population that is basically not well served right now.
Well, so obviously you're making the connections and beginning to see this, but I'm wondering if there's a way that on a day that we're looking at how to accelerate health equity by design, that we could be design conscious about the connection activity, the relationship activity. And Global Minnesota, where I work, we hosted the ambassador from Panama just a few years ago, and he had gone to high school here. He had been an exchange student, so he was kind of wired for connectivity. And so, but having your story be an example and then use that story as a way to lift up an organized approach to this, I'm wondering if the two of you could talk about your dreams or your aspirations for how we accelerate this, not to take away from Panama, but to accelerate it into South Africa and Brazil and wherever else on the planet people are making innovation happen.
I'm not sure if I should go, Rolando. I mean, you just unlocked it when you said your dreams and aspirations. I'm like, where do we begin? So, yes. No, thank you, Marge. So it's in terms of, like I said, one of my greatest passion is I know that there's just so many, so many innovators, so many gems, undiscovered gems around the world. And it's really, my dream is to go and discover them, right? Discover them, but also kind of bring them to light, to highlight the work that they're doing, connect them to opportunities. So the way I'm imagining this is, and we had this discussion with Rolando when I was just recently in Panama. I said one thing that's missing as we're thinking about not just that the fact there's no accelerator and incubator to really, invest into the innovation of young Black innovators, but it's also the fact that we need to focus and kind of invest into health and sciences, right? So sciences especially. And I was like, how fantastic would it be if we focus, right? We focus, there's been, for example, in recent years, quite a development in ICT, based education, but also like in software developers, which is good, which is also necessary, right? To develop those tech skills to be able to innovate and accelerate the innovation in health. But it would be fantastic if we focus really on researchers in health and sciences and applied sciences, right? So I thought, how fantastic would it be if we're able to, from the university, and then kind of continue with their path, and then seeing how they're able to come up with these innovative solutions, and then invest them, accelerate their ideas, kind of invest, but not in terms of just capital, but opportunities, equipment, and then connect them. For example, what Rolando has been developing and doing in Panama shouldn't be in isolation to what was happening in neighboring Colombia. And I know neighboring Colombia, they would have completely made use of this, but there's no connection. There's no really connection between what's happening in Panama, Colombia, and Brazil, and South Africa and other parts. I remember, I'm not sure if you remember well, Mark, and the first event that we did that you took part in, there was somebody from Colombia and somebody from Mozambique, And I was thinking, how fantastic would it be, especially in a South-South collaboration, not just going always with the global North, because they have similar realities, if we're able to do a knowledge sharing, right? So if we're able to set up labs and science centers where they're able to share the knowledge and then grow and develop the work that they're doing based on that knowledge sharing. So my dream and aspiration is to be able to set up these knowledge centers, these very developed and centers, basically these accelerators and incubators for young Black innovators, not just in health and science, but I think health tech is a very important component of the work that we're doing around the world, and then for them to connect to each other, right? So, and then for us to be able to so one of the projects that we're doing, for example, in Panama, one of the dreams that we have is to create a Black innovation tech park, right? So basically like the Silicon Valley for Black innovators, to have it in Panama and have young Black innovators from around the world in health tech and climate tech and clean tech and other types of innovation come to Panama and be able to develop their ideas, and for us to be able to bring all the supportive organizations and investors and all the people who are interested in developing that ecosystem come and meet them, but also come and see the work that they're doing and invest and support the work that they're doing. So that's I'm just summarizing some of the dreams that I have, but this is the way I see for us to be able to unlock the potential of that knowledge that's been produced, but it's unfortunately not been taken advantage of.
Yeah, I mean, I would add to what Niousha is saying, that we also need to focus on having success stories, right? Like in countries like Panama, countries in Africa, countries in Latin America in general, especially in our region in Latin America, we don't have that culture of, creating entrepreneurship or startups or spin-offs from academia as you do in the United States. It's not that common, and I don't know if it's something cultural or there's definitely a lot of innovation. There's definitely a lot of, very good ideas that can be implemented, but because it's not that common and we haven't had enough success stories, then it's really hard to find, people that are willing to invest in these ideas. And then that kind of creates this negative feedback loop where people basically don't see that as an option. And I think that that's one of the, one of the major learning lessons that we've gotten from this project. We actually have been running the project from a grant that we received from IADB Bank here in Panama, and that's what has been allowed us to keep going for these 2 years. And now we're in the stage where, with our institution, we're discussing the possibilities of creating this as the first spin-off that will go into the private sector and then continue to do this and continue to grow. And so, but in that transition, we find ourselves finding some of these difficulties that Niousha was talking about, and that because there's not enough people thinking about this or finding these opportunities for young entrepreneurs, especially from other communities, is not that easy. But at the same time, you can see that throughout the region. I still remember how, for example, in Chile, they were able to turn most of their academic laboratories into diagnostic laboratories for the public health system, and very quickly provide the resources and the information that the country was needing when the pandemic was in its height. So I think that we have several examples of how we have the tools, and now we have to coordinate better so that we can get people together. I mean, here in research, we're very used to working in diverse teams, interdisciplinary research. And we need to understand now that interdisciplinary research and interdisciplinary opportunities has to include the community. So talking about transdisciplinary, but it has to also include, business-minded people and investors and the industry, because if not, we're going to continue to work in our own silos, trying to solve our own problems, but not necessarily the priorities of the country. And I think that that's important.
I was struck by in the way that COVID had sort of made some things happen. I know that in Kenya, they created a national council, and one of the decisions they took was to make all their textile factories start making masks. And they ended up now having mask making and exporting capacity. So there are things that can happen. But I was fortunate enough to be able to participate a bit in the Dubai World Expo, where they had a very special program, one that we want to duplicate here in Minnesota as we look ahead. But they just use the phrase, they call it Export Live, but innovation can come from anywhere to everyone. So in that little phrase, it says what I hear you speaking about and demonstrating and inspiring. Innovation is going to come from anywhere. We may not be given the chance to know it if we don't get our systems right, but it can and will come from anywhere. And it must go to everyone. And your idea of building out this connection point in Panama, of course, that's also where the World Food Program has a very big presence. And so there's lots of energy and good thinking there. There are people in other Central American countries and Costa Rica and others who've especially been, I would say, interested. But it is thrilling to think about this and to think about ways that we could work together. I think that we are near the end of our time, I'm afraid, but for this is the first conversation, many more will come. But you've been inspiring us. Give us just a little bit more, both of you, that can help us keep going tomorrow when we get up and we're thinking about how great and how vital this is going to be as we go forward.
I just want to make sure that Rolando has the last word, so he'll end on a very inspiring note. I just wanted to say, for example, Rolando is only one example, right, of many others who are coming with such interesting and cutting edge solutions. But I also want to bring up two examples that I mentioned to you last time, Mark, is Lucas Lima. So Lucas Lima is from Rio de Janeiro in Brazil, and he's from a community called Complexo Alemão. And Complexo Alemão is a very harsh community because it suffers from a lot of high rates of violence. And Lucas is a mechanical engineer. He's 24, he's very, very young. And when he saw that during the pandemic, there was a shortage of protective gear in his community in Brazil, but especially in his community, and given the lack of investment, especially from this current government into Black communities in Brazil, he went to the junkyard and he just picked up some scrapes and metals, and he created a 3D machine to print the first set of protective gears for his communities. And then as he saw that it was success, he did some more, and he was able to provide protection at least to some level to his community. After that, Lucas went on to do some more. We're able to work with him and kind of mentor him and guide him into how he can think about having his own company and manufacture some other things. So now he's working on affordable housing, for example, and where he's able to print a 70-meter square house in 48 hours. That's just one example. With a little bit of support, how he went from doing something, very important, but at a much smaller scale, towards something on a much larger scale. So now he's thinking about setting up his own company, really manufacturing health products and gears for all of Brazil. So that's Lucas Lima. Then we have Arthur Lima, who is from Bahia, Salvador de Bahia, and in Brazil as well. Arthur basically came up, created a platform to address a lot of the systemic racism in Brazil that was going to connect, Black patients with Black doctors, both to provide, more employment opportunities and jobs for Black doctors, but also to make sure that Black patients were being attended the way that they should be. So that connection was really successful, and especially during the pandemic, because of the existing, again, racism that in Brazil, but they were able to get attendance and the medical attention that they needed and advice through telemedicine. So he was able to completely shift the way that they were doing things in person and adapted to the needs during the pandemic. Those are just two examples, but and Rolando is a fantastic other example. But like I said last time that we spoke to, Mark, if we're able to invest just a little bit into some of these innovators around the world, imagine what they could come up with, not just vaccines, but much more, right? So, and given the limitations that they have, they're able to still innovate. So I would just say that, but one of the things that's really, really important that we do for us to understand is that beyond this platform that we have today, that we do a mapping of everything, like a really thorough research of everything that is happening with, young Black innovators, and hopefully with, young people, indigenous people as well, which is really important. That's another population that's highly overlooked, not just in Latin America, but other parts of the world. But, and like, Siyabulela was saying, with young Palestinians, what are the innovations that they're coming up with that we can invest in and that can help us as a global society? So thank you.
Well, I mean, I would like to end just by saying that, like this session is called local action, for equity. I think my mantra now is local manufacturing of many things. We can create, we can create so many things, and it is possible, like we have been able to go through this process and start creating these medical supplies that are in need. But similar things are happening. This was because of the pandemic, but now we're realizing that it's not the pandemic. This has been a problem that our region and our countries have had for a long time, depending, too much maybe sometimes on the production from other countries. And like now with the war between Russia and Ukraine, we're seeing that some of the same issues that we saw with the pandemic, global shortage or lack of access to certain supplies is still happening, and there will be future pandemics. So we need to be ready, we need to invest in this, and we need to believe in our people, in our scientific community, that we have the capacity to do this. I think that most of our countries have beautiful plans. I can say that Panama has beautiful plans, to become a pharmaceutical hub, to become a hub of biosciences for health. But sometimes we have, we lack a bit of experience in the implementation part of it. And I think that small projects like this can start generating that data, generating that knowledge so that we can do it and we can do it better. And so I think that, like the last panelist said, we are one human race and we have to continue to work together, reprioritizing. I want to believe that the pandemic and now this war is helping people reorganize what are their priorities. And we need to invest in the things that are going to help have impact in our society.
Amen. Thank you so much, both of you, for your work, for your inspiration, but also I can't wait. Well, I can't wait to come visit down in Panama, but I can't wait to see how we take the next steps of this forward. Thank you again and goodbye.
Thank you.
Welcome to everyone who's joined recently. This is Global Minnesota's World Health Day 2022. We've been looking at the ways that accelerating health equity by design has many different components: localization of innovation in manufacturing, the necessity of getting the media involved so that information and disinformation and other things that keep us from reaching our potential can be addressed. Our next presentation is from the Chief Science Advocate and Corporate Scientist at 3M, one of Minnesota's oldest and now one of the most global and innovative companies and corporations. She has been for 28 years a scientist and engineer, corporate scientist, so almost 29 years. And I take some great pleasure in noting that she started as a summer intern there back in a few years ago. My niece, my precious niece, Sophie, started there as an intern a few years ago while in college and is now a computer scientist at 3M. 3M is an amazing, innovative company. Jayshree has been leading their work to bring more people into science and technology careers, especially people who've been often locked out, women, people of color, indigenous people, and others. And her work has been fundamental to changing how we understand that equity in health will be greatly assisted, and it's in fact impossible if we don't have all of society engaged in the innovation, in the manufacturing, in the creation of that system. So I want to share her deck and video with you now. Thank you.
There's a stereotype of scientists, one, that they're male and they're boring, they don't dress well, and they're like very awkward. I'm obviously not that type.
My name is Dr. Sierra Civils. I'm a nuclear engineer.
My name is Dr. Jessica Taff. I'm a microbiologist.
My name is Jayshree Seth. I'm a scientist at 3M.
My name is Gitanjali Rao. I'm 15 years old and I'm an innovator, scientist, and promoter of STEM.
I was the first Black woman to get a PhD in nuclear engineering. I saw that as an opportunity to open the door for people that look like me to come and be involved in these fields.
A scientist is anybody, and it shouldn't be based on age, race, or gender. It should be based on our capabilities and our motivation to tackle world problems.
I want to tell the next generation of STEM students that you don't have to be what people expect from a scientist. The more stereotypes we break, the better outcomes we're going to have because we invite more people into the world of science. We need every diverse perspective in order to solve problems.
Wherever we're going, wherever we're racing, we're gonna keep riding.
If you inspire a girl and show her the different ways that she can do what she loves,
you open their eyes. Then they look at you and think, if she can do that, I can do that. And my message to them is, yes, you can.
She can change the world.
We will be tameless. We will be tameless.
Greetings to all, and thank you for this opportunity. There has never been a better time to talk about this topic than right now. Virtually all of humanity. We faced the same existential crisis. We confronted the same fears, and we all awaited our turn for the same gift of science, the vaccine. There is no doubt in my mind that science will vanquish this pandemic, but during this strange time that we're living through, we have seen very clearly that science and scientists and professionals in STEM, science, technology, engineering, and math, have a profound impact in shaping the future. We're seeing that the global public is recognizing that as well, and it is important that we advocate for science and for adequate representation of women and underrepresented minorities in STEM. Science is currently having a moment, and that is exactly why it is a great time to advocate. So let me explain what is going on. During the pandemic, science skepticism declined for the first time since we started tracking it 3 years ago. And as you can see, it was steadily rising till before the pandemic. But during the pandemic, it is down. And trust in science and scientists is the highest it has been. So now you're probably thinking, good to see that science is being seen in a positive light, and you have all these questions, including, wait a minute, why is 3M doing this research? So let me back up a bit and quickly give you a little background. This is our sustainability framework at 3M, and I go to work every day, and our projects relate to science for circular, science for climate, and science for community. We are committed to creating a more positive world with science, and we are aligned with the UN Sustainable Development Goals. And we have a long-standing commitment to education and STEM equity in all the communities we operate in. In 2019, we spent $41 million in a variety of initiatives across the education spectrum. And in 2020, we also announced a $50 million fund for social justice, and a key element therein as well is STEM equity, which is a critical area. You know, less than a third of STEM roles are held by women, so we are far from parity. We have a lot of room for improvement on the STEM equity front because it has a wide-ranging impact, including that on the talent pipeline of companies like 3M. We need all the diversity of thoughts and experiences we can get in order to creatively solve the problems we face and to unlock the secrets to a sustainable future. And at 3M, we are all about science. It's our most distinguishing characteristic. It's what ties our businesses together, and it's the foundational strength behind our brand, science applied to life. We care about science. Science matters to us. So we wanted to understand what the global perception around science was. And we didn't find any studies that were relatively recent and global in nature. So we commissioned one. We surveyed 14 countries in late 2017, 1,000 respondents per country. And the results have been really interesting and, let's just say, thought-provoking. So for those who may have heard me speak at various venues will likely still feel the same feeling what they felt when they heard me the first time I shared the 3M's Data Science Index, because every time I speak, I get the same sensation. So here goes. 4 out of 10 people surveyed globally said if science didn't exist, their lives would be no different. And I repeat, you heard me right. If science didn't exist, their lives would be no different, they said. And 32% of the people call themselves science skeptics. And in this population, 60% said if science didn't exist, their lives would be no different. Now get this. They were taking the survey on their laptops or mobile phones. So yes, you can pick your jaw off the floor just like I did. It's very clear that science is invisible, science is underappreciated, and science is taken for granted. That is the problem. People don't realize that all this wonderful technology that they so seem to enjoy the benefits of, their phones, their cars, their microwaves, their coffee machines first thing in the morning, that it's fundamental science and research and application that allowed them to afford these benefits. Some of the other things that people around the globe say. I was more excited about science as a child. Many said as an adult, I don't think there is a need for me to understand science. 36% of those surveyed also said only geniuses can have a career in science. So thank you, Albert Einstein, but no thanks, because who do you think? Who do you think a label like this, a label of genius, deters the most? Exactly those who are underrepresented in many STEM fields. And no surprise, across the globe, women trail men in the positive sentiment for science. When asked if you could have a satisfying career in engineering, 25% of the men agreed. But for women, it was only 9%. And I stand before you as an engineer, certainly not a genius by any means, and with a satisfying career in STEM. So we have work ahead of us, especially since people want the next generation to pursue science. Interesting, isn't it? I don't care about science, not so important for me, but you go ahead, kids, you do science. How does that work? It kind of doesn't. I know as a parent, kids are watching. So although it's great to see people want their kids to know more about science and have careers in science, we have our work cut out as it relates to advocating for it, especially if the general population doesn't seem to be that aware of it and appreciate it. So these are just some of the results from the first round. There's a lot more there, but it was clear that science needs advocates, science needs more champions, and it was clear that this is not some data we can keep close to our vest at 3M. This needs to be shared, and we need to foster a global conversation around this topic. And I was called upon to be the company's first ever chief science advocate. And when I got this call, I was like, what now? What role? Because if you Google it, it doesn't exist. You see that the role doesn't exist anywhere. And my first reaction was, I can't do this, because truth be told, all along while I was growing up, I never thought of myself as the science and engineering type. I was just strongly encouraged by my parents to go into the field. I could not get admission to top colleges. I had my share of struggles through graduate school, and I came to 3M through the back door as a summer intern. But when I saw the results of the survey, of course, first I questioned everything. How did you define science? Who did you ask? Blah, blah, blah. And all these other questions. And quickly I realized the problem is real, because people are simply reacting to whatever their perception of science is. And we need to work on that perception. And then it kind of all started falling together for me, my own journey as well as my experiences in raising my kids, a son and a daughter, and noticing the differences. And I took this role on, and I'm really glad I did. So first thing, as an engineer, I broke down the problem into A, B, and C. A is about raising awareness and appreciation and acknowledgement of science so we can move people from this sort of apathy. Second area is, of course, breaking down the biases, the boundaries, the barriers, and the beliefs. You know, I'm not a genius, I can't do science, or I'm a girl, science is not for me. And that's an issue, right? We see the portrayal of science in the media. Despite having 2 PhD scientists at home, my own daughter said, I don't want to do science, that is for geeks. So the image of nerds and loners and mavericks and evil and genius and male scientists in media isn't necessarily going to inspire little girls. So that needs to be addressed, and it's happening slowly. And finally, we have to focus on the context and champion and communicate that scientists solve problems and science can improve lives. I know from my own experiences how important context was to me, and I saw how important it was to my daughter, whereas the content was sufficient to motivate my son. So with girls, we need to put a different lens on our, for communicating about STEM education and careers. And I should point out that's me. It's the science of makeup and lighting. And I own this image because it impressed my daughter. She thought I finally was the cool scientist. So, hey, whatever works. And you can access this website and see all the results from previous years also. I've put the link there, 3m.com/science index. So what did we do at 3M once these results became available? And again, I'm just giving you a sampling here of some of the things. We compiled a scientist as storyteller guides that has tips from many known SciComm folks. We have Alan Alda, Scott Kelly, Katie Couric, and they talk about some powerful concepts as it relates to science communication. And that's me and Janet in the lab holding up one of my favorite tape products that we developed. And this guide is downloadable from the 3M website, so check it out. We also hosted a podcast series, and here we just pick apart the survey results and discuss, the why and how and what to do about these things with scientists and educators and inventors and innovators. And then we also did a video series called Beyond the Beaker, where we profile diverse 3M scientists as everyday people, people with the same interests and hopes and desires to show that they are real people. And we had to do that because of the data unearthed by the State of Science Index. And I speak at a lot of events to take this message to the world and share the results of the survey. And we also pull in celebrities to amplify the message. And in 2020, we also created Science at Home series, where we have 3M scientists doing simple science experiments to keep kids engaged. 55 million students in US alone had to transition to distance learning, and very suddenly, and many of us had to work from home. And my colleagues were working hard to attack the pandemic from all angles. What else can we do to help? So we came up with this idea, and it's been very successful. It's just short videos with easy experiments that you can do with common household materials, but they introduce or reinforce core scientific principles. So you use them with your students. And of course, if you know of kids and grandkids and nieces and nephews, please send a link to them. Science at Home. 3m.com/science at home. I did one of these experiments, and you can actually see how exciting it was for me. Honestly, I'd never blown up a balloon with baking soda and vinegar before, so check it out. And I also write a lot, so please follow me on LinkedIn, and if the message resonates, please help us to amplify it. I write about topics such as science advocacy and what I've learned, that we need to keep making that connection of science to everyday life, to keep it in the forefront, otherwise it's taken for granted. We need to make science feel more of a human endeavor as opposed to some strange ivory tower thing, because we can't have that chasm with the general public. It'll be an issue when we need the public to follow science. And we see how that is even played out now. And finally, it is the importance of keep talking about STEM and encourage exposure and education. I also talk about the multifaceted issues of girls in STEM and women in STEM. There are issues across the spectrum, social conditioning to early education, to STEM in college, STEM professionals, how we need more role models. We need to adjust and change the way it's taught, communicate that it solves problems, and you can help others. The way I like to say it, it is time for steam cleaning. S is for shattering the stereotypes, T for telling the wholesome story, E for providing exposure and environment, A is for allies and advocates. We need men to be allies here. It's not a zero-sum game. We will all benefit from it. And finally, M is for metrics and measures. Listen, without that, unfortunately, sometimes numbers just don't move, especially in many corporate and institutional environments. So we at 3M, for example, have set diversity goals, and it's a great thing because the public expects it. And we saw that in our 2020 results. So what did we find out about this 3M Data Science Index, the global perception of science? We found that when we took a pandemic pulse during the pandemic, people are definitely seeing the need to follow the science to get out of the pandemic. And there's also the appreciation now that there are negative consequences to society if we don't value science. We also found that people were trusting scientists and science-based organizations, which frankly was really good to see, especially with the level of misinformation and disinformation that is out there on social media. Well, turns out globally, people seem to know what not to trust. I don't know about you, but I would get all these strange things in my WhatsApp from friends and family around the world, and it started to worry me because it looks like, people are reading all this stuff, don't forward it, but people knew where to place their trust, so that's good to see. What else was on people's mind in 2020? Of course, the coronavirus, but you can see a reflection perhaps of the year that it was. Social justice and STEM equity also rank really high with environment. In fact, people recognize the strong role that science can play as it relates to solving sustainability challenges. So this is great that science is in the forefront now and people see the connection of it to our future. Another trend is that people are seeing pandemic has highlighted the importance of STEM education. They are now more likely to agree that the world needs more people pursuing STEM to benefit society's future. However, there is a problem. Many say that they have been discouraged from pursuing STEM. And among who say they have been discouraged, one of the barriers is their gender, race, ethnicity, which, by the way, in US is half of those who say they are discouraged. So now you're beginning to see the why now, which you perhaps intuitively knew already. So if we pull it all together, the way I like to say it is 2020 is the year to start to stem skepticism. And now we really need to advocate for science and STEM equity because people are primed. They seem ready and willing to do something about it, especially as these 4 key relationships have become evident from the results of the 3M State of Science Index Pandemic Pulse in 2020.
First, I call it science of health for the health of science. With healthcare, in many ways, science gets personal. Our inherent interest in our health provides a way in to attract more people to science more generally. It also provides a strategy for building an ongoing healthy relationship with the scientific process, and communicate that it is dynamic and relies on new data and ongoing debate and discourse and discussion. And that's just how it works, so people can't politicize it easily, you know. Second is the technology and sociology of trust revelations. Trust in scientists was the highest, and even corporations was high. So there's a clear opportunity for scientists and science-based companies to be visible, accessible, and active in their advocacy to bolster that foundation of public trust in science. Third is the engineering of sustainable solutions. During the pandemic, people saw images of nature thriving as humans took a pause. So it's not surprising that outside of healthcare, environmental impact remains the top concern. Now is not the time to put sustainable solutions on the back burner, but to show the critical role of science in solving sustainability challenges. It also gives a unique opportunity to attract underrepresented minorities to STEM and build a sustainable talent pipeline, given their higher affinity to communal and pro-social goals. And this is well researched and documented, the fact that underrepresented minorities have more affinity to pro-social goals. So it's a win-win, really. And finally, the math of equality and accountability. There's a multiplier effect when everyone in the community comes together to solve common goals. Survey results show that people mostly hold governments responsible for solving societal issues associated with health, sustainability, and STEM equity, but our findings also suggest that the most positive impact likely happens with shared responsibility, when scientists and governments and business leaders, NGOs, academic institutions, and individuals pull together in the pursuit of common goals. The pandemic pulse has really given science a lifeline of support, and now is time to double down on our efforts to stem skepticism, advocate for science and inclusive innovation with a focus on STEM equity. So all this data on public perception, I'm hoping gives you keen insight into what people are thinking in this unique moment in time. You know, with the pandemic and social justice issues and sustainability challenges, and linking up science to society and giving it a human context. And these messages really resonate with me. I already told you I didn't think of myself as a science and engineering type when I was growing up. I just wanted to help people improve lives and make the world a better place. And I naturally gravitated to fields where this contextual pull was strong. And I frankly didn't see that in STEM fields. I ended up here, but I've made that mindset really the cornerstone of my success. Because without that, I feel a sense of what is called communal goal incongruity. And the more I talk to women, the more I find out how much it resonates with many of them. So we have to make it more visible and lean into it, and that is good for all. Today, I'm at the highest level at 3M, the 4th woman to ever achieve this level. I am the science and engineering type.
And this picture is actually from when they were filming a 3M brand campaign. And if for some reason I look familiar or my voice sounds familiar to the folks in the US, yes, I'm the lady from the 3M ads, as my daughter calls me. You may have seen it playing. And in each of these ads, I basically wanted to highlight exactly that, how my work helps people, how we build on ideas working collaboratively, and how science is a journey, not that one aha genius moment. So I can give you my spiel. What's the real shtick? It's STEM: science, humanities, technology, engineering, and math. And this is very important when virtually half the world will only trust science that aligns with their beliefs. Science is not a belief system, and the only way to get us out of a trust paradox type situation is to teach STEM with a human context and advocate for science with a societal perspective and promote STEM equity. And that should foster trust, and that should instill hope. And turns out hope is the defining sentiment around science in 2021. We surveyed 17 countries in 2021, and not too surprisingly, the themes from 2020 continue. In fact, skepticism is low and trust remains at the highest level as we turn on the corner on the pandemic. You know, with vaccinations and countries or regions are opening up, there's a sense of hope. And beyond dealing with the current crisis, science gives us hope for our future. Science gives us hope for our planet and for the next generation in pursuing STEM. In fact, people agree that during pandemic, scientists and medical professionals have inspired a new generation to pursue STEM education and careers. But people around the world, 17 countries in all, say that we need to do more to encourage and keep girls and women engaged in STEM careers and education. And I'm so proud that 3M premiered a docuseries called Not the Science Type, and it intends to inform, to influence, and hopefully inspire. We want to foster a conversation around shattering stereotypes that deter women. It shows that we're all the science type. We can all have different paths and backgrounds. Doesn't matter your race or ethnicity or age or nationality, you can blaze trails, you can pursue your passions, you can bring in your interests, and you can shape your careers. Your potential is exponential. And I'm honored to be one of the scientists featured in it. With this film, we want to catalyze the conversation around changing the constructs, dismantling the archetypes, shattering the stereotypes of who enters, who persists, and who excels in STEM.
After all, who is the science type? Interestingly, at age 6, girls draw 70% of scientists as women, but by the time they're 16, they draw around 75% of scientists as men. And if you're wondering when does this number start flipping, it is at 10 years of age. And much research has been done on the topic of why many girls and young women do not see themselves or even their gender in science careers. And many factors can contribute to this at an individual, group, cultural, and societal level. In fact, studies have found that a less pronounced masculine image of science itself has the potential to increase the likelihood of STEM career aspirations for girls. There are also these deep-rooted gender stereotypes that can impact a child's social identity and the perception of who is a scientist and who can be a scientist. I wouldn't have opted for STEM thinking I too was not the science type. I'm fortunate that my unique circumstances prompted that I pursue nonetheless, and here I am today, a corporate scientist, the highest level at 3M, 72 patents, many products and technologies that I've been part of developing, and the first ever chief science advocate. So our paths can be diverse, just as diverse as we all are, and science will be better off for that diversity. You don't have to be a specific race or gender or ethnicity or nationality. You don't have to be a child who tinkered, and you don't even have to have a degree to be the science type. I highly recommend you check out our docuseries at 3m.com/nottthesciencetype, and please spread the word. Our research shows that the public has an expectation of shared responsibility, including expectations from corporations and even down to the individual. And we can all do something about it. In fact, people know that as individuals, we have a strong role to play to step up and address the inequities. And there's a lot of effort currently to ensure equitable engagement, participation, and success of underrepresented minorities in STEM. I hope what I said resonates, and I leave you with 5 ways we can all give our voice to plant the seeds of STEM in the next generation, nurture them,
and watch them grow into well-informed problem solvers. And you don't have to be in STEM yourself. You can volunteer at events. You can organize science events in your community. You can inspire impressionable minds by showing how science can solve a problem they have. You can champion to bring more STEM tools in your local schools through individual or corporate involvement wherever you work. You can engage in conversations that draw out their natural curiosity and engage in the sense of wonder, and you can engage in learning together. And I would like to close with my own attempt to build community in STEM of making hashtag 2020 count. I have compiled essays that I've written in this book, The Heart of Science, Engineering Footprints, Fingerprints, and Imprints, and all proceeds from the sales of my book will go to a scholarship for underrepresented minorities in STEM to be administered by the Society of Women Engineers. So what can you do? Well, if you buy the book and like it, please spread the word and you will help give the gift of education.
And why did I write the book now? Well, as I said at the beginning, and I hope I have convinced you, there has never been a better time to talk about this topic, advancing women in STEM, than right now. Thank you.
Thank you so much, Jayshree, putting that all together into one big vision and then passionately letting us know how important this part of changing perceptions, of changing aspirations, of changing composition, of changing the diversity and the inclusion equation, in this case in one company, but as a for the whole society, for the whole world. So thank you very much for that. And I, again, I'm a proud uncle of a young scientist there at 3M, and your presentation has even given me more of that kind of pride in our local community, but also hope for the future. And that hope for the future is the topic for our next discussion. Dr. Luqman Lawal is the Vice President of Health Equity at Bright Healthcare. Prior to that, he was at Starkey Hearing Foundation. Many of us are aware of Starkey and their work all over the planet. And I think it has taken him to 60-some countries. But Dr. Lawal is thinking about how we take healthcare, and as we design it in a different way, which is part of what Bright Healthcare has been doing, we can move us in the direction of that accelerated health equity, and we can do it by designing how we design those systems. Dr. Lawal, please join me on the screen, and thank you so much for being part of Global Minnesota's World Health Day 2022. Tell us about how you came to see Bright Healthcare as the place you wanted to be designing to address those health equity questions.
Thank you so much, Mark. I'm so honored and thrilled that you've invited me to be part of your World Health Day celebration. And I must thank you and your entire team for all the hard work to put this together. I know it takes a whole lot to get this done. And I would like to start by letting you know that, yes, health equity for me, it's beyond just the phrase. It's beyond just trying to get something done. I was born and I grew up in Nigeria, and growing up in a middle income family, I lived close to and I had family members that died for no just cause, but because of where they were born, where they lived, where they worked, or where they played. And that was what kind of inspired me to want to be a physician. And working as a physician, I saw the challenges beyond the scope of what I thought of while I was growing up. And I saw that this was not a problem I could solve on my own. And I started yearning for, how do I really get a public health degree to start addressing the problem upstream and start providing more of preventive approaches to solving the problems. And like you rightly mentioned, while I was working at Starkey Hearing Foundation, I was leading the global health work. And that took me to over 60 countries. And going to these low and middle income countries further strengthened my resolve and further exposed me to health inequities in such a way that you can never be taught in any four walls of a classroom. And I'll give you an example. If we go to, for example, a country like maybe Malawi in sub-Saharan Africa, we may drive on that road for about 2 hours to fit hearing aids. on patients that couldn't afford hearing aids. And once we're able to do that, you see this stark poverty in those patients you're trying to help. And sometimes late at night, after the work, you are driven to the palace of the president, which will now host you to maybe a luxurious dinner. And for me, it was quite tough putting side by side the young girl I fit with hearing aids in the morning with the extreme lavish dinner being hosted by the leaders of the country. And that for me was very striking. And I felt there needed to be something to be done. And what accelerated that for me was the pandemic, in the sense that we returned from part of the work we do, helping Armenia develop national policies and strategic plans for ear and hearing care, specifically 20th of March, 2020, everything got locked down and we were just locked in the US. And I started thinking of, yes, we've been able to do all this work globally. What can we do domestically to help improve health equity and to make it strong? The epicenter of social justice movement that was emanating then was here in Minnesota with the death of George Floyd. And seeing my two young boys, one was 4, the other one was 6, every day, and looking at them, 2 Black boys growing up in Minnesota, I really wanted to do something. I wanted to be part of a solution to help improve health equity domestically, so we could leave a better United States for these boys. So I started looking for organizations that are interested in bringing on people with health equity experience, and I got opportunities from 3 other ones. And I chose to work for Bright, mainly because I saw that this is a Minnesota company, this is a young company with an opportunity to bake health equity into their DNA. And my role going in as the vice president of health equity was to provide the strategic plan, help lead the development of a strategic plan, and help oversee the implementation, the monitoring, as well as the evaluation of this strategic plan that we're going to develop. And we're able to develop a strategic plan, which we see as an essential piece of really advancing health equity. Because there's the saying, if you fail to plan, you plan to fail. So we really needed to really adopt one of the best practices of having an approach, a systematic approach of addressing health equity. So that's more of what we're able to do with Bright. And I don't know if you would like me to go into some of the details of what we're able to do with the plan and how some other organizations could benefit from the framework we used.
Yes, for the thought process of the day, the specific ways that you have seen, if we design it in this way, that will add to the reduction of disparity, the advocacy, and the accomplishment of equity in health.
Yeah, thank you. So being a World Health Day, I like to always reference the 6 building blocks of health from the WHO, and how do we kind of embed all our designing, implementation, monitoring, evaluation of health equity across those lenses while we try to advance health equity. And in the same vein, using those 6 building blocks from WHO also resonates with more of what we call the 5 Ps of healthcare here in the US. And if you look at the WHO building blocks, we have what we call leadership and governance, which is a key component of health equity building blocks. How do you ensure the leadership and governance of the country, of a state, of a county, of a community, have policies, programs, and procedures to help ensure health equity is advanced within that society? So leadership and governance is the first building block. Then you move to service delivery. Then from service delivery, the third building block is medical devices as well as medications. The fourth building block is health information and research. We have health financing, and the last piece is the health workforce. And this also resonates with what we call the 5 Ps of healthcare in the US, with the patient at the center. And you look at the policy development from what is more or less the leadership and governance from the WHO building block. You look at the professionals and the academia, which is similar to what we have as the health workforce or the health information and research from the WHO building block. Then you have the payers, which is more of what I do with Bright Health Group, the payer system, and the providers. So how do you ensure at each facet, at each of the stakeholders have a design system that's embedded health equity into what they do so as to achieve what the goal of health equity is, everyone, everywhere, having a fair chance to be as healthy as possible. And if you take it piece by piece, look at the policy piece. Policy in the sense as the government and the leadership and governance of a country. How do we deliberately have systems in place? How do we deliberately have processes in place to advance health equity? How do we ensure that we have a system to address what we call the social determinants of health? And when we talk about the social determinants of health, we have issues around social factors, opportunity for health access, as well as health quality that is being received by a certain group of people, educational access and quality as well, the economic opportunities, as well as built neighborhoods, as well as physical spaces. How do you, as a government or as a leader of a particular country, look at these different factors and see how do you advance that in the design of your policies, in the design of your systems, such that this is brought to the front of the burner and every single person within the jurisdiction of your country has equal access to attain their maximal health potential. Now you move to the professionals as well as the academia. These are people that are in our institutions of learning. These are people that are in charge of research. How do you design your research in such a way that it's non-biased and it covers the entire population of the country? How is it reflective of the people within the country? How are you including African Americans, Hispanics, Native Americans, LGBTQIA+, people of low socioeconomic status in your research? And beyond that, those that make grants for research, what are the things we are looking at as objective metrics to provide grants to people to be able to do research? How have we factored in health equity? How have we factored in diversity, equity, and inclusion in how we make grants and how we give funds to people to carry out research? Do we really have the criteria that kind of governs if the applications qualifies with regards to health equity? Then you move it beyond that and go to the provider space. The provider space, how are our providers of healthcare services making it accessible, affordable to people of color? How are we able to design a system such that the accessibility goes beyond just the colors, but like you look at people that are either physically impaired, how are they able to access the design of our family, our healthcare environment? How are we able to put the perspective of the people that will be utilizing these services into the design of the environment, both physically as well as socially? Who are the people that will be interacting with the patients when they come in? Do they look like the people that are the patients coming in to receive the services? And are they culturally competent? And that brings us to the need to have what we call culturally and linguistically appropriate services for everybody within the United States. And the last piece is more of how within Bright we're able to design what we call the health equity 5 building blocks. And this is what we use as a template to help advance health equity, and which is still currently being used by Bright Health Group to advance health equity for the majority of the patients, as well as the majority of the subscribers of the health insurance program. So the 5 building blocks are kind of designed as to ensure the adequate infrastructure to advance health equity, specifically reducing health disparity by promoting quality, access, and outcome to the diverse patients that are being served. How do you help improve the identification as well as addressing social determinants of health, as well as how do you advance diversity, equity, and inclusion, both internally and externally? And lastly, which is the 5th building block to advance health equity by Bright Health Group, how do you utilize partnerships and collaborations to advance health equity? So these are the 5 building blocks, and I don't know how much time we have. I can really go into details of how this design has started being implemented and the potentials for other people to benefit from using these 5 building blocks to advance health equity?
Well, it seems like one example from how Bright Health Group convinced you that they were the place that you could make the biggest impact, having a whole life of thinking about making an impact. What's the thing that grabbed you that said, that's just where I want to put my energy, my skills, my passion?
Oh, thank you so much, Matt. So for Bright, for me, I saw a young and rapidly growing organization that would provide me a template, more like a blank canvas, to design the framework and also oversee the implementation, monitoring, and evaluation of health equity activities within the organization. So I always talk about how do you catch them young, meaning it's easier to bake in, to weave in the health equity activities and policies while the organization is still young. However, it will be more difficult to try to retrofit and fix a broken system. So how do we build it from scratch? Meaning, when I joined Bright Health Group was barely 5 to 6 years of age. And this is a fast growing company whereby I could really bring in my knowledge and skill sets and network to be able to develop something and bake into the DNA of the organization, whereby everyone that works within Bright understands the language of health equity, understands the importance of health equity. And I'll give you an example. Part of the key building blocks, which was the DEI component, especially the external facing one, was how do we ensure the dollar we spend looks like the people we serve? And this had to do with working with the director of vendors and suppliers. And what we did was to be able to build more or less like a dashboard that kind of reports out how much are we spending and who are we spending this money with. If, for example, if an organization spends maybe $250 million annually, and maybe 98% of that spending goes to a certain race or ethnicity, then you're not solving the problem. You are the problem. So how do you as an organization be sure you want to solve the problem by ensuring the money you spend looks like what you're trying to achieve, that you are willing to put your money where your mouth is? It's a difficult task, but like, how do you really have those tough conversations to start tracking? You may not get there in 1 year, you may not get there in 5 years, but there should be a pathway. There has to be a political commitment to start looking like what you want to achieve. And beyond that, what does your board look like? What does your leadership level look like? You need to start reflecting on what you want to achieve. If you have a board that doesn't reflect what you're trying to achieve, then there's no way. That means the people that have lived that kind of experience will not be there to advocate for advancing health equity. So those are some of the key things that we've been able to do at Bright.
Well, those are some fabulous examples. And I hear from your story the possibility you could see a young company growing quickly, but also a blank slate when it came to the particular thing of how do we bake in from the beginning health equity and then measurement and benchmark. And then those examples, of course, are resonant with anybody watching today who's saying, I want to be helping accelerate health equity by design. I'm not working in an insurance company, I'm not working, but everybody has the opportunity to think about where their money is being spent, where their investments are being made for their retirement, where their charitable contributions and others. So, I mean, that's a part of design. But I'm also taken by the example that that company was able to attract an exceptional leader like yourself because it was committed, difficult as it may be, long term, while you are clear, this is going to take a while. It seems like one aspect of doing your design work is that serious people then say, oh, you mean it. It won't be a smooth ride, but it is going to be a ride in the direction that we want to take all of society. And so it's very inspiring for me to hear, you know, this part of the story. I mostly see the business press, know that Bright Healthcare is, you know, successful, young, you know, on the move, but now I have a much bigger picture in that way. When I was on the advisory board, senior advisory board for our National Guard for our state, one of the central kind of metrics was making a National Guard that looked like our state.
Exactly.
And so this gets kind of a fundamental thing that you're raising that then is applicable to all of society. You've chosen.
I totally agree with you. I totally agree with you on that. And for me, if there are some key things I would love people to take from this my talk with you today, is like, we need to put our money where our mouth is. Yes, after George Floyd and with the pandemic and with the polarization from the presidential politics and all that, there is still some momentum. And for us to really achieve what needs to be achieved, we need to start doing the real difficult tasks. And what I mean by the difficult task, like you rightly mentioned, you can't really say you want to advance health equity without willing to make your leadership look like what America is, without willing to spend money where things need to be changed. So we need to have that political will from leadership, and beyond just really having a health equity officer or a DEI officer, which were a lot of things that sprung up after the death of George Floyd, as well as during the pandemic. We need to empower these people to be able to make impactful changes. And that will entail a difficult conversation, which at the end of the day, studies have shown, McKinsey studies and many other studies, that health equity, DEI, goes beyond just a moral imperative. There's a business case for it, and that's more of what I always tell people about. For example, if you're able to serve this population or this demographics better than any other organization does, better than any other competitor does, these are loyal demographics. They will be the one to blow the trumpet for you. At the end of the day, that adds to your bottom line. And I look forward to a time whereby in the United States, part of what we measure companies by won't only be the amount of their revenue or the amount of money they return to investors, but more of how do we start including metrics on health equity in our ESG matrices. How do we start measuring through what we call a double or triple bottom line that goes beyond just the dollars, but something that reflects the planet, which is which is a theme for the World Health Day today, the planet and the people in terms of health equity, so that people that want to invest don't just invest in your company because you're going to give them tons of money, but they know you are giving them tons of money and you are treating people right, you're helping improve the world socially, and you're impacting the planet better. So that's more of what I'm advocating for people to listen to today.
Well, that's the inspiring message that we were hoping that today would bring to people, and you've said it so well. And I'm hoping people from those investment companies and those people that are, asking for ESG and these other reports to say, look, it's time to build in. Yes, climate's important. We have that built in. Health, that's important. But having you there at a dynamic company, young company, but one that's clearly large and moving ahead, also means that as a society, we're beginning to build in places of authority and places of responsibility, people who will keep on keeping on and will be raising difficult questions. We talk about this being a period where some difficult conversations are needed. You've brought us into the middle of one, and I look forward to being able to continue this conversation going forward. And I'm so appreciative that today we had a chance for Bright Healthcare to get some spotlight, but also for your vision, your journey, your path. And all of us together are trying to create that future for your two boys. And this is one of the ways that Global Minnesota Connecting, it's a way that we can look forward with the kind of hopeful anticipation, aspiration that we want. Thank you again for joining us today, and I look forward to our next way of finding a path to walk together. Thank you.
Thank you so much, and thanks for having me.
Yes. That was such an inspiring talk about a new way that people are thinking about and are engaging in the reshaping of our medical system and our healthcare system in lots of different ways. And we're moving one part of our program because we were scheduled to have a talk, a presentation, and we're going to have to put that right in onto the direct on the screen because we're still working on part of that process, getting that video down. So it means that we will be moving directly now to our next presentation, and I will come back to this. But Geo Murickan is a leader in a national movement around medical use of artificial intelligence and around thinking about the promise, sometimes the peril, but the opportunities. And he's a very unique business person, engineer, designer, and he works a lot both in the sphere of alternative energy and alternative systems of power and transport. And he's really the leader in all kinds of ways about the national work about AI Med or AI medicine. So we've been in a conversation about how we think about big data, artificial intelligence, that cluster of new, not all completely new, but certainly new on the scene as a dominant factor. How is that technological or digital revolution going to be harnessed and used to advance that health equity by design? And what are the ways that caring people and business leaders and others like himself are working to make sure that it is being harnessed for that purpose of, in a design way, bringing us to a new level of health equity? Geo, thank you so much for joining us here today, and please join me on the screen. And how does somebody with all different kinds of entrepreneur and business things going on focus suddenly on something so large and critical and say, oh, we've got to take the bull by the horns here and society-wide talk about and then advance how this becomes a real tool for achieving health equity?
Thank you, Mark. Honored to be here. Great day of discussions. This is a fabulous venue to talk about these topics of advancement as well as equity world over. So appreciate that. So you asked quite a few questions there, and I step back a little bit and say just how fortunate that I am in my career to be in a place where I can meld the different experiences I've had and the connections and relationship and really advance forward in this world, something that's very meaningful and needful. And in that sense, AI in medicine, or AI Med, the society that I'm the global ambassador for, really came about because people were open enough to talk about the issues and how to solve it in a bigger and meaningful way. So I'm a person that always talks about collaborating and scaling, right? It's not good enough to go off into a lab and create it and come up with a solution. You really have to open up and look around the world, who's working on what, who's doing it better, and then try to partner to bring that to the forefront, because that's the only way we can advance technology. Number two, and I think this is part of the conversations we've had in the past, is I view my role today, as you have for years, as whatever I'm doing today is for the next generation. Really, I am creating a platform, a path, a way to solve things that they will take forward and do much bigger and better things with. But it's our duty to put these issues in the forefront and create that pathway for it to go the miles it has to go to see the fruition. So in that sense, I come from a background of innovation, IoT, and really in the power and energy space. But about 7 years ago, I had this transformational conversation with Dr. Anthony Chang, who heads up AI Med Society. And he asked me what I do and what I'm interested in. And I talked about AI and IoT, Internet of Things, and big data, and how it affects energy space and industrial space, and really bringing things that have not been seen and on the dark side of the world, meaning the machineries that run this world, until they break, and find predictive ways of not have them break down and fix them ahead of time. So he said, well, I don't do anything much than that. That's what I want to do. I just do it for human bodies. And I said, I chuckled and I said, yeah, no, that's true. And then he went on to talk about how he took a break from his medical journey, as in, decades of experience in pediatric cardiology, to do his master's in data science from Stanford, and how it changed his life and focus around to say, hey, look, AI in medicine can help people and can bring it not just advancement, but healthcare equity around the world. And from that conversation really is what sparked my interest. And he welcomed me into that society. And today AI Med is global. And it is primarily driven by clinicians or physicians who are embracing technology, and embracing technologists, entrepreneurs, biomedical device companies, insurance companies, to come in and talk about how do we solve the problems that are at the heart of healthcare today. And what we generally talk about is, what we have is sick care today. When we get sick, we seek medical assistance. How do we take it to wellness care, where we can predict that we need care, or there are devices and technologies that help us to tell us, hey, you might need to seek assistance before you get sick. That's where AI comes in, and how AI medicine can help. So in this journey, I also learned very quickly that advancing technology is a great initiative, but there are some barriers that we face across the world, even in America, which is to process and deliver this type of healthcare. You need the ability, you need consistent and reliably available power and data connectivity. Without that, I mean, it's like our phone. If we don't have this phone in our hands, we feel completely disengaged from society, right? For half an hour, we go, is someone trying to reach me? Am I trying to reach someone? And with technology and the advancement in wearable technology, biomedical devices, there's so many things that can help us to diagnose early symptoms and other things. But if we don't have a way to power those devices or connect those devices, it's nearly impossible to harness that technology. And if you look around the world, that can be problematic. And even in the US, that can be problematic. So eBoost was born out of that, that need in society. So when Pioneer Power Solutions, we're a publicly traded company, been in the industry for 30 years. We changed our to eBoost because we believe not just EV charging for electric vehicles and advancing that, but providing reliable on-demand power and connectivity, whether it be through data cell sites, but also satellite connectivity, brings that to even the rural areas in America. And that's a big divide that we can try to help conquer. And with that, it opens up new possibilities. So 5 minutes ago, I was talking about AI medicine and the advancements, but how do we deliver that? How do we bring that connection between the physician that wants to utilize the technology to help provide the advanced wellness care, and then the patient who might be in a semi-rural, rural setting that may have the devices, the wearables that can help send the data to the physician or clinician that can help diagnose this. And at the heart of that becomes the power and connectivity. And that's how the two worlds of mind kind of combine and come together.
Well, so this is a fabulous way to understand the kind of expansion of even the notion of the Internet of Things into like, oh yeah, the things inside our body, and oh yeah, these things have to be able to connect. But I think in this moment, the opportunities that have been lifted up, COVID and many other things, does open this to a much wider possibility. Are you seeing young or old, new or long time in the field scientists who are taking what big data, we called for a long time, or artificial intelligence, and turning it into brand new things that will be exciting for especially the younger people who are watching today, but also for the society as a whole, new innovations that will take us to this new place?
Yes, I think there are two interesting areas you touched on, right? There is the not just the advancement in technology, but the two sort of sectors of society. The younger folks who are, let's just say, the newer generation, that are much more open to using wearables and devices and very comfortable with it. And you have the elder generation that can start to see benefits from this and how it can help them with even when they may not have family or friends nearby, and how they can get access. But where it really starts to open up is in two places. In the field of medicine, one of the little known or talked about issues is burnout of physicians and clinicians. And for the younger generation, it becomes a hypersensitive topic. Yes, I want to pursue this field of passion in medicine, but do I want to burn out in it? But that's the promise that AI brings, because what AI is starting to do at the infancy has been to automate a lot of the paperwork and the monotonous things that physicians and medical centers have been dealing with, and really get to the heart of what clinicians and physicians have always wanted to do, which is administer care, and if possible, cure. So that's the first part of the excitement part. The second part is what COVID has done is that we've had to deal with circumstances or situations where we've had to seek alternative ways of getting medical care, whether it's telemedicine or remote ways of managing that. And what we found out is some places did well because they had the robust infrastructure, other places didn't. Now, if we can tackle that along with the technology, we have an opportunity here to provide medicine into the remotest part of the world. And not just medicine or just basic care, but really advanced care in ways that we never thought could be possible. So from Minneapolis, the Mayo Clinic, some of the best experts in the world can provide a patient in Kathmandu the type of care that they need, because they've been able to diagnose it early they've been able to isolate it early, and now they know how many cases exist and what has been successfully worked on those type of patients and what the probabilities are. All of that data with AI all of a sudden can be harnessed at that physician's or clinician's hands. And that's the promise of AI on the other side. So that's what's exciting, and in the point in time we're in. And that's why I feel these two worlds of mine are perfectly aligned to see something exciting over the coming decade.
Well, I know this the kind of a unique situation of Minnesota having such large diasporas, especially from Africa, but the ability of like the Liberian Nurses Association or the Liberian doctors to then be in direct communications in certain villages with certain dialects. I mean, there's a whole language part that also gets AI assistance in many different ways. And so I'm really thinking about how you're crafting and describing these, not just benefits, but fundamental changes. And when you take burnout as an example and can present the way that, whether it's teachers or principals or people, I mean, you name it, having the things that burn us out or tend to reduce the number of people, let's say, entering helping or caring professions. This has implications down the road for all kinds of things, but it also has the information gathering part of that. What are the aspects of our paper-driven society, so to speak, or our forms or all the different things that are the things that burn us out or that are in some ways creating other problems? I'm aware that some professions, and the one I serve as Minnesota's civilian aide to the Secretary of Army, up in front of the Army's questions is, why so many suicides? What is going on here? What is going on here? And so in that moment of the kind of deep crisis about that question, being able to call on tools that can help figure out some of those things and then figure out solutions seems really important. You've been inspiring others as you were inspired by that great conversation that you presented, that you related. And I know you inspired a next generation, and your son has been creating AI clubs in high school, and we'll have him on in a little while talking about collegiate. Do you see the whole society, the Rotary clubs, the Lions Club, all of the different things, finding ways that their own incorporation of data analysis or whatever begins to be part of just how they are changing the way that we think in society? Can you see data analysis, Internet of Things, all of those things, finding their path in a new kind of more mass way so that, the kind of connections you're describing don't seem so unusual, but they seem just kind of like we used to say, riding a bicycle?
Right. No, absolutely. So, one of the overused terms over the last 5 years or so is, data is the new oil, right? Which is in itself a bad analogy in one way or another.
That's a day-long symposium on that.
Right,
Come right
exactly.
Somewhere. Yes.
Right. So I'm not going to get into that discussion, but data is really at the key of everything we do in society today. And sometimes we feel, everyone wants to track and collect data and things like that. But when you start to show the benefit of the data collection, right, to any age demographic or any part of the population, that's when people start to see, I see the benefit from this, right? And I was involved with a company, a very innovative company, and this young lady came up with this concept of utilizing the interface with or interaction that people have on the phone, your normal phone, and just from the snippets of unlocking and locking a phone, try to determine the mood of a person that day. So one of the things that was interesting in delving more into this was the fact that, if you are going through a mental condition, or you're just having a bad day, right? You can try to hide it in many different ways, and you try to put on the best face. But it's weird how candid you can be in front of the phone. I don't mean a video conference, but when you unlock your phone or when you do it, because it's your normal gesture you're going through, your frustrations, whatever it is. And the phone is the one device that is next to you, next to most people, that captures all of this. And utilizing just little inclinations from that data, just the normal data over a week, who you are normally and who you aren't that day, could serve as a way to intervene into a person's life where it could lead to something bad or catastrophic in their life. And I thought, for a second, I said, okay, there's a lot of liability issues and iPhone versus Google rules and regulations you have to go through. But the concept at its basic, what she was trying to get is data that is meaningful enough to point to a problem that could solve something very major for that person or their loved ones. And that type of discovery, that type of way of interfacing and harnessing data, and that's just a small point, but every little thing that we do could change the trigger and find new solutions to things we've tackled with, not just in healthcare, but just society in general. So that's the criticality and importance of data, number one. Number two, how quickly that can be harnessed, how securely it can be processed without divulging identity, and then be able to share it with the world so that other people can utilize that data to make better, more precise medical decisions.
Well, it's interesting in this moment where there's a lot of news about warfare and war that's going on and data analysis and all this. But also kind of simultaneously, there is the general understanding we're having a mental health crisis at all ages, but especially among the young. We're having a suicide crisis in the military and a lot of other professions. We're also having the question of shootings and mass murdering and, in sometimes inexplicable, but in sometimes, coming from a particular condition. And I'm just thinking about that little ad that's on public radio often, somebody solving previously unsolvable problems. And the thing that you're saying is there are, in fact, examples and instances where first giving ourselves permission to say that is seemingly an unsolvable problem, but if we apply a new way of thinking, it's possible to solve it, like predicting suicide. I mean, for parents and loved ones, for everybody, this the grief, the destructive aspect, all of that, predicting mass shootings. Right. I mean, the use of social media tracking and all that, we know there's little bits, but you are giving us some examples, but also some concrete ways that you've been, I would say, adjusting elements of your entrepreneur life into the life that says these pieces are part of creating that future. You opened our discussion by saying, creating a pathway for those who come behind us. We're just about out of time, and I want to take this moment to ask you, you've been inspiring us to think differently and to expand ourselves and say, what are those things we need to figure out? And here are some tools that can help us, giving us some inspiration about how we tomorrow morning keep that inspiration and start asking those bigger, maybe previously unasked or afraid to ask questions, and how this technology is in fact moving ahead in ways that can give us that new opportunity. You're in the middle of that. give us some words about how to think about it tomorrow morning.
Sure. So I tell this to everyone around me, and especially the ones I can inspire the next generation. I said, be curious and open to technology, right? Not all technology is bad. Try it. If you don't like it, it's fine, but give it a try and see how it can help you. Yeah, there are bad sides to every technology, and we need people in responsible places that are monitoring it and controlling it. But there's a lot of good that can come out of it, and maybe the start of something good or better. And to the younger generation that's in medicine, and to the ones in the current medical field and technology, so there's this event, AI Med North American Conference, in May 24th through 26th of this year, next month. If you are at all curious about this space, and you don't need to be a technologist, you don't need to be a physician, just you want to learn what is happening, what has worked, what hasn't worked around the world, it's a great, non-threatening place to come attend and learn about it. And I would say it will inspire you in many different ways. And so, and it will shape our future one way or another. And I would encourage people to say, hey, utilize what's good out there. And we have the responsibility for the next generation, their health, the planet, and everything that comes with it. And so we should be inspiring and directing them to say, experiment with this, be open to it, and really make it your future.
Geo, thank you so much for those words. Thank you for your work and for bringing this to light, and look forward to all the other ways we get to walk together into this future. Thank you again.
Thank you, Mark.
Bye now.
Bye.
Wow. So beginning to think into a new way, beginning to imagine problems that we could tackle and new opportunities that are in front of us, that intersection with the physician and the engineer and the computer scientist and all of those things. It's been throughout the day that we've been hearing about how these different possibilities to accelerate health equity by design intersects with many different things, including medical education, how medical schools and how our doctors and other clinicians are trained being part of a much larger conversation. And we're really, really fortunate today to be joined by two of the people who've been making that change happen at one school and now have connected that into a network, including our own University of Minnesota. This is an opportunity that's very rare, and I am thrilled. Dr. Leona Hess is the Director of Strategy and Equity Education at the Icahn School of Medicine at Mount Sinai in New York. And Dr. David Muller is Dean for Medical Education at the school. They met a few years ago in a new connection, and that combination of different experiences in different parts has led to a transformation that I'm so excited that we can hear about and talk about here and now, into more of a network and a movement across the country, answering some of those things we've heard throughout the day about what does it take to change our design to accelerate health equity. Dr. Hess, Dr. Muller, please join me on the screen and welcome. Welcome to Minnesota and to Global Minnesota's World Health Day. We're thrilled to have you here, and maybe you could start out by giving us just a sense of how your collaboration has come to be. Dr. Hess, you've got some slides. You got them up?
I'm trying to get them up right now.
And we're familiar. Hello.
Yeah. Oh, there we go.
Great.
And I'm just going to say, by way of introduction, first of all, thank you. I mean, we deeply appreciate the opportunity to join this exciting session and this incredible audience and the ability to share the work that we've done. It was a little weird, Mark. You described our first encounter as something sort of mysterious, and it wasn't at all. Leona is someone that we in the medical school first brought on as a consultant to help us work on our own racism and frankly our own communication and leadership skills. And it didn't take as long as a year for us to figure out that she needed to be a full-time part of our faculty and leadership staff. She just had that kind of an impact on us. So we didn't bump into each other at a cocktail party. I didn't want people to feeling anything like that. David Muller, Dean for Medical Education here at Mount Sinai. Clinically, I'm a general interest. I practice primary care and take care of people who are homebound. Leona, I don't know if you want to say a word about yourself before we jump in.
Sure. As a senior director of strategy and equity, I'm a strategist and systems thinker. I come from the socio-medical sciences. So I'm excited to be here and present the wonderful work that we've been shepherding.
So I'm going to kick us off. Leona and I will tag team a little bit. There's a lot of, even if you look at the title of our talk, medical education is in there, anti-racism is in there, transformation. We're going to talk about some terminology that probably lots of folks are very familiar with, some folks are less familiar with, and some of us may have just begun to scratch the surface. I think Leona and I also want to make it clear, since this is an international audience, that the issues that we're talking about are probably very, very different in the United States in terms of racism, bias, white supremacy than they are around the world. Not that we don't share many commonalities, but it is our sense is that it is extreme here more so than in lots of other places in the world, and that it has imbued everything that we do, including, sadly, medical education. So the agenda is here. We're going to talk a little bit about water, actually culture. We'll talk about types of change before we dive into transformational change. We will share what we call a change process roadmap, which is something that Leona has brought from outside of the biomedical model into medical education. And then we'll end up talking about what Mark alluded to, which is the network we're now sharing this model with across North America. And so on the next slide, we want to, just for the sake of framing, the first few slides will really be framing to give people who are not as familiar with medical education a sense of what we contend with. The little cartoon on the side we love, the one fish asking the others, how's the water? And the two fish saying, what the hell is water? I have no idea what that is. I live in it, I breathe it, I swim in it every day. It provides me with my sustenance. I didn't even know there was such a thing as water. And that really is the way in which not just we, but lots of people frame culture, the culture within which we function. The graphic here, sorry, go back one. The graphic here that we put up with these sort of moons revolving around the planet medical education. And we'll define these terms a little bit, but don't want to spend a ton of time on them. So we are in medical education very heavily influenced by scientific racism, which we'll talk about briefly, the biomedical model, which we'll also define, and then white supremacy or white dominant culture. That is the water that we swim in and that we always have throughout the history of medicine, not just in this country, but I think ever since there was such a thing as a provider or a practitioner. And so on the next slide, the first thing that we want to mention, and again, these are brief definitions, we couldn't possibly do all of them justice, is scientific racism. So also called biological racism, it's this pseudoscientific belief that there's evidence to support racism, which is that one race or one group of people with a certain skin color are inferior or the other group is superior. There's a little bit of a timeline here with some historical markers, but probably for folks on this, in this seminar, in this conference, you're very, very familiar with the way that science has wrapped its arms around racism and has buttressed it over the course of hundreds of years. And in the next slide, we want to touch on also something that comes much closer to the actual hands-on practice. How do we deliver care? It's this biomedical model that has been in place, certainly at least since the mid-19th century, if not before then. It's the way in which we as physicians think about disease, how do we think about illness, how do we diagnose it, driven predominantly by biological factors, often to the exclusion of other things that are listed here: psychological, environmental, social, but also spiritual. I mean, there's so much more that goes into what makes a human being. And that biomedical model has driven the way medicine has been practiced, thought about, and frankly, researched. And in contrast to that, the biopsychosocial model, which again, I won't go into the definition in detail, but obviously provides a much broader, more holistic spectrum of things to think about when we think about our patients. So we have scientific racism, we have the biomedical model, and then the third moon, if you will, that was orbiting around our planet is what we want to talk about next. And so before we introduce a conversation about white supremacy culture, we wanted to reinforce this concept, what the hell is water, beforehand. Culture is powerful precisely because it is so present and so very difficult to name or identify. So if you were to ask someone in a typical medical school or academic medical center about racism, it is essentially invisible to many, many people. It's certainly not invisible to people of color, people who live it and breathe it every day. But to many of the rest of us, we just sort of shrug and say, what racism? The system seems to work beautifully. And so that culture is something that a group of people in medical education, in our case, believe deeply in that culture. We value that culture. It's how we define what's normal and, of course, what's not normal. It's how we define quality and value. And it drives everything that we do, every decision that we make, every conversation that we have. That culture in medical education, but again, we want to reinforce it's not just medical education. It's all of the medical profession. It's all of America, is driven in large part by white supremacy culture. And in the next slide, we want to dive a little bit into that. Again, we're not going to really be able to do this justice, but without this framing, none of the rest of the work necessarily is going to make sense. So white supremacy culture is the widespread ideology that is baked into beliefs, values, norms, etc., as you can see here, of groups, communities, towns, the nation, that teaches us overtly, uncovertly, that whiteness is value. White is right. The white way to do things, the white way that things have been done historically, are the things that hold value in society. It is also, to a large extent, the unnamed political system that's made the modern world what it is today. And political here is not to speak specifically only about politics, but political, economic, social. White supremacy, the idea that white is right and makes the most sense, is what drives a lot of the behaviors, certainly in academic medicine and medical education. And in the next slide, we use some of the incredible research by Tema Okun, who begins to break it down into these 15 characteristics. Now, this is not the only way to define white supremacy culture, but it's certainly, from our perspective, a tool that we have used that brings it down to the granular level of what are people doing? What are people saying? What are they thinking? How are they behaving? How do they interact with and treat each other? That drives this idea of white supremacy culture within medical education. If you're on this call and you're from any other industry, any other academic background, this should look very familiar to you. It's true in the corporate world, it's true in law school, it's true essentially everywhere. The paternalism, the power hoarding, the defensiveness if you bring up something that's a little bit outside the norm. And again, we couldn't possibly dive into all of this, but just by way of background, we wanted to walk you through the culture that we deal with in medical. Take it for the next few slides and talk about our approach to change.
Thanks, David. I mean, one of the things to think about, we always, it's important to name and identify the water that we're swimming in, because it dictates then what is the change, or what kind of change are we really talking about when we want to transform, whether we want to address health equity, whether or not we want to become anti-racist, whether or not we really want to meaningfully disrupt racism in our institutions. And I think this has always been helpful for us to think about the process. And if you're designing change or thinking about change in your institutions, what are we really talking about? And, we're not talking about developmental change, which is really just thinking about, this is like quality improvement, where you're trying to, change a particular process or a procedure, and therefore it is more effective, right? Or it's more efficient. And that's more developmental change. And we can't treat social systems or oppression with developmental change or transitional change, which is really just moving from the old state to a new state, and where there's a transition state between those. And so, a good example is, working remotely or working in hybrid teams during COVID. We have some idea or notion what the new state could look like, because we know that people need to access tech, or we know that they need to access, the things that they needed to access when they were in the office, right? And so we're really talking about this transformational change, and transformational change is radically and fundamentally alters the culture, and we're really getting at that piece. Therefore, the future state is really unknown, especially in our case, in terms of our school. We can't necessarily say and define today what an anti-racist medical school will look like, because we're not there yet. We haven't been able to uncover. Now we're on our way, and we're designing processes to get to that point. But we also acknowledge that part of on our way means this emergent and re-emergent process. And so, as you can see, the transformational change graphic down on the lower right-hand side, there's this birth or momentum towards wanting transformational change. Maybe there's some growth, and maybe there's some success that you have. Maybe you're implementing an intervention, or you discuss an approach or a change to thing, or you declare that you want to become anti-racist, and there are people who are bought in and on board. And then it's just really important to recognize the chaos and wake-up calls that happen through transformational change, and really thinking about that emergent process over time, and really understanding how can we identify these breakdowns with the breakthroughs, and really understanding how are we emerging to become anti-racist. So we approach this as a process, which leads us to the notion of, so what is then our design around this? How do we design an intervention or approach? And it really is the core of what we're doing in our medical school, is really thinking about the change process roadmap. And so David later will talk a little bit about why we call it a roadmap and not a strategic plan. But essentially it's moving through these 5 phases. And so today we're gonna, for the remainder of the time, just walk through and give you some examples of how we've designed each of these phases. This first phase, which is assessing readiness to change, and I just want to acknowledge sometimes when we declare that our institutions need to change, and then we jump in, we say, okay, we need training, and we need to change these policies or structures right away, without acknowledging that what is the level in which that perhaps we're ready or not ready to embark on this particular, on any type of change, but in our case, anti-racism or leading towards anti-racism. And so we spend time assessing readiness to change, and you'll see with each of these phases, we always offer a paradigm shift. And our paradigm shift is really important because part of this work is really transforming the status quo. So just acknowledging that organizations don't change, but people do. And so individuals must be willing and able to put new mindsets and practices in place for the change to happen. And so we can change structures. Absolutely, that's an important piece, but really getting down to what are the mindsets and practices. And so really assessing that beforehand. Can we intentionally design around looking at readiness and just acknowledging kind of the complexity of readiness? And as you can see here, there are really 4 areas that people can demonstrate that they're ready to change in very bold and subtle ways. And so some of the things that we've been doing now and working with some of the medical schools is just identifying what's the emotional readiness, the mental, the physical and behavior, the spiritual or energetic readiness, and what are some of the factors that are playing a role in our culture if we really do want to see cultural shifts. And we can recognize these in our stakeholders, and these are really good also measures of whether or not there's early indicators of progress towards transformation, which is sometimes really hard to see because it's ambiguous and we can't necessarily, measure our impact in a year, right? And so I think it becomes really important to be sophisticated around identifying these various readiness.
So phase 2 has a paradigm shift also. And I think one of the things that we are really challenged to acknowledge in medicine, and this may be true in lots of industries, is that we move very fast and we push very hard. We are trained to diagnose illness. We are trained to come up with a treatment plan. We're trained to intervene, to cure, to comfort also, but all of that is very, very linear. You are faced with a set of problems or a set of data, you figure out what the solution is, you fix it, you move on to the next one. And that bleeds into everything that we do. It bleeds into our organizational culture, going back to that word. And it also means that the way we think about things when we address a paradigm like racism is typically driven in a very linear fashion. And so the paradigm shift in this slow but meaningful and persistent preparation for change is letting go of the need to tightly control a change process. There's nothing linear about what we're talking about. Racism is not going to go away because we figured out how to check that box, or as Leona said before, we figured out exactly the right training. We've got to let go of that tight control, the need for a tight control. At the same time, acknowledge that there has to be some sort of navigation system or what we call a roadmap. And so this curve, the change curve you see here, is just one example that we wanted to offer of how this plays out, the idea of fundamental change, transformational change. Any kind of change, when it's announced at an organization, creates this sort of curve of emotional responses that people have. And again, if you've been anywhere where the boss gets up at some point and says, I'm announcing a new strategic plan, or we've brought on a consultant to look at our compensation model, shock immediately, denial soon following that, and then, oh my God, I can't believe this is happening again. If you've been at the institution for a long time, depression, frustration. If things go really well, people start to come along. They decide that maybe this is worth pursuing. They dip their toe in the water. They're willing to experiment with it a little bit, and then in the best case scenario, there's some integration. But along the way, this is incredibly complex and does an enormous amount of harm. And so instead of taking that very linear, task-oriented, we've got this figured out and we know the right way to do it approach, there's a roadmap. And so in the next slide, we demonstrate the 5 phases that Leona showed a little bit earlier, not to go into them in detail because you can see this is rich with content, but to demonstrate that this takes a fair amount of time. With each one of these phases, you can see each box describes, and these slides will be available. So if you're really interested, there'll be plenty of time to peruse it afterwards. Each of these boxes represents either individual work that each of us has to do. Some of it is reflection, some of it is actual work, or work that's done in a cohort of people who are really committed to being the drivers of change. And in each phase, those 5 or 6 activities help to build, to lay down, if you will, the building blocks of what it will take to work through very gradually, very systematically, laying the groundwork. It's almost like you're planting a garden. You're not going out to the greenhouse and buying a tree and plopping it into the ground. You've got to make sure the soil is ready. You've got to water it and fertilize it. I'm not going to go into the allegory more than you absolutely need to, but that is a fundamental shift, certainly for us in medical education, of how we take upon ourselves the idea that something has to change. Before we even think about what it is that we're changing, we've got to do a lot of work to make sure that each of us individually and some of us in cohorts are actually prepared for that change. You get at some point to phase 3. The paradigm shift in phase 3 is that you can actually intentionally create an environment and a strategic network, which is essentially a neighborhood, a collection of friends and allies that is conducive to embracing that change. You don't just stumble upon it. You don't just hope that it's going to be there when you arrive. You can intentionally take steps to create that environment so that when you're ready to talk about things that may need to change, it is ripe for that. And so what we've demonstrated here, and again, as you saw in the slide before, each of these phases is quite complex. Here, what we've demonstrated is the critical part of phase 3, which is moving away from an initial small cohort of very dedicated people and creating a broad-based guiding coalition that represents a full cross-section of the community you want to influence. It's not going to be everyone. In our case, it's not the entire health system or hospital. It doesn't include our graduate school that trains PhD students. We stuck to our medical education program, the MD program. But in your institution, the community you want to influence can be broader or narrower. What you end up with is a guiding coalition that for us is constituted by these 6 spheres, sorry, I lost count. And this just demonstrates how far reaching we chose to make it. And you can see that it can be constructed in lots of different ways. This guiding coalition needs to be fully representative of the people whose lives are touched by racism and bias. That has to include, of course, students, of course, the faculty and the leadership and the staff. And the staff is not just people who are in administrative leadership roles. It's the staff on the ground. It's the frontline staff who are often, frankly, overlooked, maybe even ignored, whose lives every single day that they come to work are impacted by racism and bias. And so we've made sure in creating a guiding coalition, and this is an important part of phase 3, to reach as broadly as possible and bring into the fold people who are self-selected, people who are very motivated to the guiding coalition. Creating a guiding coalition is not about pulling in people who are resisting. It's about bringing in all of the strongest allies and friends, people who are eager to do this work, putting them around a table and beginning to think about what that change is going to look like.
Now that brings us to phase 4, which is engaging and enabling the institution more broadly. So this is even beyond now that guiding coalition. And so really the paradigm shift here, something that we had to acknowledge, is really focus efforts on identifying the root causes and uncovering the patterns, the supporting structures, the mental models, the cultural and institutional values that underline the events or problems that we're trying to fix. And this was definitely a paradigm shift for us, I think, in medical education. Often what happens is that there's an incident that happens, and then we go to fix that problem, and we want to be able to address it. And then maybe there's a particular action or event that we're going to address. And then we move on to the next thing. And so really that place of just constantly responding to events is very reactive. And so our job in the very beginning, with actually hundreds of people in the medical school, as David mentioned, all of those different stakeholders, was really to do an analysis, to go deeper into the iceberg, to really begin to uncover what are these patterns that are perpetuating or causing these events? Because there are patterns, especially as it relates to systems of oppression, right? There are patterns. What are the underlying structures that are then producing those patterns? And then what are the mental models and our behaviors and the institutional and cultural values that are driving and informing our mental models around it? And so when we really went kind of the deepest, in the iceberg, really is where we find the transformation. We want to be able to transform our mental models and our cultural values, very similar to what we discussed when showing the transformational change graphic. We want to be able to get to a process of finding the emergence and becoming anti-racist as a process by going as deep as we can go in this model. And so we all did an interactive exercise with hundreds of people in the medical school so we can really understand how we can better anticipate some of the patterns, we can design or redesign or deconstruct some of the structures, and then what are some of the new mental models that we need to introduce and the values in order to align ourselves towards transformation. The fifth And final phase is really thinking about implementing and sustaining change. So now that we have a plan, we've identified those root causes, we're getting back to really understanding, so what's our, vision towards the change? How are we going to begin to align ourselves to do the work towards the change that we want to see? And, one of the things, or the paradigm shift that we're offering, is that the deviation from that plan or from that roadmap isn't the problem. The real issue is how quickly we can spot the need to course correct, learn from those situations, and then be able to change course along the way. And this is what makes it very different from a strategic plan, which tends to be very linear. It's like, if we didn't meet our outcomes and we failed, this is acknowledging kind of that emergent process through chaos and breakthroughs, where we acknowledge what our current reality is. We know that there's a transformational process. We're followed by a roadmap. So it's not like we're not aligned with something, we're following that North Star of the vision that we have. And along the way, through the bumps and the chaos, that we are course correcting when new things are introduced into our system, and really thinking about how are we going to then learn and continue the course always towards that vision. And for us is to become free of racism and bias in our learning environment. And so we constantly kind of hold that as our North Star. So now that brings us to, so those were the phases of our transformational change or change management strategy that we've employed. One of the things that we have been excited to introduce this year, or the end of last year, is working with 11 medical schools and what we call is the ART in Med Ed, which is the Anti-Racist Transformation in Medical Education. We received funding from the Macy Foundation in order to engage 11 medical schools to capacity build and build their capacity in order to implement those, the phases that we just reviewed. And, we really are really excited. This is the map of the 11 medical schools that we're working with currently right now. And all of them, which is really great, is that one of the things about the roadmap is it can be very responsive to each environment. So because it isn't very didactic, or it doesn't allow, like, you have to do these steps, we're really learning a lot about how the different environments, the different types of medical schools, there's public medical schools, there's private medical schools, there's small schools, there's big schools, there's geographic location differences. And so we really wanted to, engage schools to see, what works, what is working, how can we then collectively as a community of practice move towards transformation, that it isn't just our school or this model, but really a movement. And so the aims of our Med Ed is, one, to do the capacity building, which I was talking about. And then the second one is building that community of practice to promote that shared learning, to dismantle racism within and across medical schools, because we acknowledge that it isn't just our school. It really is looking at, in this case, medical education, but it can be applied to medicine, the health professions, really thinking about that. We're actually thinking about, we've got asked about nursing school, right? And so we are dealing with, similar and different environments. We also wanted to see whether or not we can replicate it or scale it to a larger, for instance, all medical schools or other health profession schools. And so we really want to understand the conditions that this change management strategy for transformation can be replicated, and really identify the features that yield the best outcomes. What might yield outcomes for us doesn't necessarily apply to others. And so we were very intentional about looking and evaluating, assessing this across the medical schools. So I think that we've come to a close of our presentation. I think I don't know if there are questions, but I will stop sharing my screen.
Fantastic. I mean, there's one that sort of jumps right out, which is, you mentioned thinking about other schools, all schools. You mentioned nursing, which of course is a huge profession in its own sort of crisis. You are starting with this first, the 11 school cohort. Is there a plan that takes you into any of those other defined parts of medical education?
Go ahead, David.
Leona and I can never decide who's supposed to answer which question.
Yeah.
So
we have time.
There's no plan. There are aspirations. Obviously, we would love to see this have the desired impact on the 11 schools that have started. We've had already inquiries from individuals, institutions, and actually from the Josiah Macy Foundation, which is funding this initial project, to see if or when we will be ready to expand. I think we want to give ourselves at least a full year in to get a sense of whether this is a model that is working and has potential. And then if we're going to expand, I think we would, I can't speak for, I can speak for both of us. We would love to do that, but it would require the kind of infrastructure and support so that we can do it well. The last thing we want to do is a half-baked effort and leave people kind of dangling with something that looks like a bunch of cool PowerPoint slides, but not the kind of support that's required to do this in a lifelong fashion.
And have you, in this relatively short period of time, but begun to notice differences? You've got schools in Saskatchewan, you've got schools of osteopathy, you've got some diversity there on that map. Too early to tell, or there's some things that you're picking up already?
What's really interesting is one of the things that, when we were assessing readiness to change, one of the things that we looked at is what is some of the language that we're using? Are we saying DEI? Are we saying health equity? Are we saying anti-racism? Are we identifying whiteness? Are we talking about white supremacy culture? Like, where in our institutions, what's the approach of each institution? And, some were kind of all over the map, and we looked at different areas. Like, what do we say to donors? What do we have on our website? What's in the curriculum? What's in, our promotional material? And so one of the things, and so that was across the board. There was some variability. Maybe there was some kind of, West Coast, East Coast phenomenons happening. However, what was fascinating is when it came to white supremacy culture, whiteness, or talking about it, it never was embedded or baked into any of the materials across all of the medical schools. Oh. And I thought all of the medical schools, and one of the things that we began to talk about is unpacking why that is, and in places where it might have leaked into, for instance, the curriculum, and who was the driver of that? Was it the students and their advocacy around using and naming what is happening in the water that we're swimming in, which I think is so important because, and that's one of the reasons why we started off with that today, because it's so important to name that the water that we're swimming in, because I don't think it necessarily has the type of attention that perhaps we need in order to understand or make the case for transformation.
David, you mentioned that there's a regular sort of webinar or conversation series or monthly series. Say some more about that.
We started several years ago. Leona, it's her brainchild, Chats for Change. Which are informal, I'd say semi-structured, meaning it's an hour long. Anyone in the institution can come. We pick the topic, or we solicit ideas for topics from folks in the community. We provide maybe 10 minutes, 15 minutes of framing. And then at least 20 minutes, we break everyone into small groups of 4 or 5 to dig deeply into the topic using a couple of sort of trigger questions. Then we come back to debrief. It has gone so well here within Mount Sinai that about a year and a half ago, I'm looking to Leona, we decided to do it nationally. And so every week, there's a Chats for Change within Mount Sinai. Every month, there's a national Chats for Change series. We had the April session just this week. Leona and I co-facilitated. There were 125 people from all across North America.
From the 11 or from everywhere?
Anyone. Wow. Everyone is welcome. Yeah. We've had people, we've had students who are applying to medical school find out about it and join conversations. And they're just incredibly stimulating. I think people so appreciate the ability to talk about topics that are sometimes really taboo to bring up in their own kind of professional environment. But it's all of us professionals coming together and sharing the fact that these concerns cut across every institution, every state, every clinical practice,
Everywhere.
staff. I mean, yeah.
What was the topic the one that you just did, just for instance?
So the last 6 months, the theme has been say what you mean what you say.
Mm-hmm.
So we've picked things like, for example, white supremacy culture, which was this month, critical race theory, which was last month. Things that are out there, they're sort of become jargony. They carry a lot of weight. In a lot of institutions or environments, you're not even allowed to say them. And if you say them, you just start to make people completely crazy. So we wanted to create an environment for 6 months where we picked 6 hot topics, and we asked the audience each month, give us some other ideas. What other topics do you see us discussing that are off limits, so to speak, at your institutions, and that we can sort of dig into here and maybe bring back to our home institutions and figure out how to put them front and center when we have these conversations.
So it seems like you use that model internally. Every week is a lot. I appreciate like what the work is here that we're talking about, the hours, the days, but it had proven one way, and then you tried it out and it's a safe space and it's having some of the same, kind of benefit. In that way, are there other sort of general things that would maybe in the old days when we were COVID might happen, but a gathering or a particular professional event that attracts people? I've got a couple, well, at least one pre-med coming on in the last segment of the day, these young people that are organizing around health with their colleagues. And so I'm just thinking about the mechanism by which that attraction and that inspiration can take place. And you've got it in a Zoom format or something. Are there other things that you're thinking about that would be magnets like that, safe place magnets?
Leona, what are your thoughts?
Yeah, I mean, I think, what's interesting is that we formally started this process doing these 5 phases in 2018 and getting kind of that going. And we did have events locally where we invited, because part of this work is also breaking down the silos. What's really interesting is that there's people from across the institution who's coming together who would never meet otherwise, right? Because if you think in medical education, where are the places in which people are congregating from different kind of areas, right? Or different professions, different locations, it actually is very siloed. And so we did do that initially, and then COVID happened. But the benefit of that is that we could offer things that could invite national, which we weren't thinking even national at that point. And so, or even globally, I think we've had people who were working remotely in other countries who were calling in and participating in Chats for Change. I think ideally what's going to emerge over time, especially working with the 11 medical schools and building that community of practice, I believe that what's going to emerge out of that is more convening together and having forums, whether it's a conference or gathering or some type of information sharing around some of the key topics. Like one of the topics that we're even exploring now that cuts across all of the schools is compensating students for anti-racism work. Or what does the curriculum look like when we want to embed kind of principles of anti-racism, or whether or not health equity is at the core, or whether or not we want to address some of, even in like the Patho-Phys or other courses where hasn't been traditionally talked about, or racism hasn't been integrated, or social determinants of health. So I think that there's like a really interesting moment, and I feel it percolating. So I think that's definitely to come.
And is there a faculty chat for change? In other words, they're students, and I don't know all the different components, but it seems like maybe in the 11, there might be special faculty who are especially interested, or
So that's the beauty of Chats for Change. It's everybody. So
Mm.
you can be in a breakout room with a hospital president, a faculty, a student, an executive assistant, or maybe the person who works the front desk. And we're all engaging because we can all engage in racial dialogue. We can all have a conversation from our lived experience. And so that has really shifted, and that was intentional in the very beginning, in order for us to really break down the silos, for us to change our mindsets that you can only learn in this particular way. You can actually learn by, for instance, racial dialoguing. We can build our awareness around it. So we intentionally designed it to have mixed groups, and it's worked out really great. Like we just had a dinner with our fellows, our anti-racist, because we have a fellowship program for students. And one of the things that they identified was that Chats for Change and these types of forums is some of the only forums where they can actually have exposure to a lot of different people.
Wow.
Yeah.
Yeah. I mean, you're in medical school, you're a little busy, right? I mean, I could picture it. Having this opportunity to create a living model and then to have it carefully tested and some other things and then expanding out is quite a gift to the nation, to the planet. Is there appreciation of that in enough quarters that it's getting the love and the nutrients and the resilience planning that can maximize its impact over the next 20, 30 years?
I'm only smiling because I feel like saying, Mark, say what you mean and mean what you say.
Hey, come on, you guys. Are you taking care of this puppy? I know you're relatively.
Has anyone given us $1 million yet to do this on a really, really broad scale? No,
well, yeah, and I know that you are different ages, all right? So I think about the process of long-termism has elements, $1 million or $100 million or whatever, but it's a combination of things that make them 30, 40, 50 years. And you two are birthing a special thing. And then the rest of us can say, oh, that's going to be a benefit to the whole planet. So how can we help? And then one part of that is you guys are thinking through some aspects of this, and you've got a foundation that's interested. But to nurture something as big as maybe all medical schools or whatever also is, as you said very clearly, you need the money and the infrastructure. I mean, that's a big project. That's, it's a big project now. So part of, World Health Organization has been around since 1948. It's pretty good size, probably not doing this work yet, but you know what I mean? The advancements that we're seeing in just, communities or countries that are just, thinking differently about so many different things means like almost every presentation from today talked about the special moment that they're in, that something really different, something, in a completely new opportunity is in front of us. Do we take advantage of it? And you are. Then do we sustain it? A different question. And so you're making me think about all the things that people do and think about, like, does the Congress have part of the national budget that is dedicated to things like this? Are there foundations, or is there endowment, So maybe it's to say that towards this moment when we're almost out of time, I like to think about, how can we make sure? And then I'm happy, I can think about how I could be directly involved, but then it's that bigger picture of how do all of us, make a contribution. And I have to say, medical schools are impressive in their ability to raise money sometimes. Hospitals, impressive. And so, you know what I mean? So we're in a category that says this kind of change has real meaning and real possibility for the long term. And so how might we next year on World Health Day have like a new vision of how this is. So you've been inspiring a bunch of people. I know there's one pre-med been watching this for sure really hard. And I'm wondering if you could leave us with some words that can help tomorrow morning think about how those who are inspired to make change back where they are, whether it's a medical school or some other place, words that'll get them up and going tomorrow morning.
Leona or
David, you can go first, and then I'll go.
Yeah, I'm going to say, and partly in response to my tongue-in-cheek $1 million, $1 million would not help us. Not because we need $10 million, but because it's not really about that. It's about role modeling how to be different every single day, so that it spreads ripple effects of that. And so that when Leona leaves or David leaves or anybody leaves, it's sustainable, not because there's an infrastructure and a project manager, but because people just think differently, they speak differently, they work with each other, they make decisions differently. The culture of the place, the water, has changed in a way that doesn't depend on an individual or a grant. It depends on the people, because the kind of people who come to that sort of institution want to be in and sustain that sort of an environment. It's the way they want to be. That you can keep your $100 million, because if we don't have that, the $100 million is going to get spent pretty fast on nothing. Leona?
Yeah, I just want to, I think part of this process, and, whether you're a student or administrator or a staff or working in medical education or not, and really thinking about it being an emergent process. Now, we always have to respond to events and crises. That's important. And we also have to understand this long trajectory of this consistent and persistent transformation. And part of that is going to change the landscape of medical education. And it's slow, but it is emergent. And so looking out for those levers of change, looking out for those bright spots, those places where you can, really accelerate that change, they're there. And I really do believe that there is incremental change. I really do.
So both of you at different times in our discussion mentioned places or events or things where people who are watching could plug in after. Could you repeat those just so that people could hear it and write it down? And also, there's a way to find you and that kind of thing, because I think people will want to follow up.
Yeah, we have a website where you can access the anti-racism transformation in medical education. And if you just Google that and Mount Sinai, it will pop up. You'll also see some of our videos talking about it. We have a paper in academic medicine if you want to learn more about our process.
And that's a journal. That's a journal named Academic Medicine. Okay.
Yep. And that's addressing and undoing racism and bias in medical school learning and work environment. And then if you Google Mount Sinai, National Chats for Change, you will find the schedule. although the schedule is not up to date, it will be up to date next week because our person who updates it is on PTO. But we have a bunch of new topics that we're coming up with once a month.
And is it appropriate for people who saw that map and are near or somehow familiar with to contact other members of the cohort? Is it at that stage of development, like writing to the University of Minnesota Medical School, Dr. Toller, and saying, hey, I'm very interested, please keep me informed? Or is it too early for that kind of decentralized organizing?
I mean, I think that if people are interested, they should reach out to us.
Okay.
Not
Perfect.
to the exclusion of those other schools, but those other schools are all still working within a small cohort of 10, a dozen, maybe 15 people. Lots of people at those institutions are not as familiar or frankly have no idea this is going on yet. So if anyone's interested in more information or interested in an introduction to the people at those institutions who are doing the work, we would be happy to provide that. I put a bunch of stuff in the chat, but I don't know if everyone who's on this session has access to that.
Well, no, but what because of people watching it from different platforms.
Sure.
But one of the things that we can do is for all of you watching who haven't registered, please do. But we will provide those
links.
kinds of things
Great.
out. But it's exactly what I needed to know. For now, it's sending people your way,
Yep.
and as this builds out, because we wanted to do. You know, there's I think say in our community in particular, high level of interest, but there's also just a lot of other things going on. This has really been wonderful. Two things. One, just your process and what you're doing and the change that you're making. But second, just the inspiration that, you know, many people have pointed out just how hidebound is a funny old word, but how difficult to make change in medical schools. I mean, you know, just the words are used are dramatic about how hard this must be. And they're also superlative about the change that you have made. And I, for one, know what that level of work just might have been like. And it is a giant task that you've, you know, started the process on. So thank you from the future generations that aren't here yet and from those of us that are. And I look forward to keeping up with you, but also with their university that's right here in my backyard. So thank you again for joining us today, both of you.
Thank you. And thanks to Amy and Dawn for keeping up with us.
Yes, aren't they great? Aren't they great? Yes.
They're
all right. Chats for change. Here
Chats
we come.
for change. Great.
Bye now.
Thank you.
Bye.
Take care.
Wow. So many times in the morning and other sessions, people have talked about needing to change this and to change that about medical training. And, you know, we've heard it in so many different ways. It's so exciting to hear about that change taking place, happening, being put together, being, in fact, part of that process right there. So we will get some of that additional information out. And of course, they mentioned Mount Sinai, you can find them. The part of this day that's been on my mind, but also one of the more enlightening and stimulating part as we were putting today together was noticing that more and more there were next gen organizers, we called them accelerators, but people who were taking matters related to health equity into their own hands with their cohorts, their friends, but beginning to build out organizations, affiliation groups, just the kind of things that we would call basic grassroots organizing, but in the process of changing matters within the broader health and wellness world, and doing it in a way that's inspiring, but also says, oh yeah, there's a next generation coming and more change is on its way. And so one of those is Tom Murickan. Some of you earlier met his father, who's one of the people in Med AI, who is been a national and international force. But his son started organizing high school clubs, Med AI club in high school, and lots of young people who talk about data and think about gaming and all of these things got involved. Pretty amazing footage of that. But Tom is now a pre-med student in a bioengineering program at Arizona University. They have a Bio 5 Institute. He's a new and active student ambassador for AI Med, research assistant doing his own biomedical research, but he's also been organizing on campus and on other campuses, getting more other pre-med, other biomedical, bioengineering students involved. And he had a class at this time and couldn't miss it. So he was kind enough and generous enough to record. And so we're going to hear from our first accelerator, our next gen health equity leader, Tom Murickan from the University of Arizona.
Thank you so much, Mark. That was an incredible introduction, and I could not be more glad to be here.
Well, so Tom, first give us a sense of how you first began noticing AI was just kind of lingo for a while, how you first began noticing that this needed attention, and then how did you get started organizing and educating and reaching out on this very particular, very important new development?
Absolutely. So in terms of my introductions to the whole concept of AI in healthcare, that stretches back to the summer of 2018. It was during this time that I participated in an internship at the Children's Hospital of Orange County under one of my greatest, most respected mentors, Dr. Anthony Chang. This particular internship focused on AI in healthcare and how AI was going to be creating these huge strides in for the lives of physicians of the future, like myself. And this internship was incredibly eye-opening. I got to hear from a variety of physicians, nurses, data scientists, engineers who brought their experiences to the table and shared with us how they saw AI shaping their roles and their future trajectory as well as ours. And I think the particular moment that solidified how incredibly important it was to learn as much as I could about AI and its future in health, its future for healthcare, was when the internship concluded and I came back to school, beginning of my junior year, and I started talking to a bunch of my friends who were also pre-med, and finding that they were all stunned and amazed by all the concepts I was talking about. But the big resonating statement that I got from all of them was that I had no idea that this was going on, which forced me to reflect. Prior to the start of the internship, I also had no idea how incredibly essential AI is to not just healthcare, but just so many industries moving forward in general. And as someone who's been invested in becoming a physician since I was 5 years old, it was just truly shocking that I had no clue how important this was to my future and to many people I knew. And so started the effort of what I called in high school AI Med Club, Artificial Intelligence in Medicine. And the whole purpose was to just spread this awareness to any interested pre-med or just pre-healthcare space students who wanted to learn more about how AI, data science, and coding, and a bunch of related concepts were important in our knowledge base in order to be successful in a healthcare career. And it was an incredible experience. We were able to quickly expand throughout my junior and senior year, bringing in guest speakers, many of whom I had met at CHOP and who were delighted to come and speak for the club, other professionals from around the Denver area where I grew up. And it was an incredible experience. And I just kind of took that as my passion, and I just kind of ran with it. Like you mentioned earlier, I've brought it to the collegiate level now, kind of upping up the name, the AMED Society, as we like to call it now, and with the hope of expanding it to other universities across the nation to, once again, just prepare the next generation of physicians for this huge wave of advancing healthcare. And as I'm sure many of you watching can tell, I am incredibly passionate about it. And I think it's incredibly important just for us to be able to not only invest in all sorts of technological advancements that we may see on the news on a daily basis, but also help to cut down on a lot of the administrative burdens and insurance details and a lot of things that are important parts of the healthcare system, but have been wearing out physicians for so long that we are now seeing the highest rates of physician burnout we've seen ever in the history of healthcare, which is incredibly concerning. And so AI has the power to, decrease that burnout and help return the physicians focused and the team surrounding them return their focus to just the patient care experience, which is something that has been the root of my passion for healthcare for so long. And so that's been my journey.
Your interest started before COVID hit. You've entered college, university on your way to medical school, kind of in the middle of COVID.
Right.
But it must be the case that, like in many of the technologies, even like the Zoom we're using now, there's been an acceleration, but also perhaps new directions and more particular things. is it the case that as you imagine going on now to medical school, that the opportunities that you've had because you have been interested and working and organizing will give you an advantage in trying to understand how the good parts can be enhanced, nudged along, supported, and how some of the challenges or some of the potential negative parts can be talked about in a way that then the whole society can benefit, not just a few.
Absolutely. I think it's 100% beneficial. And one thing that when I talk to, mentors of mine and fellow students is this journey of, kind of taking sort of my self-education and these opportunities into my own hands to help expand my horizons and push forward in this lane has been remarkably eye-opening for me. And I think it is incredibly important and beneficial in terms of, future career in healthcare, in terms of, allowing myself to understand these technologies and softwares that will power healthcare for the future. I think it's really great from a physician's standpoint and, a rising physician like myself, to understand these things because especially, as many terrible things have happened during COVID, one thing that it's forced a lot of people in healthcare and non-healthcare spaces is to, get together and just become more collaborative in solving issues. Solely just due to the fact that, we weren't in the same spaces physically. We were kind of forced to, adjust our schedules and get on Zoom calls like this and just stay on top of things, which has led to, within a healthcare standpoint, and I was speaking to you about this earlier, seeing a lot more projects develop, leading to a lot more publications, which has been a great thing to see. And I think for myself and for many interested students, seeking out an education that's supplemented by AI, whether it's through classes they take or through opportunities they seek out for themselves in research, industry, etc., is important because when it comes to a collaboration standpoint, when we become physicians or nurses or any professional role within a healthcare space, we are going to be collaborating with a variety of other professionals within a data science standpoint, public health, ethics, etc. And having all of that knowledge will help bridge that communication gap that's been present in healthcare for a little bit now, but now with a lot more physicians getting attuned to the fact that they need to be knowledgeable of these scenarios, they can much more easily communicate with data scientists and computer engineers that can help solve the pressing issues they see instead of without knowing the lingo and all these things, hoping that they're conveying the correct messages and then possibly the goals they're looking for are not being achieved. So I think it's really important from that standpoint.
Seems like a very hopeful vision. And I'm reminded of some of the sort of great stories in medicine, the sort of collaborations of things where people have come together, the creation of things like pacemakers, where you needed tinkerers in garage and you needed electronics, or the Mayo way is the way that we talk about the sort of team approach that some medical centers, especially led by Mayo. But it seems to me that those young leaders and young people in school that are watching today live, or we'll see this over the years in the archive, it seems like you are providing an inspiring image of both how you can stay cutting edge in technology and apply that to the healing art, the healing practice, the healing profession that we call physicians. And is there some aspect of this that you're able to share and get other young people who maybe thought about being in the medical care space, but they were really, technically talented and all of that, that you said, put them together, come with me, let's create a new future, put them together?
Yeah, absolutely. I mean, Gosh, I mean, there's so many examples. I think the most recent one is probably within the biomedical devices law that are working currently, which is all focused on both wearable devices and implantable devices that are, helping to solve pressing medical issues for patients. I work with a team of multiple undergrad students and a couple of PhD students, and we have a team composed of myself, my PhD mentor, and an undergraduate student who is just starting to apply to medical school just within these past few months. His story's pretty great. He had started out as just solely engineering based, and he did want to enter into a biomedical device capacity. He had a slight interest in it first, like you mentioned. He had that idea in mind, but a lot of his experience back in high school was really relegated to hard coding and statistical analysis. And so when he got the opportunity to join the lab his freshman year, he was a little skeptical. He was able to apply a lot of the skills he learned, but he just wasn't sure of the future impact that it might hold. The stories he tells me are, he heard of, how healthcare has been, a lot of stories, same stories I heard as a pre-med student, ironically enough, about how you have all this physician burnout. Now healthcare is kind of being stifled by, high administrative burdens and, some financial models for hospitals that are just not providing the best care for patients. And it was a lot of those stories, again, similar stories that I heard as a pre-med student, that were kind of preventing him from really delving into what he could provide as impact, creating these biomedical devices. And it was actually partly through our mutual private investigator, the head of our lab, Dr. Gittens, and then myself coming in with this whole idea of AI med, that over the past year, I'd say myself and Dr. Gittens kind of tag team on convincing this fellow student of how much potential working within the biomedical device industry serves, and the strides that it can make within healthcare, helping to alleviate a lot of these issues and make things a lot more convenient for both physicians and patients, right? I mean, when we look at wearables, it's amazing how far these things have come. You have devices that you just clap onto your wrist and it sends up data to the cloud. You don't need to do any fiddling. You don't need to do any manual entry. The physician gets everything through the cloud. They can search through. They get pings and alerts if something is off, and they can really reach out and contact the patient or the patient's guardian or parent. So it has so much potential to again really make things easier in the patient care sense and just create a lot of impact. And I think our stories and again the ways we tried to convince him were in fact so effective that he's now seeking an MD PhD degree, which is fascinating. He had always wanted to go into research, but now he's trying to do that double degree.
What a great story.
Incredible. So
I mean, yeah. It's a great story from a lot of points of view, but it also, some of those stories about burnout, that's one thing. Some of those stories about the medical model not making patient care, these are real things, and right. We have to, but you were in a situation where you could talk about what some of the solutions could be, and to really give a sense of what some of those new technological advances could do, and the combination got society to have another really smart young person going into medicine with skills to do many, many different things. And I'm been privileged in my life to meet some of the pioneers who, were the first ones on heart valves and the first ones on, pacemakers. And a lot of my work has been around things that relate to heart transplant. And so when you meet scientists, doctors, surgeons, but people who we're making the kind of advances that you're describing, it's really inspiring, but it's also a reminder of how human all healing and caring is. And I'm inspired, but also heartened by the fact that individuals like yourself, starting out at age 5, wanting to be a physician. Okay, that's a little bit unusual, but what's important is that now you're bringing these human elements together with the things that can help the humans called the caregivers and the humans needing the care or providing the care to themselves. I wonder if you contemplate much things like your own self-care and where you imagine AI might, help you out sometimes. You know what I mean?
Yeah, no, I definitely do. It's funny, I was actually just recently speaking to a principal investigator at the National Institute of Health who I'm hoping to begin a project with him. He's director of the National Eye Institute there, and a lot of the work they've been doing has been centered around using natural language processing and AI-powered models to help more efficiently diagnose, eye disorders and patients
through natural language diagnostics.
Exactly. Yeah.
Wow. Yeah.
I know. It's fascinating stuff. And as someone who does not have good eye health at all, it's been really fascinating talking with him and just seeing how again, it's something that obviously in terms of self-care it could help me, but more than that, just helps so many other patients like myself who may have poor eye health or are deteriorating eye health. And the other, I guess, quick point that I can mention as well is Dr. Anthony Chang, who I mentioned earlier, one of my great mentors. He is my younger brother's pediatric cardiologist and kind of served as my catalyst for a huge passion for cardiology as well. My brother was born with an atrial septal defect in the heart, which the month following his birth, he had to go through multiple follow-up procedures, which culminated in a successful open heart surgery. He's an amazing, energetic kid, love him to death. And I remember the first time visiting Dr. Chang's clinic, must have been like 5-6 years ago at this point, how he was showing me the small but really effective AI technologies he was utilizing just within, obviously through a diagnosis standpoint, using AI within his EKG and EMG modeling to quickly pick out abnormalities, if there were any, with his patients, so that he doesn't waste valuable time sifting through graphs, and he can spend that time, in the appointment with the patient, and then also using that to help streamline patient appointments and rebookings through his, administrative team there, so that they can also focus on the patients who are in the office versus constantly being on a phone or clocking away at a computer. And so, again, it's just been fascinating seeing the impacts, through patients within my family, my younger brother, and seeing the impacts it could have on my own health and the people that I care about, and just every patient out there. It's been a wonderful journey, and I'm excited to see where it takes me. So
that's a really, really great story. And, I have had every life is filled with things that take you into a medical emergency or take you into some kind of situation. And what I love about our conversation, and I'm sorry we're near the end, but what I've loved is just being able to understand about how being able to integrate inside your heart, inside your soul, inside your mind, but also inside your life, these different elements. And over the years, some advances have taken place, and sometimes we know that after wars, we talk about different phases when medical science of a certain kind jumped. The Vietnam War was one era, and other wars. It seems to me that we are perhaps able, and you will be part of the generation that can make this happen, be able to think of advances being taken place, not, oh, there was a war and we got to do A, B, C. No, there was more knowledge, more care, more tenderness, more concern. And we put that into advances that really made a difference. We're at the end of our time for today's conversation. How do young people of any age that you've inspired who want to know more about AI and med and your job and is there a place that people can really get some more information and can be in touch with the network that you're building across the country and with others around AI and medicine?
Absolutely. The two big resources I would recommend is the AI Med professional website. That would be ai-med.io. You have tons of incredible articles and links to online resources and multiple events throughout the year, including our flagship conference in May, which I'm really excited for. So definitely check that out. And the other one would be the Medical Intelligence Society. You just Google that up. They also have monthly events talking about innovation and just medical intelligence and how things are advancing, monthly journal meetings where you have tons of the greatest minds in research and industry coming together to discuss innovation. And I'd say, yeah, those two resources, definitely take that into your hands and explore as much as you can. It's a brave new frontier. There's so much to explore. And for anyone interested, I wish you the absolute best of luck in broadening your horizons and joining this community, because we're incredibly welcoming and we look forward to seeing you.
Great. Well, thank you for inspiring us, but also giving us hope about the future, that these things that sometimes seem not fitting together, you were able to do it, and a whole generation that you're helping to be part of. So thank you again, Tom, and thank you for being part of World Health Day 2022 here at Global Minnesota.
Absolutely. Thank you so much for having me, Mark.
So this was an amazing conversation about one of the elements of our next generation reaching out, seeing something that's coming at them, going into the future, and then finding ways to bring others, in this case, other pre-med and other students in college. But this way of thinking about getting organized and doing something is one of the characteristics of what seems to be building momentum in general around moving towards health equity. Accelerating towards health equity by design was the local theme here that we chose today, because we really did want to say that this is something that people make a decision to want to make something better, design a way to approach that, and take the steps necessary to bring the resources, the colleagues, the community together to do it. Our next and final panelist for the day, Abby Hauser, is one of those young leaders who's just been making a difference and bringing people together and getting the new energy around so many things that are happening in this world. She's been so active for a number of years around rare, or sometimes we call them rare diseases, but getting consciousness in the society about many of the challenges that people face and the ability of us to take active steps to address that. And she started out with a bachelor's in kinesiology and then a master's in biomechanics, and it just finished an assistive engineering certificate down in Chicago. Abby's a national speaker, but she's a local and activist in our larger community. And I'm just thrilled to have another one of our accelerators, another one of our next generation of health equity leaders. Abby, please join me on the screen. Welcome, and thank you for agreeing to be part of this World Health Day. And congratulations on that fabulous speech in Washington, D.C. That was the one opportunity I've had recently to see you. But could you share with the audience, young and old out there, your path to this new role, or not new, but this role of helping to bring new people and new awareness to the society?
Yeah, thank you for having me. I'm really excited to be here, and I've loved everything that I've heard today. It's been really exciting to hear. And for my journey specifically, I have a rare disease called classical Ehlers-Danlos syndrome, which is a connective tissue disorder, and it causes a whole host of symptoms and things. And I was lucky to be diagnosed really young. A lot of people with my condition and other rare diseases have something that we call the diagnostic odyssey, which can take upwards of 6 to 7 years to get a diagnosis. Many people, even with my condition, wait 15 to 20 years, even though it's a condition that you're born with. And I started having more issues as I ended my time at the University of Minnesota with my health and my body. And that's kind of when I wanted to make this more of a central part of my story. I wanted other people to understand what was going on. And I'm a writer by nature, and I felt I had a space and a voice that I could contribute to this. So I started a blog called Owning My Story, which is based off of a phrase that the author Brené Brown uses just about how when you own your story, you get to write the ending instead of letting it define who you are. And that really embodies what I wanted. And it just started as a personal project. Honestly, I just wanted something to share with others and for people that didn't know about my condition to understand how much it was impacting my life, even though it seemed like I had it kind of all together on the outside. And from there, I got into some state advocacy here in Minnesota. I helped with the Rare Disease Advisory Council bill that we got passed a couple years ago to give more rare disease issues a voice in government at the state level. And that somehow, after the pandemic started, I decided, I was like, why not? I did the state advocacy, why not go federal? I had time on my hands during the pandemic, so I joined with this group called the Every Life Foundation for Rare Diseases. And they have a wonderful young adult program called YAR, which is YARR. And they are empowering young advocates from, I think it's like 18, might be younger, up to 30 to have a voice at the federal policy level, especially with healthcare issues. So I got involved with them. I participated in a leadership academy through that program. And then through there, I was invited to speak and MC the Rare Voice Awards, which is this big award ceremony for rare disease stakeholders, policymakers, lawmakers, anyone that has anything to do with rare disease. It's a big award each year. And then I was accepted to their board of directors just recently. At 27 years old, I'm fulfilling their first ever young adult seat on the board. And I'm hoping to continue growing that and use my voice to show other organizations too that there are younger members that we could fill board seats with and that we're capable. And that's just sort of where that journey took me. It started from a personal project and just kind of grew from these amazing connections that I made with other older leaders that just kept believing in my voice, regardless of how old I was. And that's how I got
such a great story, and such congratulations on this board position. I didn't know that. But you were dressed to the nines at that big fancy awards in Washington. But what I realized was that in all aspects of health and health equity, and you were pointing out how little, that diagnostic odyssey is just it's a disparity, it's an inequity, but it takes organized action to do something. And you're pointing out at the state level, there's an important role. At the federal level, we see these. Now you are incorporating yourself into that sort of leadership and governance part. What advice do you have for young people watching, activists everywhere, that would give them maybe that getting over the first hurdle to jump in? And also any advice for that, I don't know if I want to join with those older people at that other level. You've done it. What advice do you have?
That's a great question. I tell advocates this that are kind of on the fence about getting in. We do these meetings with our federal lawmakers each year about bills that are important to us. And there's always young advocates. And I'm young, but I say younger, that are like 18 and younger than me at 27. That are kind of on the fence about, like, I don't know if I can meet with a lawmaker, like that seems intimidating, or I don't know that I have anything of value to add because I don't know the policy or I don't know how a bill becomes a law, or any of these things, these kind of barriers that we face in terms of accessing this advocacy. And the advice I always give is that there are other people that know these roles, that went to school and that did the things on how a bill becomes a law. The place that we have a voice is our stories and our experiences, and what we can use to tie those into policy or activism or other changes that you might be passionate about. And honestly, all it starts with is knowing your story and what you think you want people to know and what can be added to it. I think we tend to overlook the small personal details that can make a difference. We think that we need to have this big grand voice or this big effort contributing to advocacy. But if you just share a story with a lawmaker about your most challenging day, or even how hard it was for you to get out of bed with your condition or whatever it might be, those are the moments that stick with people. And those are the moments that keep driving people to make a change. And it doesn't have to be this grand scale where you're creating this nationwide movement. Sometimes it's those little things that make the biggest difference, and anyone has that capability. So I always recommend for younger people getting started or that feel they don't have a space, is that one, you always have a space. There's always space for you. And once you share the things that you care about and the voice that you want to contribute, the people that you're networking with and working with won't care how old you are. I have seen, especially, obviously I'm in the rare disease space, so I've seen our community just love the young voice. Like, it's well respected through pharmaceutical companies, through organizations, nonprofits, stakeholders. People making these decisions want to hear from young people. And sometimes these young people are parents of a child with a rare disease, and sometimes they're someone with a condition themselves, or with any healthcare inequity that you're seeing. There's a spot for your voice to stand out. And once you start sharing it, it doesn't matter. Like, the people that you're working with will not look down on your age. And I've never felt that anyone has been like, oh, you're too young. The only person that has ever felt like they were too young to be there is honestly yourself. And I feel that the most. I feel like I'm the only one that's like, oh man, I don't know if I belong here, when everyone else could care less how old I am. They just want the voice that I'm bringing to the table and are excited to hear it. And knowing that that exists out there, I think motivates advocates and reassures them more than anything else, and creates that better activism, just knowing that there are welcoming communities out there for you.
But that's a great line, that the only person who's questioning whether you're old enough or not is yourself. And I want to say, I affirm this at many different levels. But one of the things that you pointed out is that there are processes, and there are people who've been through the process. Maybe they studied it, maybe they just were that new person in the lobby group or in that. And I feel like one of the things that is special about Minnesota, and many things are special about other places and other states, but in terms of Minnesota, is that we do tend to have this notion about organized kindness, that kindness is a good thing, but you ought to kind of get it organized, and you ought to, have a group, a letterhead, and it seems like this serves us well, partly because it also gives a lot of places for joining, for intersecting. It must be a path. Let's say for you, it was, kind of particular, but it then opened you up to new relationships. You've met lawmakers. You can complain to them or suggest to them, depending on the time of the year or the day. But also, it must give you some sense of getting the opportunity to get to know other kinds of people and other people in the community, other neighbors. I mean, we live in a place, we have our bubbles and that sort of thing. Can you talk a little bit more about some of the benefits that have been in your life that were maybe unexpected when you were jumping in on advocacy about a particular thing, then other things might have come along for the right, or maybe even deeper?
Yeah, that's a great point. And I believe in the kindness of Minnesotans. Feel like it's ingrained in who I am as a person, and I know that a lot of that's just from where I was raised in this state. But I've noticed when I meet, lately we've been doing these virtual meetings with lawmakers, and we have a group of maybe 10 Minnesotans that are meeting either with our senators or with our federal representatives. And we come from all different areas of the state, and we've only been meeting in these virtual things kind of before and after these meetings. We're advocating for specific bills. Yet I've made friends with these people in these small moments because we just have that immediate bond that we've connected on, but that people are friendly enough about and supporting each other's voices. And we immediately, after each meeting, are like following each other on social media and are immediately sharing what everyone else is doing, because we're just excited about people passionate about what they're doing. And that's something that I was not expecting to find in this advocacy. I thought I just wanted my voice to be used for some sort of change. And for me, I found the avenue of public policy and federal and state laws and bills that we can pass to better the rare disease experience, or even just anyone with a chronic illness or disability. But I was not expecting the immediate connections and kindness that everyone shows. For me, I can't go to a meeting or webinar without someone saying, oh my gosh, you need to connect with so-and-so. And then they connect you, and that person connects you with someone else. And like everyone just wants you to succeed. And it's it feels very Minnesotan in how all these organizations work, and that we know that we're small. Rare disease affects a lot of people when you put them all together, but there's all these patient organizations that are kind of separate little islands, but everyone just wants to be connected. And that's something I wasn't expecting. And I've connected with people. I've written guest blog posts for people on website accessibility and how to make clinical trial materials accessible, and just things that I never would have imagined when I started, because I started just sharing my story by writing because I'm a writer and that felt comfortable for me. And I just wasn't expecting that now everywhere that I go in this community, someone wants to connect me with someone else, or wants to be connected with me because they value the insight that I might give someone else. And I think that's just really cool, and something I think is present in a lot of other health organizations and things. I can only speak to what I know, but I know that like the disability community in general, outside of rare disease, is equally accommodating and welcoming. Everyone just wants everyone else to succeed and commit to what they're doing, and are just excited about what's happening.
That's great. I mean, I was part of a group that was organizing a day-long symposium like today on International Day of Persons with Disabilities. And it was global, so it was kind of amazing. But it was that sense of just everybody wanting everybody to succeed. And sometimes, sometimes with great difficulty, depending on, how it all worked. But one thing that happened was that we were organizing that in Dubai as part of the World Expo. It was December 3rd, so that was there. That was going to be USA Week. Anyhow, one of the things that happened in that was that the people of Dubai and UAE, the country, United Arab Emirates, a few years ago said, we are changing our words. And in Dubai, these are our determined people. These are our people of determination. And, this is complex in two different languages, Arabic and English, but the explanation, and I ended up meeting one of the people in on that discussion where that change happened, just said that the head person said, people who we say have disabilities, actually their experience is they are the most determined people, and they're the people of determination, and that's the kind of language that we should be using here, and not language that talked about kind of a difference of a certain kind. And I was speaking to a friend of mine. I said, oh yeah, in Mexico in Spanish, we have this. And I'm just thinking, it's language like rare disease or disabilities. I mean, there are ways that your passion and then you seeing that passion in other people is a kind of determination to have your voice heard or to find a change, because sometimes the changes can be life-saving. I mean, this is, particularly this COVID era has really taught us a lot about how some things land differently depending on where you are. Have you chosen other places where your passion has been focused and you've been part of change making in related ways or in slightly different forms?
Yeah, I also, since my background is in exercise science, kinesiology and fitness and all sorts of things like that, I am equally passionate about, I guess, achieving some balance of inclusion in the health and wellness space for people with disabilities and chronic illnesses. It's a spot that many people are left behind, and I think we forget, even in terms of health equity, that we're telling people in the health space that exercise and fitness are important and vital to well-being and longevity and injury prevention, yet we just don't have the tools and the ability to provide equal care to a lot of disabled people and people with just chronic illnesses or any differences in the gym setting.
Right.
Because people assume that we belong in the medical setting. We get sort of relegated, like, oh, you should see a physical therapist instead of a personal trainer.
Not Lifetime Fitness.
Yeah, exactly. So there are times when a physical therapist is the right call, but there are many people with disabilities that do not need to be in a physical therapy setting for fitness. And like, if they're just going for fitness like anybody else, they're not overcoming an injury, they're not trying to gain a new skill or function. And we just, I know, I mean, I'm a personal trainer myself, and many people that I've worked with just are not comfortable when someone with a disability walks in or rolls in or comes in with any sort of aid, or uses a hearing aid or needs help with focusing on the volume of the music in the area or just adjusting to anything. And I think that's an avenue that we can continue pursuing for just continuing that health equity. I think it doesn't always have to be in the medical setting. It can be towards things that we're working on in terms of access and equality in fitness and sports. And I do a ton of adaptive sports myself, and I love all those programs. But there's also an equal spot for us to join a gym just like anybody else. Like, we don't have to go to a special.
And is there a point of pressure to improve that? Is it just having the example? Is it just what's your advocacy model for that?
Yeah, so for that, like, that's an area I'm still working on building myself. But when I worked in the gym setting, it was honestly just me being there and being, because I use forearm crutches in my day-to-day life. So just me being a visibly disabled personal trainer that was training what we in the community, or what I prefer calling just non-disabled people, showing them that that's equal and that trainers can look like any ability as well. You don't have to look like this super perfect body to be able to train anybody. And the reverse is true, is that I didn't need to be the only trainer that would train our disabled clients.
Right,
Like, it's
exactly.
not like if someone walked in that was deaf or hard of hearing, I didn't need to be the one that was immediately on the schedule. Like, anybody should have that skill and comfort level of just communicating with their client and getting that access. And many gyms on their own just have physical barriers of entry. They're not ADA compliant. There's just a ton of other issues of barrier to entry, but because of these issues, people just assume that a lot of disabled people don't go to the gym, or they don't work out, or they work out at home, or they're in the medical setting. And I think the way that we just continue building this is to have people that can show up, continue showing up and making that visible presence, but then also continue our education. I'm hoping to continue advocating with the personal trainer organizations to better their materials that they're presenting on training clients with disabilities, and just including better models. I've taken personal training continuing ed courses that didn't have closed captions, and I had to email them, and I'm like, I paid for this course. And I don't see closed captions, and it's not something that I needed, but it's something that we should all be advocating for the second we don't see them. And the responses I got were like, oh, that class doesn't have them, or like, we'll get you the printed transcript in like 3 to 6 weeks. Which is not the answer that we need. And that's another barrier. That's just another barrier to.
It's a great motivator for people like you.
Yeah. So it's just another thing.
Yeah.
Yeah. So I think there's a lot of ways that we can tackle it. We can tackle it from like the trainer, gym staff side, but then the physical universal design of getting better fitness models out there and just getting people more comfortable with disabled people existing in the world. And
yeah, it's kind of fundamental.
Yeah.
I mean, it's throughout the day at different moments, people have referenced different things about, the specific question of health equity, but somewhere underneath was always some other thing about people's assumptions about others or people's attitude. You know what I mean? You're raising it up. And I have to say, it's one of the things that maybe each generation of new leaders in the kind of advocacy world bring entirely new elements. And this particular moment where Crip Camp got nominated for the Academy Award last year, and then Coda won it this year. Well, something's going on. And there you are, you're in DC, sissing it out, and you know what I mean? So there is an element of, we could be overwhelmed if we just read the newspaper and read about, all the different wars and all the different health problems and all the different climate, you know what I mean? But there's another way, which is to hear your story and to hear the things that you're doing. And then also these other elements where you begin to see, oh, well, we can make change. And then, we have to get organized how we do it, is a very kind of hopeful thing. And I don't know if health is the only area, but for sure, feeling hopeful and feeling supportive really changes your odds on breast cancer treatment or whatever. I mean, there's a soul and spirit and emotion and mental health and all of these things wrapped together with physical and the other parts. And if nothing else, our ability to now understand this better doesn't necessarily make us make use of the knowledge, but we now have the knowledge. And your ability to see things with your eyes, therefore your experience, and then to feedback to whether it's the personal training, you know what I mean? There is a part about what you're doing that then is the model that says there's a reason why we say it's good to have diverse voices. There's a reason why we say we support democracy. It's not because everything's perfect. It's because we have the ability to communicate with each other. And that connecting point when you were lobbying, and the Zoom calls and talking to people, and then the reconnection, this is the experience of life that I consider the source of energy. I know there's introverts and extroverts and some people, but you know what I mean? That is energy that is as palpable as a solar cell or a wind turbine. And you've been one of the leaders in helping to kind of bring that to life. And I was in a way I'm not a big social media watcher. I mean, there's a lot, you can spend a lot of time each day, but occasionally I do find, and one of the gifts and treasures was seeing the picture of you in Washington and then learning a bit about your story. But most importantly, it's like being reminded that none of us knows exactly how many days we have here on this particular plane, but what we know is that we have things that we can do each and every day to make a difference. And for you, you've been making a difference for your whole life. But I mean, especially now, you've got an organized plan on how to make a difference. And that element, there's that medical center we call Sanford Health nowadays. I mean, it's 100 and some years old. But anyhow, when they were raising money to kind of build the first big kind of hospital that's of that system, they called it in their little booklet to raise money, an institution of organized kindness. And they put that on their sign, their kind of historical sign outside of one of their main first hospitals. And I've always thought, you know, that aspect, the way that you and others have recognized and implemented the notion of organized kindness, is one of the things that makes each and every day the opportunity to participate with others. Yes, there are things we do in our own life, showing up, being there, but there are things we do in our life with others that you represented, and I'm so grateful for you sharing your story today. Tomorrow morning, these young people that you're inspiring here are going to get up. What kind of words would you have to close out our day here on how they can keep the momentum and the excitement they've gotten from hearing your story and seeing your passion?
I think that as long as you, one, feel comfortable sharing some aspect of your story or whatever you're passionate about, that's gonna be the key, is one, finding that passion and committing to it, but then also connecting it to that personal. You don't have to always be sharing these hard facts, even if what you're advocating for or being an activist for are tough topics. You can always bring some of that personal in. People want that connection of why it matters to you and what that difference is. And once you feel comfortable with that, honestly, that is like a fuel from within, is that like I am motivated to share my story because I've had so many people reply to me on a social media post or a blog post and say, I thought I was the only one that experienced this. And just for me to be able to share something for my own personal benefit of getting it off my chest, but then to have someone feel like they're not alone in this, and that they're glad that someone is giving a voice to this because maybe they don't feel comfortable being an activist. That if sharing your story is something you're comfortable and confident with, let that fuel you. You let that personal aspect leak into what you're sharing. You can share those hard facts in the bills. I'll advocate for legislative policy, but I'm also going to bring in the personal with that same context. And that's how I think we're going to start creating this change, is bringing in our stories and our unique aspects to whatever we're passionate about, whatever it may be. And just let that one fuel you, because if you're not passionate, other people are going to tell. And then continuing to share and build that base. And don't be afraid to connect with people. I think if there's a speaker that you like today, you might have written down their name, find them on LinkedIn, find them on wherever, go connect with them, send them an email, send them a cold email and just say, hey, I loved what you said. And that can be it, but just start kind of building these connections and let people know if something that they said resonated with you. And that's just how you keep growing. And that's a hard thing for a young person, is to reach out to someone older than them. But it's worth it. And I think that's how we're going to move forward.
Well, I love this phrasing, and I'm going to use it on my loved ones, but the notion of the fuel from within. Thank you for giving all of us, and from me, giving me more fire and oxygen and warmth and that fuel from within. And I look forward to finding many different ways to continue connecting and finding ways to work and make this place so that it is normal. Yes, organized kindness is kind of a structure, but how we treat each other better and respectfully becomes what we do and who we are, even more and more, thanks to people like you telling your story and showing up and others responding. And what you just said about people today, don't be shy. You can find everybody who spoke on LinkedIn or at Global Minnesota, and you cannot imagine how important it is, the little bit of, yes, you made a difference in me, what that means to people. So thank you so much for being with us. Great to have this opportunity to share, and I look forward to seeing you again soon.
Thank you for
Bye.
having me.
Bye now. Wow. So finding these stories and this next generation, these accelerators, they're going to keep moving us on a path. They're going to help us accelerate that, move those new initiatives for health equity. And they have their own designs. Abby was amazing in talking about just the process that she's been through, but also the way she thinks about how we take this forward. And actually, this was kind of the purpose of today was not that we were going to figure all things out, but we were wanting to reach a very wide spectrum of success stories of people who were thinking about and designing and implementing changes that would move us in the direction of health equity, of reducing disparities, of addressing discrimination. And these different presentation days and panels brought those perspectives from all over, but they all had the elements of hopefulness and the notion that this particular period, for a variety of different reasons, but we know some of the big ones like COVID, is a time of some real opportunity, and almost everybody was making good use. We used to say sometimes making hay while the sun is shining. But it's a day that will be archived and available for a very long time. And I want to remind folks that it's just be up on YouTube under Global Minnesota. But there's a couple special things about that. There'll be some things up right away tomorrow, and then some that'll take a little bit longer. Professor Ahmed's presentation about robotics and AI and how that is transforming the ability to bring care to people all over the planet will be up by tomorrow. It came in the middle of the day, and the timing didn't work to get it crafted and then dropped in. So it's a very important part of our bigger picture. It'll be up tomorrow. Also, Andrés's amazing presentation about his work on the National Disability Council will also be up. And then all of these presentations will be eventually up, in individual format. Teachers use these, folks at Rotary clubs, that kind of thing. But we want to urge you to make use of that archive, and also previous years. Archives are all up there as well. Last year, we had a broad focus, but we knew this year we wanted to really hone in on health equity. And we wanted to look at where we were going, and we could see that those initiatives that were designed to achieve greater health equity, designed to reduce disparities, were going to be the most important. But it turned out that was a very, very fortuitous decision, because much of the world has been moving in this direction, and we were able to highlight that and to provide some special opportunities to think into that future in that hopeful way. There were folks who were critical to making today happen. Our amazing American Sign Language interpreters, Don and Amy, you see them on the screen. What a day. Thank you, thank you, thank you. Carolina Gustafson, who manages all of our events, and Olaf, and there's a whole team with Olaf Krohn, but there's a company that we work with, In-House Media, help bring all the pieces together. Tim Odegaard, our program director, who's responsible kind of overall, and Alex Albright, who ran the green room, lots of people in the team at Global Minnesota. And of course, our entire board, who've been super supportive in keeping Global Minnesota strong and moving ahead during the COVID period, when we're still in the COVID period, but when it looked very shaky and no one knew exactly what was going to happen, our board has been there saying, we've got your back, keep going, keep using the new technology, keep moving ahead. Today we had special support for this seminar, King Solution as our platinum sponsor, and Communicating for Agriculture Foundation as our gold sponsor, and Sunrise Bank as our silver sponsor. We also have sponsors in the larger sense of the organization during the course of the year. Our global platinum members, Carlson Family Foundation and Delta, Premier, Cargill, GHR Foundation, and UnitedHealth Group. And then for all of you out there who are our individual members, your contributions each year, your membership and participation in our gala and in our other events in our organizations make all the difference in the world. Your support makes it possible for us to do this and to provide it free worldwide. So thank you again. Coming up, just so that you know, Dr. Mandela will be part of a panel at the Humphrey School, Human Rights Activists on the Front Line of Conflict, April 13th, 1:30. So at the Humphrey School at the University of Minnesota. Global Minnesota and others are co-sponsoring that, but that'll be a very important in-person event with a live stream. Global Minnesota's former board chair had been tapped to come out of retirement, and he served as the acting charge d'affaires. So he was the acting ambassador, so to speak, in Kabul and Afghanistan the last 2 years. And his spouse, Margot Squire, who was also a Foreign Service officer, was the head of cultural affairs during this last period. And they're going to be talking about their service in Afghanistan on April 13th, 6:00 p.m. That's a virtual. You can get that information on the Global Minnesota website. International Women of Courage Virtual Roundtable. The State Department every year names about, I think, less than a dozen women from around the planet who've risked their lives in defense of human rights. And they are named International Women of Courage. They're brought normally to the US. Normally they would come here. We've been really blessed to be asked to host 2 of them. And there'll be a roundtable on April 15th at 11 a.m. You can get all of those under the Global Minnesota website, of course, under events. And we're looking forward to our annual gala. So there's lots of information there on that website. Please check that out. You won't want to miss that. And you want to be part of a fun event, but also really be thinking about how the next period, these lessons, these hopeful words, these inspiring ideas that we've heard today can help give you the kind of motivation, the kind of assistance or support. And Global Minnesota will keep doing events, webinars, visits, exchanges, all these things to help us keep on connecting Minnesotans to the world and that world to Minnesota. And thanking Abby again. I'm hoping this whole day provided that fuel on the inside that get us up tomorrow and get us on to making the world a better place by accelerating health equity by design. Thank you again for being here for World Health Day 2022, and we look forward to seeing you at our next event. Goodbye now.